Thanks. How many people rotated with Dr. David Kaufman back in the day? I'm a roamer like he is too, so I'll try to stay still if I can. We're going to start this lecture. Thanks for Maya asking me to do this. There'll be 32 years in practice this year, and historically go way back with the college. Dr. Dubin at one point had this administrative arm that he not only took care of the college part, he also took care of the Board of Examiners part. And early on, as I came through the whole field, my dad was on Board of Examiners for a long time, and he kind of finally brought me into the fold, and probably for about 12 plus years I was on the board, and Dr. Dubin was a big factor in that. So it's been a pleasure to be asked to give this presentation. There's going to be a little bit of history in this, not only history of the college maybe, but even history in some of the research that we're doing with PDIG, and then some of the interesting new things that are coming out regarding how to treat amblyopia, because that's always been the bane of our existence in trying to treat that. So we'll start with, I have no financial disclosures. Now, just a little bit about myself. My dad was a general ophthalmologist for many years. There were 4 boys in the family, and 3 of us ended up going into ophthalmology. So I guess I was the black sheep in deciding to do peds. I did my medical school at Kirksville. I then did my rotating internship, back then it was at Metro Health Center in Erie. Did a year of family practice because I didn't get in first year, and then I ended up doing my residency in Flint when it was Flint Osteopathic. That became Genesis at one point. And then from there, I was able to get a fellowship at Children's in Detroit. And it was interesting, that was the very first fellowship that they started. So I was their very first fellow. So it was kind of like a learning curve for both of us. What I found very interesting in that fellowship at the time, because it was early, it was a really hands-on fellowship. Some of these fellowships that they have now there's a little bit of an academic twist to it where, you're doing your clinic stuff, but then you're also kind of expected to do this academic stuff that might take you away from the clinic a little bit. So it was a very hands-on fellowship. And Dr. Baker was my mentor, and I still have a really good relationship with him. And that was, like I said, about 32 years ago. I ended up back in Erie because they didn't have any pediatric ophthalmologists there, so I figured that was a good place to start. My dad was a big member of the college at the time, then he became a Board of Examiners, and I remember being in high school in our house on a bookshelf. There were all these books of photos, and every once in a while I'd grab them, look at them, and there are all these pictures of these eyes. And it turns out that was my first experience with becoming on the Board of Examiners, because those were the quiz questions for the oral boards that he had. So I've been involved with the college even before I even was in school. So anyway, so that's that. Now, start practice. You're plugging along. You're trying to figure out how to kind of make a name and do things. And I started in around '92, and around 1996. This PDIG thing started kind of coming out. The PDIG stands for the Pediatric Eye Disease Investigator Group. And it started with Jonathan Holmes, who I'll introduce in just a second. And he started it, he was at Mayo, he was a pediatric ophthalmologist. He wanted to do a prospective study on 6 nerve palsies and just kind of gather data. And I thought, what kind of research can you do in a private practice? I mean, it's just not you can't do bench research very effectively, obviously. So I thought, well, this is more clinical. I mean, I can find maybe a dozen people, half a dozen patients that I can share. And then that was kind of my first introduction into PDIG. And then as the organization kind of then developed, it was started by Roy Beck, a neuro-ophthalmologist. I think he was up in the Michigan area. Mike Repka, who's I think going to be the new American Academy of Ophthalmology president next year, I believe. And Jonathan Holmes from Mayo. And it was this collaboration to come together. Can we think of things that we want to talk about and try to find answers for in such a way that if we can have multiple people doing it all the same, we can really get big numbers of people for things. And that was kind of the beginning, and it started in 1997. The first couple studies were the congenital esotropia observational study and one of the first amblyopia treatment studies that I'll talk about in a minute. Real quick with CEOS, it was interesting because at the time there was a particular pediatric ophthalmologist that thought, darn it, that 3-month-old has this gigantic ET. I want to do surgery now, because if I can do surgery now, I can get binocular vision out of this kid, because it's happened to me one time before, anecdotally. And it was actually his son. I won't tell who the doctor was. And we were all going, well, that's fine and good, but is that really a smart thing to do? So the CEOS did that. We looked at kids for that first year of life, and what was their angle, and what did their angle do by the time they turned 1. I remember one of the kids I had in that study, looked like a big congenital ET, really is non-accommodative component, and she went from like a 45 prism diopter ET, by the time she was a year of age, a smaller angle intermittent ET, and I thought, well, if I would have done surgery early on, I would have made her a consecutive exo. So that was kind of the beginning of all this. And then we moved into the amblyopia treatment study, but we're NEI funded, and we've been funded now for many years. We have conducted 57 studies. We have about 4 or 5 current studies going right now. And over the years, about 140 manuscripts have come out from all these different studies. Right now, there are 117 sites in the organization, 27 community sites. So there's a lot of academic sites in there with multiple ophthalmologists at their sites, but there's a lot of private. There's 27 private practices, 446 investigators, and then all the other staff. We actually have some sites in Canada too. We are pediatric ophthalmologists and also pediatric optometrists, usually at the academic centers. From 97 to 23, now we have this many, 52 studies that we have completed. We have about 4 or 5 current. I think I might have to change that number, but then we have about 3 upcoming. 24 amblyopia studies that we've done over the years, 10 strabismus, about 3 nasolacrimal duct. Refractive error, that's mainly, there's a myopia one, but then we kind of just looked at prescriptions in kids. We did like a hyperopia study at one time in young kids, who to correct and who not to correct. ROP is one that's going on currently, and I'll talk about that in a minute. A cataract perspective, kind of looking at a bunch of eyes and what did all these kids do. There was an optic neuritis study and a corneal thickness study that we did because we didn't have any data on kids' thickness of their cornea, but we only had the adults. And then Chalazion study, and we got another Chalazion study coming. So I'm going to kind of pick and choose some of the things that I kind of found interesting in all these studies that we did. And I might digress now and then as I'm kind of giving you this data and kind of saying what I found out clinically as opposed to what maybe even happened in these studies. But ATS1, so think about when I started practice. We had an amblyope come in. What did you do? Full-time patching most of the time. Full-time. Okay? And that went on for quite a while. And then people are talking about atropine. I'm thinking, me personally, that person, that kid, when they still looking far away through their appropriate prescription that's atropinized, they still see clearly. So how are we really doing anything? And are we really switching fixation and forcing them to use their amblyopic eye? So I wasn't a real big atropine believer early on because I just didn't think, I couldn't understand how that was effective. ATS1 kind of put that to sleep. Okay, so 419 kids enrolled in this particular study. We recruited 31, actually. So it's one thing to read the results of a study and go, okay, this seems like this is right. And then it's another thing to do it and live it and see these kids get better. And then when you see this, you go, yeah, that's real because I experienced it. So basically, for about 6 months, the kids were randomized to either 6 hours of patching or atropine. Okay. And what they kind of found out early in the study was that at about the 3-month point, the patching kids were doing better. But then when they hit the 6-month primary outcome, both kids did equally. They had equal improvement at that point. And that kind of all of a sudden changed my whole mindset. So I think what's really nice with these studies is does it change your clinical practice? And if they do, then I think that study had some effectiveness. That was ATS1. That was our very first one. Now, we're going to talk about ATS2C. That was where when you stop patching, who recurred. And it turned out that it turned out that, I don't have, 25% of kids seem to recur when you stop the patching. And it turned out that it looked like the majority of those kids that recurred because they were stopped cold turkey. If you weaned the patching, they didn't tend to recur as frequently. So again, just change your practice. I jokingly tell the parents that when I'm stopping patching, I'm a weaner. And that's because I do think that patching them a little bit longer is probably helpful, at least maintaining your improved vision. ATS-3. ATS-3 looked at treating older kids. So this one looked at 7 to 17 years old. So it turned out that in the 7 to 12-year-old group, these kids were kind of treated a little bit differently. Observation versus patching, atropine, and near activities. And about 53% improvement in this older cohort when they were treated like that. But 25% improved just with glasses alone. So other things that we've seen over all these studies is that glasses alone in treating amblyopia do have some effect. I'm going to talk about another study in a minute where it was amazing some of the improvement that kids got just with glasses alone over the about year that they were followed. The older kids were a little bit more problematic, but if an older kid presented that had never been treated, there did seem to be improvement in visual acuity compared to the older kids that had treatment when they were younger. So I think that kind of shows that if they've had a lot of treatment and they come to you older, that maybe you're not going to see the benefit. But my experience has always been, I approach older kids and I want to give them a shot. I've had a handful of kids come in, 7 or 8, pretty bad amblyopia from anisometropia typically, seen by an optometrist who said, nothing you can do. And you do it, and they get better. And I think you always have to have the family feel that you've done something for them. So don't consider treating older kids. I had an Amish girl who was 16 when she presented first time, about 6 diopters of anisometropia, 2160 vision. Back when I was patching a lot, she was a 6-hour patcher back in the old, before all this. She improved about 20/30 at 16. So I think you got to try. And that was a good family because it was an Amish family and they were going to do what you expected them to do. So, because that might not have otherwise happened. Okay. ATS-5. This was the one where kids were initially screened. We observed them for a period of time in their glasses. And when we saw that they did not improve in their glasses alone, at that point, they were enrolled to either patching or continued observation. And it was amazing that 25% of these kids improved significantly in vision alone, just wearing their anisometropic glasses alone. And I have a little side note that I had a kid come in that was 23/20 in her amblyopic eye that got in the control group, observation only, and this kid improved to 20/25 minus with no patching at all. So I think it does show, and that changed my practice pattern because when a person came in with amblyopia, glasses, and patching right off the bat. So it changed my practice pattern into, let's just get them in the glasses, let's see what you're like in 3 months, and at that point we can make a decision how we want to kind of continue our treatment. Oop, hit the wrong button. ATS-17, this was one of our more interesting studies because there was some literature that showed that levodopa somehow might kind of kickstart the visual cortex and maybe enhance our patching. There were some kind of little studies out there that showed that. So this was one of our more interesting studies because all of our studies were really treatment versus treatment of some sort. This was like, okay, we're going to give your kids levodopa or placebo. And there was a history with levodopa in kids, I guess, for some seizure things. So it wasn't like it never been used. But basically, we went through this study, and we found that levodopa didn't have any effect. So, but they're always looking at ways to try to improve vision. Now, we did a couple nasolacrimal duct studies, okay? The one I found to be the most interesting that we participated in, well, we participated in all of them, but this one was more, I'm an office prober. Who P's guys in here do office probes? Okay. Usually we're about maybe a quarter or a third of all the pediatric ophthalmologists, and it really is because of where we trained. If we trained at a place that did them, you're comfortable doing them. Anyone can do them, but we're comfortable. And the advantage of doing that is not having to go to the hospital and put them under general anesthesia, which families find extremely, extremely valuable. So this study kind of looked at what happens if we probe them early in the office, or we wait until they get to about a year, and then if they haven't cleared, they're probed at an ASC. Okay. And my feeling has always been is obviously you're saving everyone a ton of money, even insurance companies. I've been able to negotiate a higher probe fee because I'm saving them anesthesia and facility charges. And this basically showed, not really definitively, but there was a potential cost saving was the main driver of the study, and that I think clinically, I never would probe a 6-month-old or a 7-month-old. I usually will sit on them until they're about 10, 11, 12 months of age, because it gives them a chance that if I do find those kids that kind of clear before that time that we go to the hospital, that I find them. I've probed a 15-month-old in the office before. It was an ENT resident's son at the time. He didn't want to put the kid under general, and that was my oldest kid. And then just recently, I did an 18-month-old because the mother was an anesthesiologist who did not want to put her kid under general anesthesia. And I told her, I said, it's doable, but I'm afraid at that point they might remember a negative experience. They just might remember that negative experience. So, and I guess we dodged a bullet on that 18-month-old, but that's a little bit out of my comfort zone for that reason. So, but I don't know, if you can always convince a pediatric person to do office probes, it's a huge thing, it really is. And think about it, yeah, I'm done in 5 minutes. They're in and out of the office in 15 minutes, you know, between turnover time in the OR. I mean, how much time you're spending there. So that was nasolacrimal duct obstruction 3 study. All right, now some ROP stuff. You probably know that Avastin is now being used for some ROP treatment when people meet threshold, okay? So the first couple studies that they did was to kind of look, number one was effective, but number two is what dose do we really want to use? I'm not involved in any of these ROP studies because I just don't see enough ROP, but they finally, with some of these de-escalation studies, found that you could go down, so they started with 0.625 milligram, which I think was believed was half the adult dose, but they did a de-escalation study and they found that you could go down to 0.004 milligrams and still have an effective response to it. And they kind of did this with the idea that they eventually, which they're doing now, is Avastin versus laser study. And that's kind of what they find. They wanted to find out what was that dose we could use when we do these study, you know, kind of treatment versus treatment study. And that's actively going right now. My experience with the Avastin versus the laser has such a good track record. It's predictable. You know more often than not how they're going to respond. But I think those Avastin kids that it's just like they're kind of, it's sort of, you don't know how quickly they're going to recur, and you have to watch them a lot more closer. Who's doing Avastin? You doing Avastin? No. Pete's got, okay, so has that been your kind of experience?
I've done mostly injections. I rarely do a laser. And my experience with injections is that they do very well long term. You get the occasional recurrence after retreat. Sometimes in treatments, I may do a laser as opposed to an Avastin. But I don't retreat very often. I have very good results with injections.
So we'll see what the study goes. And going back to just ROP in general, I remember, you know, early on when I'd be seeing these kids, I don't treat anymore, I just screen where I'm at. But I remember back in the day when, you know, you had to say, is this 5 clock hours of continuous stage 3 or 8 discontinuous and with plus disease, and you're kind of like agonizing, am I calculating this correctly? And I do think back in the older days, I think treatment kind of probably happened a little bit later than it probably could have, because you're agonizing on what to do. Then they did stop ROP, which basically said if you see plus disease, it's treatable. And I think that really kind of helped in making a decision when to treat. And so I think people were being treated a little bit more on the earlier side, which I think they responded a lot better. And I'm from the era where I saw kids that had cryo for their ROP, which freezing that eye, that's great. All right, this was our cataract kind of study where we basically just gathered data from everyone that had done cataract surgery. There were there was about 1,266 eyes from 994 children, and basically they wanted to know all the information that we had on these kids, and they just gathered the data. And some of the highlights, we recruited 10 patients, but the highlights were that by 2 years of age, almost everyone had an implant put in. And I thought was interesting too, as I look back at this, is that 50% of the eyes were within 1 diopter of the target refraction at their first post-op refraction. When I'm doing a unilateral cataract, I always try to mimic what the other eye is, the sound eye is, or maybe fudge a little bit more hyperopic, because sometimes these kids can go woo, real myopic on you, and you don't understand why. You have this group of kids that will do that. But this is ongoing, and they continue to look at the data, and they'll come up with little presentations now and then as the data goes on and the time goes on. Some strabismus studies that we did. We did an adult strabismus study with small angle verticals, but we've done a lot of IXT surgery, or a lot of IXT studies. IXT1 was our first exotropia study, and it looked at unilateral recess resect for basic type versus LR recession OU for basic type intermittent exotropia. We recruited 17 patients. So basically, when a person was ready to enroll, they were randomized to either LR recession OU or R&R. When we hit the 3-year primary outcome, it did not look like there was much of a difference between the two, because there's always this belief, if you're crossing more at near, or you're crossing the same at near, a lot of people thought that maybe an R&R was better, and I kind of sometimes was in that camp, but I really don't like doing resections if I can help it. So I try to avoid it if I can. But this said, oh yeah, there's really no difference. Okay, so then you go back to your LR recessions. Well, they did an extension study with a lot of these kids. So when they hit that 3-year outcome, they then extended for almost 5 years whatever kids were willing to continue on, and then we ended up having 9 in that of our 17. And as that extension study finally just recently finished, we found that when you looked farther out, the recess resect kids maybe did a little bit better. What's hard is we had a lot of, when you try to follow a study for 5 years, you get a lot of dropout. But that was a little bit of a potential problem with this. But it started to show that maybe the recess resect farther out actually ended up doing a little bit better, because they seemed like the LR recession groups kind of failed. They kind of fell off. And now the talk might be is that maybe we need to do a little bit more of an LR recession at that first setting, because we use kind of the standard numbers from the basic science as our decision of how to base our surgery. So there's more to that. There was IXT2. It was basically anti-suppression therapy, alternate occlusion, and basically we found in these kids 12 to 35 that it really didn't seem to make a difference after 6 months, whether we alternately patched them early or not. I tend to wait until maybe they're starting to become a little bit, they lose their control. Maybe they start to seem like they're drifting more like 40% of the time, if we can determine that. And I always do it as a conservative way to kind of give the family some feeling that I'm not ready to jump into surgery. I don't know that it works as well in the older kids. I think it's probably better, a little bit better in the younger kids. And then there were some subsequent IXT studies where they looked at over-minus. I'm not a big over-minus person. I just philosophically have a little bit of a problem giving a kid a wrong pair of glasses to try to treat a condition. They did 2 over-minus treatments, and even the one where they over-minus by minus 250, I think they kind of even slowed the study down, because I think they were getting myopic progression in some of these kids. So, and now they have the one that's out now that I didn't participate in is full-time patching in these IXT kids to see if that improves their control. It's like, I couldn't see myself recommending that. The people that are doing it, they say that the families are so much against surgery that they'll try that, but I don't think I saw that in my practice. And that's the nice thing about the PDIG, is that they present an idea, and they have a bunch of people that decide this is something I think is worth participating in or not. All right, everyone knows about myopia progression. Okay, that's the big hot thing right now. We know about MySight. We know about the atropine stuff that's come out of Asia. But all that Asian literature, does it really apply to Caucasians or non-Asian people? They did a initial myopia control study. I did not participate because I did not have some of the equipment at that time. I have it now because I've done some side research with pharma, doing some myopia stuff with low-dose atropine. But basically, to summarize, this is actually just came out. We found in their cohort that the 0.01% eye drops did not show or slow myopia progression over the 2 years of treatment in children 5 to 12 with moderate myopia. So they're thinking that, do we need to maybe rethink what dose to use, different objective measurements of treatment adherence. The little bit of a problem with the study in terms of the limitation is that they lack an objective measure of eye drop use. So I guess they were finding that eye drop compliance maybe didn't necessarily comply to what was left in the ampules when they got them back. So maybe there was an overestimate of usage and they really weren't using it. And then the other problem was COVID. So COVID really, we had another IXT study that we were using some prisms, and we had to shut down that one because that was boom right in the middle of COVID. We can do any follow-up with these kids. So I think there's so much more out there with myopia treatment. We offer low-dose atropine if families want to do it. We are in at least a trial. I have a lens company called Hoya that's going to do. They want to do a decentered spectacle, defocus spectacle study. So instead of my sight being the contacts that are defocusing, glasses will do that. And they're still in the kind of development phase of that. We might be part of that. And it'll be interesting. That might be an easy study to sell because there's the kids in glasses, no matter what. Trying to put a 7-year-old in a MiSight contact isn't the easiest thing to do in the world. All right, so what are we doing currently? We have ATS 22. It's our randomized controlled trial to evaluate sequential versus simultaneous spectacles with patching. Basically, when you get enrolled, you're either in observation or 2 hours of patching. The observation groups always have the outs if they're not getting better. But what's interesting about the patching group is the patch that we use has a thermal sensor. So we're going to hopefully be able to tell how compliant the patients are actually with the patch, because that's always been the thing that, do we really believe them? When I treat with atropine daily and the kids come in and they got equal pupils and the family said I used the drops today, that's a nice compliance measure. But the patching is, we have no compliance measure. So that'll be interesting. This is still an ongoing study, so there's nothing we got there. ROP4, as we already talked about, it's avastin versus laser. IXT7, I already talked about, it's the full-time patching. And we just closed XO6, and that's another thing that's nice about the group, is they developed a iPhone app to check vision at home. So what we did in the study was we would check vision in the office. We would show the family how to check it on the phone. They would do it a couple times on the phone over the 3-month period, like about a week in, and then right before they would come back, and then we would check vision, and then we would compare what they were getting to what we were getting. And I think already preliminary, we're finding that it wasn't very accurate. And if you think about all those phone apps and all the things out there that they're doing, I don't know how rigorous they were at looking at, how effective that app is in reality compared to like what we do. So I think this was good because it shows that sometimes things fail, and you have to show that they fail. So they're going to reevaluate the app and maybe make a change. Now, what's coming up? 2 new amblyopia studies. We're going to be talking about some of the dichoptic treatments that are kind of out there. ATS 23 is going to look at luminopia versus patching, kids 4 to 7. ATS 24 is going to look at an older group, 8 to 12, and it's going to be a 3-arm study. Patching versus luminopia versus vivid vision. Vivid vision, I don't have any information on that, but it's kind of like a virtual thing, and they're kind of playing like video games. And we're going to talk about dichoptic treatment. Basically, we're giving more stimulation to the amblyopic eye. So we're going to be able to at least check these 2 kind of new other dichoptic treatments. Luminopia and Curasight are FDA approved. I'm not sure about the vivid vision yet. And then ETS3 is another one. It's an esotropia treatment study. Basically, I use the word controversy in our field. It's like, what do you do with that kid that's pretty straight at distance, but man, it's got this gigantic ET at near? And, a lot of people will, give them the bifocal, even if it doesn't work. I always see if the bifocal works before I give it, but there's like this big group of people that say, boy, even if they're straight in the bifocal, I don't think that's treatment. And there's a lot of us that think it's treatment. So I think we're hopefully going to put that baby to bed with this study to see if it really has any benefit. I mean, I can't understand why, if you can get a stereo out of kid at near with a bifocal, why wouldn't you want to do it? But there's a lot of people out there that don't. So, and even in Europe, I mean, they do surgery for high ACA like that, which, man, you're straight at distance. I don't know why you would, but. All right, what is dichoptic treatment? Okay, so PDIG did have some early things in this. We did the first one was actually, we called it the Tetris game, but we weren't allowed to call it Tetris because it wasn't Tetris. So we had to call it falling blocks, but we still called it Tetris. So basically when the kids would wear their anaglyph glasses, the game would drop the things and your sound eye got less contrast. Your amblyopic eye got more contrast. You're not going to see it with those glasses on this one. Okay, sorry. But it showed to be maybe have some stuff, but it was boring. It was boring. These kids were going to play this game for 60 minutes. It was boring. So it didn't really, other than the fact that it shows promise, it just didn't go anywhere. So they tried to get a little bit more active, and they came up with Dig Rush. So in this game, this little thing is running around picking up gold nuggets, and so the sound eye had was seeing the blue thing with less contrast, and the amblyopic eye was seeing the red, whatever it was, go around picking up the things. They played that. What was interesting in this study is, I got the results right here. 182 kids played from 4 to 7, randomized over 36 months across 52 sites. We had 92 in binocular treatment and just 90 with just continued glasses. We met our recruitment goal, and basically we found that at 4 weeks, a little bit of improvement in the amblyopic group, but by 8 weeks, there was no difference between each group. So, and then I think what we found is, families said, oh, we did it this much, but the machine kept track, and it was like nowhere near what they said that they felt that they were doing. So again, I think it was a boring game. Again, trying to get a kid to play a game. And I think that's the other thing they found is when you got better in the game, the contrast switched. So if they would have played it more, maybe they would have got more treatment, but it never really seemed to get that far. All right, so what's the future of amblyopia treatment? What we're showing up there are two of the things that are out there right now. They're both FDA approved. CureSight is the device, like with the anaglyph glasses, and Luminopia is the headset that the one child's watching. Our office was involved in some of the preliminary studies as they were trying to get FDA approval with both CureSight and Luminopia. So we have experience kind of with both, and we'll talk about why we'd pick one over the other under certain circumstances. But let's start with CureSight. So CureSight is a company from Israel called Novasight, and it's interesting in their technology that, well, let me talk about this first, because this is why these dichoptic treatments are helpful. Okay, so we know that even after ATS-B that showed 2 hours of patching, I didn't mention that one, remember when I said be full-time patched? We got to that point where we did a study, 2 versus 6, 6 versus 12 in bad amblyopes. The 2 group did just as good, the 6 did just as good, and eventually 2 does as good in everywhere, and that was huge. That was huge in trying to treat amblyopia. And compliance is a problem. I'll throw out 2 little gems that I do. I tell the family, that you're going to get 2 hours a day. Don't wait till they're home from school. You'll never have enough time to do it. I do morning patching, so they wake up in the morning, patch until they leave to school. They're doing non-important things, getting dressed, eating breakfast. Maybe you'll get 45 minutes of patching out of them, and then you just have to worry about the rest of and car patching. Anytime you're in a car driving somewhere, throw a patch on. They're just looking out the window, but you're getting treatment. I said you can knock off a lot of patching that way. We know about pharmacologic penalization, but school issues. When I'm treating someone in school, I might do cyclomidril after school, and then twice a day on weekends, so they're not necessarily because the drops wore off before the next day. We know compliance has the psychosocial effects, and the long-term consequence of noncompliance is that we have residual amblyopia and then permanent visual reduction for the rest of their life. And I will say, I've never saw a compliant patient that didn't improve. So compliance really is the key to all these kids. All right, okay, get our glasses on. If I have to back them up. Now go back and forth between your eyes too while you're looking, because you'll find the red eye, you'll see this blur spot in the center. And the blue eye, if you do the blue eye, that would be this amblyopic eye getting more contrast, getting to full contrast. Okay, let me go to the next slide. There'll be more here. I have to start it. This device has an eye tracking, so wherever you're looking at the screen, it's going to follow you and put that central blur spot, so to speak, wherever you're looking. And the device knows when you're not looking at it, too, and walking away, so it's monitoring your compliance also. It should be, it'll go over that would go over the sound eye, yes. So when the glasses are sent to the person, they give them the right appropriate glasses for which eye needs gets the stimulation, which one doesn't. What was that? It really can be anything, really. Yeah, I don't know that they really put our limit to us, from my recollection. Okay, so let's go to the next one here. Sorry about that. Okay, now what's advantageous about this device is anything you can stream over the internet, it will do this. Okay. Now luminopia will have some limitations because they limit the digital information, but and I'll present one kid that they can watch YouTube videos. They can watch anything they want. Okay, so the only thing you need is be able to get internet. Okay. And, okay, so compliance is key, innovative amblyopia intervention. It does integrate, I think, day-to-day life, since many children are going to have a certain amount of screen time anyway. There's good compliance monitoring by the device, so we kind of know. Fun and engaging content, because it's anything. And there are some early studies that do show that there is clinical improvement. I think I got there. These two devices have interesting ways that you implement it. So in the office, when you're ready to think to enroll someone, you make that determination, because they'll want to know the stereo, they'll want to know your acuity and things like that. And basically, you call up the monitoring center, and they then take all the information, and then they go from there and contacting the family, getting any insurance information, and then figuring out how to get the device to them. And then the device is sent to them. And then as I do my follow-up, whether it's in the office, I can even, at some point in between, I can get into the portal, and I can actually kind of follow what kind of compliance they're doing. Do they need a phone call to say, hey, what's going on here, or not? And they do have a code, 0706T, which still isn't getting paid, but that is a code to show that you did some kind of interaction with the family. I think they're starting to work on trying to get insurance companies to understand that, but it's just another thing that's out there. A lot of times we still have them come back for the 3-month follow-up. And that's just the monitoring center. And we'll talk at the very end, because I think there's limitations with both right now because of insurance coverage, but it's like anything that's new, there always is. This is an example of what the portal might look like, showing the compliance in a particular kid. And I'll just kind of present two kids that I had. CK, early entry amblyopic eye vision of 20/40. We recommended 90 minutes, 5 days a week. 55 days into treatment, we only found 21.5% compliance. And it looked good for the first week, but then stopped. And I talked, and the kid just wouldn't sit still. Kid just wouldn't sit still. So we went back to atrial penalization. Now, patient 2 was different. He had an entry amblyopic vision of 20/70, poor patching compliance. We recommended the normal treatment. Into treatment, 169.1% compliance, so he was watching it more than he needed to. Mom had indicated that the monitoring center had prompted to get closer to 90, and which she was able to do, and that the issue with him was that he did come back. I had him come back for a follow-up early just because I had to present this somewhere else. And he already showed improvement to 20/50 within about a 6-week period. But he did not have to compete with the other family members, his brothers, for screen time. So he had this thing all to himself. So he was really into it. Okay, if you guys wanted to get that QR at all, I can always come back to them later too if you needed it. So that's Novocyte's thing. Novocyte too, it's my understanding, they're working on some sort of device that is going to hopefully do something for myopia progression too. So I'm not even sure what that's going to look like when it comes. I'm hoping to be part of that when that comes. Luminopia is the other. Oh, good, we're doing good on time. Is the other treatment option. Luminopia, when it first came out, was a headset. So this Scott, I don't know how to pronounce his last name. How do you pronounce Scott's last name? Zhao? You don't even know. Okay. So he was at like Boston College, and him and his roommate had amblyopia, and this kid just said, I wonder what we can do to treat it. And he came up with this idea on his own. It's like unbelievable. So basically, it started off as when we were in the study. There was a headset, but then there was a phone or a smartphone that would kind of click in. I described this to the family. It's a little different in that you're watching a full video, but I describe it as the unit kind of breaks it up into a puzzle. So one eye is seeing part of the puzzle. The amblyopic eye is seeing more of the puzzle with more contrast, and the sound eye is seeing the bits of the puzzle that's missing under less contrast. So when you're using both eyes, you're seeing the whole image, but that's how it's kind of done. And the best I can do, I don't have any active video, but the screenshot kind of shows you like what the amblyopic eye is kind of seeing in contrast to the other. The scrolling thing down at the bottom basically is when you're looking at it, you fixate your eye to whatever information you want, whatever show you want to watch. And it's got, I don't know if I have, something happened to my screen up here. How can I forward that if I can't forward it here? So they have like Nickelodeon. I mean, they have, I think they might have some Pixar, but they're always trying to get more content. So maybe in the future, I didn't do anything. We're getting close anyway. I can ad lib if I have to. I won't take it personal. So Luminopia then, it's got a little bit limited digital media, but I think they're trying to get more and more content. You got to wear a headset. So I mean, if you got a smaller kid with a smaller PD, it might be harder for them to wear it. It's usually 60 minutes of time, about 5 days a week. They have an interesting way that you prescribe it. They actually have made it looks like a pharmacy. So even through my EMR, if we're going to prescribe it, I can pull it in my EMR. I press that button, and it sends all the data to them. And then they do the same kind of thing. They contact the family, they get all the information, and then the device is sent to them. And then when it's all done, the devices are actually sent back. I think the pluses and minuses with these two new devices are going to be patient selection. And if there's a way that you can kind of figure out what's going to better work with the kid, it's probably going to be better to go one direction versus the other if you have to. And it might just be a lot of questioning of the families, asking more history about what they do, what they like, and then maybe we'll find that one is better than the other. Did that QR code thing throw me off? Or?
I don't know why the computer's off.
So Scott had some other stuff about, I think they have about 3,000 patients being actively treated now across the United States. I think 500 people using the device, so there's probably a lot more people using luminopia right now than CureSight, but they're both in their kind of like baby step phases. And with that, I had a QR code for luminopia. You can get that later if you have to. I got a lot of time for questions. Why don't we ask questions? Yeah.
So, when vision do you stop treating?
Okay, very good question. Can you repeat the question? 2025 or 2030? Can you? Okay, oh yeah, yes, sir. So I was asked, what level of vision do I stop patching? Usually about 2025-ish, maybe 2030 if I know they're a monofixator, especially. So the people, monofixation, it's like I described that to the families, they got that little blur zone that blurs out the macula when they're binocular, and I know I'm not going to get them any better than 2025 or 2030, so that's usually where I'm kind of stopping if I know they're a monofixator. So I'm always, when I'm improving, I try to check for monofixation at that point, and there's a ton of monofixation syndrome, ton of it. So that, and again, I really plug along. I probably make my families really miserable. I really want the family, when all is said and done, to maybe feel like they really did the best they could if they end up with a kid that sees poorly. Because I think they need to have that put, rest that in their mind. So I keep plugging along for quite a while sometime, 10, 11, 12 years of age. These, I think, might give other options. I think that's the future, is looking at these dichoptic treatments, maybe with the older kids. And I think that's what the ATS-24 is going to maybe help us with, understand that. So, and I think, even in our office, I talked to my pediatric optometrist. I think we're going to kind of, there you go, thank you. They're going to kind of throw that out there to maybe our older kids. So the problem is, so there's a 3,100 plus actively patients prescribed with 500 prescribers in the U.S. Some initial studies showing that there does seem to be a little bit of improvement with the luminopia. And we found that in our cases that we recruited in ATS-23 people. Our biggest problem is payer coverage right now. Some of the big payers are starting to be convinced to pay something, but so many of these kids are on medical assistance of some sort, so it's going to be a problem with that. They're trying to have an out-of-pocket cost that might be feasible with some people, but this is all just work in progress. I can't even tell you what they're even charging the people right now, because I think they're getting paid so much different from everybody. But again, I think this is the future. And there's that QR code. Okay, we had that question about where do I stop patching. Any other questions? How many people see kids? Anything else? I can't believe you don't have any questions. All right. Well, I guess I'm done. People can catch a shuttle. Thank you. There's soon to be a lot of familiar faces out here, too. Kids that people are rotating. Nice to see your face.
For those of you who came late, the golf tournament, the shuttle starts at 11:30. They don't have food at the golf course, so please pick up your lunch here. And also, I'm doing a workshop at 1:30. I hope to see you there. It's about how to handle distressed patients and examine patients effectively using compassionate language and helping your burnout as well. Oh, it's going to be across the way at the main hotel, second floor, mezzanine.
I am Dr. Tom Castillo. I am, first of all, I was thanking Dr. Sala for a wonderful presentation. What are we doing there? Okay. Thought maybe we can get moving a little faster, and that way we can get you guys off onto the golf course. I don't want you teed off at me if we're running too late. And also grab some lunch. And we'll see how we're doing. All right, thank you. Oh, so I have the honor and pleasure of introducing the next speaker. He's from Chicago originally and was born on February 22nd, 1950, which at that time was Washington's birthday. Now he celebrates on the third Monday of February. Graduated from Chicago College of Osteopathic Medicine, did his internship and ophthalmology residency there, and graduated from CCOM in 1977. That's the same class that Darth Vader and Boba Fett graduated from. Anyway, so I just retired from practice of medicine 2 days ago, and so as far as my... Thank you. That's what my patients did too. It's been a great 43 years, I have to say, and currently continue to be a part of the faculty at the University of Wisconsin, Madison's Department of Ophthalmology, an associate professor, and so we're just very happy to be here today. I'm trying to keep this from being a dry eye lecture. I just want you to be able to enjoy this. And so we're going to talk about a couple of things. Now, this is my financial disclosures. Dr. Sala said he's happy, he'd love to have financial disclosure. Let me explain something to you about financial disclosures, okay? If you're Richard Lindstrom, and you've got 3 slides full of financial disclosures, it's worth your while, okay? Because if you just have one like me, and it's kind of like, okay, fine, I've got to get this approved by my attorney to make sure everything's okay on the contract. You give them a W-9 so that way that, they pay you. And then, of course, you have to submit that to your accountant, and then he charges you. By the time you get through with all of that paperwork and financial stuff, basically you're losing money on it. So I have not taken a penny from Luminous, okay, because I just can't afford it. So anyway. Just want you to know that. But we're talking about dry eye, and Mark Abelson did a beautiful paper on 3,500 years of dry eye treatment. He was talking about the artificial tears that were made and the different things that were being done back then. So, I mean, fine. It's great that he could speak from his experience. So I only went back to 1970 because that's as far back as I could go. And most of the tears that we had then, were saline-based. Okay, so you put some preservatives in there, some benzalkonium chloride, a little something there to make it work a little bit better. But basically, it came down to the fact that it doesn't stay on the eye very long. It's very short retention time, and it just poorly covers the ocular surface. So you had to put it in very, very frequently. And we see those drops that are still out there on the market. The next advancement, though, was to use some natural polymers, methylcellulose. And so we see those currently. That was in the 1980s. Polyvinyl alcohol, povidone, polyethylene glycol. That's the same stuff that's in Miralax. And I've never figured that out because it's also the same stuff that you find in antifreeze, Now, I can understand antifreeze, polyethylene glycol, Miralax, using that for constipation, you get a little stuffed up there and you say, okay, fine, let me give you this. Doc-wise, let's say Prestone. Never mind, we're not supposed to use brand names. But anyway, so, that's okay. But that's stuff that we would put in the eye. Povidone, Ivizia is a newer drug there that we're using as an eye drop, but basically it is povidone. That's all there is. So we find some of these things, and we still find those in Systane and Refresh drops that are being currently used. Third generation, hyaluronic acid, tears, those got, we've got some nice viscoelastic properties to those. We also have increased tear stability, good protective effects, and we find those in Blink, and that's a good example of that product. It's kind of weird. We have to go through different, if you prescribe any drops, anything, let's say that you want to get something, let's say you want to give them Restasis, all right, and you go to the VA and they're in the VA, you've got to actually prove to them that you've used different types, different classes of artificial tears before they'll approve it, and that means then you have to go through prior authorizations. We heard about all the problems with prior authorizations this morning. But the fourth generation ones, now we find the lipid emulsions, and so these give us a better coating. Soothe XP, Sustain Balance are some examples of those. These are the ones now that we can see where, where people used to say oil and water don't mix. We actually can get oil and water to mix. Now, how do we do that? That's the anionic polarized phospholipids. And we have a speaker coming on Saturday. He's got, Dr. Jack Greiner, he actually holds patents to that type of technology. So prescribe a lot of that. It's good for the DOs. All right. Next thing, nutrient-containing tears. All right, so we try to say, what can we do to make, if we're going to go ahead and moisten the eye, that's one thing, but can we make things better? And so we try putting things in. Hyaluronic acid, we've mentioned already. That's one of the things. Trehalose is a disaccharide that's used to go ahead and provide a bioprotectant film over the eyes. Sodium hyaluronate, again, another drop that's going to increase the viscosity, increase the lubrication. And then you've had triglycerin and trehalose, which is, again, helps with protective effects on the desiccated epithelial cells. So we're trying to go ahead and say, can we make that cornea better? Vitamin A, vitamin E, antioxidants that are being put into the eye drop in order to make it nutrients for the cornea. I mean, we end up telling our patients that you need to have a nice tear film, because it's what really where all of your nutrients are coming for your corneal surface. And so we try to encourage them to get a good tear film going. B6, B12, those are some examples there. Visia is a newer eye drop, contains trehalose. Refresh omega-3, again, has the flaxseed oil in there. So basically, again, we try and get something a little bit better. So all of these products are trying to give you a comprehensive way of treating the eye symptoms, not just by lubricating it, but also providing some nutrients for health of the eye. So most of our current drops now, our artificial tears, are aqueous-based. They have extra additives to it, hyaluronic acetate, sodium hyaluronate, things that are going to go ahead and make your cornea stay healthy. And then our lipid-based tears are helping now, some of the newer products helping with meibomian gland dysfunction. So that's kind of what we're doing in tears, except for a problem. In 2023, these are the recalls that we had. Okay. Now, I mentioned in my disclosure, too, that, I'm going to be talking about brand names as well as generic names, but there's a concern. When you tell patients you just go ahead and get some artificial tears, we have a concern because we have a number of situations here where we've had recalls on these eye drops. And, like we said, you can see there, we've had cases for patients of having their eyes removed, 8 cases of vision loss, and there's even been cases of death from infections, from contamination of their artificial tear drops. In March of 2023, Apotex had some contamination, sterility problems. They recalled because of cracks in the cap of the bottle. So even when we were concerned about the over-the-counter eye drops, there was a small concern as well about some of the prescription drops that we have. But most of the time we would say, yep, prescription ones are okay. The other thing is, okay, you know, if you're looking CVS or Walmart or wherever, you know, what should I tell the patients? You know, it's not like we're trying to say, yes, you know, we are doing something. You know, we're always accused of saying, oh, that we're bought by the insurance companies, but we're not. We're doing the best things that we can for the patient. So I tell you, personally, you know, I tell patients, you know, get, you know, the Sustain brand or Refresh brand, something, you know, Bausch & Lomb, Blink, something that we know is going to be safe for you, and not something that we're not really sure at what part of the world it came from. All right, so we've made it through the tiers. I wish I brought you more Kleenexes, but here's the definition. This is the Tear Film and Ocular Surface Society Dry Eye Workshop 2 updated definition of what dry eye is. Dry eye is a multifactorial, you can read this, of the ocular surface. The key thing is hyperosmolarity, okay, and inflammation. So how do we test for that? Well, we can test for hyperosmolarity. The product that's out there, Tear Lab, will allow you to go ahead and test the hyperosmolarity of each eye separately. If you find that there's an 8 micron difference, then we consider it to be positive. If it's over 300, it's considered to be positive for dry eye. And then, you know, if you're trying to find out whether or not you have inflammation going on, Inflamadry is a product that's out there that tests the production of MMP9, and that's an inflammatory byproduct, and so you can say, yes, you have inflammatory dry eye. What are some of the other things that we can do for dry eye besides artificial tears? Well, again, stay well hydrated, you know, drink water, you know, work habits, telling the patient, hey, take a break. You know, you're at your screen, you're on the TV, whatever it is. Blink more frequently. As we get older, we blink less. All right, that's happening. You know, and if you have a patient with Parkinson's, you know that they're going to be having some problems because they're not blinking as much as they should. They've got that Parkinson's stare. Avoid smoking and air pollution. You know, smoking is one of the things that I always tell the patients. You know, there's nothing good in smoking. Period. We talk about heart disease, we talk about lung disease, you know, but macular degeneration. So I'm from Beaver Dam, all right, Beaver Dam eye study. That's where we showed that smoking is bad for age-related macular degeneration. So basically, again, those are one of the things you want to stop. Healthy diet, you know, leafy green vegetables. We know that's good for everything. Omega-3s, Dry Eye Workshop didn't find that omega-3s were helpful for dry eye, but again, it's helpful for everything. So I think it's always good to have some good omega-3 fatty acids in there. Good levels of vitamin A, B12, vitamin D, another one that's really important. And we find that a lot of people in our population don't have enough vitamin D. Control your blood sugars, your lipids, your blood pressure, those are always important. Humidifiers, you know, that's one of those things that we find that the patients are always complaining about, and we have to educate them. You know, if you're driving, you've got the air conditioning on, you've got the heat blowing in your eyes. Both of those things, you're just going to go ahead and dry your eyes out. And then, you know, in the wintertime, the humidity's down in the house as you turn on the heat. So, you know, we have to kind of say, these are some of the things that you want to do. Make sure you have a good humidifier or something that's going to produce, you know, some nice moisture within your home. Lid hygiene, very important. You know, one of the things that we find is, you know, patients that may have meibomian gland disease. All right, so you want to make sure that they keep their lids clean. You can use some baby shampoo. There's enough products out there for lid scrubs, and we can use those things also. But one of the things, I went to Ascris last month, and what's one of the things that they're pushing right now? You know, kill them, Demodex. mites. And so this is a lotilaner ophthalmic solution, and it's indicated for the treatment of Demodex blepharitis. You take 1 drop every 12 hours per eye for 6 weeks, and it's successful. It gets your cure rate down to 50% in 43 days, reduction in collarettes. That's your key sign there that you may have Demodex. And then there's a 60% mite eradication and a 25% erythema cure in 43 days. So I went on Google to find out how much does this stuff cost. All right, so $1,950 for a 10 ml bottle. And you've got to go through the full treatment if you want to make sure that everything's done. So what are you going to do? It's kind of a tough situation there. You got bugs on your eyes, ma'am. And I'd like to prescribe this stuff for you. I'm going to go ahead and write you a prescription for that. And the second prescription, yeah, you're right. Yep, that's for nitroglycerin. Just in case, you never know once you get to the pharmacy. So, we've got great things that we can do, but why do we end up costing patients this type of amount? I don't know. That's just my personal concern. But anyway, you go through and if you see this, they have this thing. Tarsus is the name of the drug company. They have their Tarsus Connect. They have 4 of these pharmacies that you can get this from. One of them is BlinkRx, which is a company also that's handles a lot of the Bausch & Lomb products. So keeping the eyelids clean, home remedies, warm compresses to clean the eyes. Rinse your eyelids with warm water and baby shampoo, as we said, clean that off. Non-preservative eye drops or thicker ointments may last a little bit longer. One of the other things that we had when I was younger was goggles. You could put these, hydration goggles on. Basically, it's like a swim mask, but you would put moist pads in there, and that would help, when you're sleeping at night to try and keep your eyes moist. But there are other products out there, Metabeads, things that you can put into the microwave, get things nice and warm and release warm, moist heat, and so those are helpful as well. Prescription medications, Restasis has been around, cyclosporin has been around for a while. There's a new formulation with this Cequa, which seems to be working a little bit better, a little bit higher dosage than the 0.05% cyclosporin. I think it's 0.09%. Liftograph, which is Xiidra, that's been around for a while now. And again, these are indicated for the treatment of signs and symptoms of dry eye disease. It's not really curing the problem, but it does make things better. Short-term use, this Isuvis is loperidol, which is Flarex, and basically it can be used for a short term. It's corticosteroids. Short term, they say up to 2 weeks. This is a nice drug for trying to get a quick response on the dry eye. And I know people will be talking about dry eye and cataract surgery, so I don't want to get into that. But again, this might be a time when you say, yes, I want to get your eyes in a little better shape before we go ahead and get your measurements for your multifocal implants and so on. Matter of fact, really, what has driven our interest in dry eye is the fact that we have all of these wonderful implants that can improve your vision after cataract surgery, but then you run into the situation where you have to explain to the patient, why they're not seeing as well as they could. So we like to attack that sooner than later. Cholinergic drugs can be used to help stimulate the tear production, and there are devices now that you can use to stimulate the trigeminal nerve by putting that in your nose, or even outside. There's another one that's available. Some of these are not approved yet, so that's why I haven't gone into them. There's another nice picture from the Asterisk meeting. They had a lot of these little booths set up with you get your picture taken with the whatever, it doesn't matter. But the fact of the matter was it's fun. But MIBO, again, now we're trying to attack the evaporative dry eye. So, this is just pure perfluorohexyloctane ophthalmic solution, which I've really practiced many times saying that. I just want you to give me a big round of applause on that one. Oh, thank you. But it's vehicle-free, water-free, preservative-free. This is just 100% of perfluorohexyloctane. And I wanted to say that again. Dual affinity, air and lipid. So again, we're mixing, air and water and oil together to make this work. It directly targets evaporation. A lot of our dry eye patients are evaporative dry eye, so we're thinking, wow, isn't this great? We can use it, and this is going to work. Of course, we don't know how it works. That's the problem. We don't know how it works. And what is it indicated for? Basically, again, for the treatment of signs and symptoms of dry eye. But, hey, this is a lot cheaper than other stuff because, 1 drop per eye 4 times a day. Well, it's not really cheaper. It's only a 3 ml bottle. But, now it's running it depends on if you have insurance or not, $750 to $950 per 3 ml bottle. Again, it'd be great to say, hey, I got something for you. Now you have to sit down and explain to them. And then the patients are going to go ahead, and this is where you get the phone calls and say, pharmacy said this is going to cost me $900. Can I get something cheaper? I mean, you say, well, I can get you something cheaper. It may not work. We don't know. But anyway, that's something we have to deal with. That was supposed to come out a lot bigger. I don't know what happened. Autologous serum tears. So this has been around since 1975. The biggest problem we have is, getting this made up. You can go ahead. It's made from the patient's own blood serum. And, and it has, all of the good stuff in there. It's got the cytokines and growth factors, everything that you would like. But the biggest problem that you had was, how do you get it? Okay, who's going to spin it down? Who's going to make it? And, when it was being made, basically, it was being done, by the individual physicians and for the individual patients. So you'd have to go ahead. You have to get their blood drawn. There's a company out there called Vital Tears. Again, I got their information while at Ascris. Very nice. They've got a whole system planned out where you can go ahead and have you can go to one of their centers, or they can have a phlebotomist come to your home, draw the blood, okay, then it gets shipped out overnight to their facility, they process it, and then they can ship that back to the patient as their artificial tears. So, and then you can have different concentrations. You can give them 10, 15, 20, 25, 30%, or their standard conversations, 40%, or you can go with 50, 75, or 100% concentration. I've talked to several physicians who actually use this. Most of them will use the standard conversations, but there's like one doctor I spoke to, he says, I just go right with 100% right off the bat. So it's just kind of like how you feel about it. I mean, if it's very, very severe dry eye, you might want to go with the higher concentrations. But so we do have at least something that we can offer the patients now as far as serum tears. How many people have actually had patients who are really severe dry eye and just, you've done everything that you can for them and just still having no luck? You guys have any of those patients? Yeah, I have too. And, it's just, this seems like this would be a nice way to go. It's nice to be able to say, yes, there's a way that we can get this done, and it can be efficient and hopefully not too expensive. I did not get a price from them as far as how much this would cost. Mm-hmm. 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 So Dr. Scorin, I'm going to repeat what you just said, though. So he says about $290, $300 It'll last for about 3 months. They have little vials that can be frozen. They can keep that, and they really like it because it's a holistic approach. And how does it work for you?
Like anything else in dry eye. Sometimes yes, sometimes no.
Mm-hmm. Do you know what percentage or what concentration it would be? It's over 40%. Okay. So anyway, that's something we have. IPL, very, very popular treatment that can be done in the office. That's been very successful, I believe, again, and there'll be more people that'll be talking about that. Amniotic membrane implants, another way to go. Surgically, closing the tear ducts. We can do that with cautery. Electric cautery can be used after you numb the eye. Of course, you numb the lids. You can close off those tear ducts permanently. Usually, I like to do that if they've been successful with a punctum plug and have not. That keeps falling out. They lose it. Whatever happens, and then you kind of say, well, they were happy, why don't we do this? And they do that okay. Lid surgery, lower lid tightening surgeries will be helpful, and making sure that they have a good blink. Some patients, there's not much you can do about lag ophthalmos. You just have to tell them, you use the little artificial tear ointment at bedtime. Punctal plugs, yes, it's a great way to go. Making sure, if you can size them and then put them in, that would be the recommendation. But still, if they rub at it, they'll come out. So what else do we have? Well, this is something that's new. Again, it was presented at ASCRS last month, and it's a hyaluronic acid gel that can be used. There's a syringe, basically, that will give you enough to fill both canaliculi. And they did the study that found that it was not inferior to an Oasis plug based on the Schirmer test and the OSDI at 3 months. And so it gave them relief for 6 months. You could bill for it using the code that you would use for punctum plugs is what they were telling us. So that sounds like a nice way to go. But, talking about OSDI, there's a lot of dry eye questionnaires that have been used throughout the years. And so when we're talking about, relief of signs and symptoms of dry eye, when we're talking about symptoms, we have a number of questionnaires, the DQ25, the OSDI, the SPEED, Standard Patient Evaluation of Eye Dryness Questionnaire, which is the Dell questionnaire. And then there's one that was used for studies, the Dry Eye Screening for Dry Eye Epidemiology Projects, DEEP questionnaire. So this is the dry eye screening questionnaire, the DQ25, and you can see this has quite a few little questions on there. The SPEED questionnaire, the Dell questionnaire, again, had about 14 questions on there. But the SPEED 2 is the one that ASCRS is using now, and can combine that with an evaluation for dry eye for the use of a premium IOL prior to their cataract surgeries. How many people here actually do use questionnaires, dry eye questionnaires in their practice? You got a few, okay? Because, it's kind of interesting. Do you only use those that are using them? Do you only use them because of your premium implants? Or are you just on everybody? Pardon? On everybody. That's the key thing. We have a lot of patients. So basically, the dry eye is a very, very common disease. Matter of fact, when I'm talking to patients, I'll say, if you want to know how common it is, just go to Walmart and take a look at all of the artificial teardrops that are on the shelf. So, it gives you a little idea. So, if you really want to go ahead and say I can help my dry eye patients, you might want to go ahead and just have them fill out a little questionnaire as they come in, and then that may help you out in that regard. But I didn't want to get too much into the ASCRS questionnaires, but it is part of their ASCRS preoperative ocular surface disease algorithm. That's right off the bat. So that's where you would start out, and then take it down to whatever's going to be necessary to get you your best outcome for your cataract surgery patients. So, yeah, so over the past 43 years, I've gotten shorter, I've gotten fatter, I've gotten bald. So basically, I had a patient the other day that told me I look like the guy from the Jersey Mike's commercials. So I just wanted to tell you guys, thank you very much, and have a great... Do you guys have any questions? Okay, yes? There is a sizer that you can get. I'm trying to remember who we got it from, Medic or something, but you can get that, and it comes. There are two probes. Kind of think of it like punctum probes, basically a punctum dilator, and they are marked for 5, 6, and then you have another probe for 7 and 8, and you can just go ahead and size those up. I can't remember. I've had that for such a long time. I apologize. Yeah. Mm-hmm. Mm-hmm. Yeah. I got mine a couple decades ago as well, because it's exactly what you're describing. Eagle. Mm-hmm. Yeah. Yeah, they come in a nice little case. You can sterilize them, and they're fantastic in trying to avoid the wasting of a plug, as you say. Yeah, it's too big, it's too small, whichever. Any other questions? Yes, sir. Tim.
Thank you for your review of the recent outbreak of the infection from the dry eye. I just had a few questions along those lines.
Okay.
Do we have any answers as to why the Pseudomonas have got in there?
I remember reading one of the manufacturers explained to the FDA when the FDA said, your sterile technique here is very poor. And his response is, I didn't know that these artificial tears had to be sterile. Yeah. Okay, so basically, what are we looking at? You look at these coming from India, Venezuela. I mean, you pick up a bottle of anything nowadays, it may be distributed by somebody here in this country, all right, but, it's manufactured in some other country. So basically, the main problem, and here's part of the thing too, we see an increase in these number of recalls. It's not that, things are getting worse, it's just that we're looking at it now. The FDA is paying more attention to this. Why Pseudomonas? The only thing I can tell you is that, somebody just wasn't paying attention where they're making the drops. And then, of course, what happens? That's what we end up on the shelf as the generic. And, a patient came in the other day again with a drop from Equate, which is a Walmart brand, and it's made that, I believe it was in India, and, we're not supposed to be pushing any particular brand, but on the other hand, in the safety, for me anyway, for safety for the patients, I tell them, hey, get this brand or that brand, and stay with the branded drugs. Yes. There were four deaths that I recall that were reported. That was Pseudomonas. It was I believe it was Pseudomonas that was the cause. Pseudomonas was the key one that they found causing loss of the eye, so on. I mean, let's put it this way: any bacterial contamination of the drug, is a concern. I wish I had a better answer for you for that one, but unfortunately, I can't say, for sure. All I know is when I've got somebody that's, has a potential for going out and buying something that we're not sure of, pulling back. They did pull all of those drugs, Walmart and CVS did pull the drugs when these things were occurring. The question is, how good have we gotten at making sure that these companies are producing these in a sterile facility? That one I don't know. But yeah, I did. Yes, yeah. No, you're absolutely right. I ran across that as well. Yes, Sarah. It was sepsis, yeah. Yes, sir. I'm sorry. Uh, which one? You know what? I never used that one, okay, because basically, what I had heard from others where they were just not really satisfied. It didn't work out as well as the nasal spray. I'm trying to remember the name of the device that we used in the nose. It seemed to work well, but it seemed to the patient it seemed kind of dirty. But there is a newer one too, though, that stimulates the trigeminal nerve, but it's placed outside of the nose. And I can't remember the name of it. It was one of those that were presented at the ASCRS. Mm-hmm. Mm-hmm. You had a question, sir?
There are some doctors in my area that claim to be dry eye specialists. What exactly are they doing, to claim this?
Yeah, that's part of it. Mm-hmm. And IPLs. So, but yeah. Microblepharoexfoliation is another thing that you might find at these dry eye clinics where they go ahead, like Blefex, I believe, is the device that will go ahead and kind of scrub your lid margin. No, no.
No, but I think having a dry eye component in your practice, we have APIs 9, and one of our ophthalmologists is a medical ophthalmologist, does not do surgery. She trained in cornea, but she is our
Mm-hmm.
But I mean, she goes to town on it, and she does serum tears.
Mm-hmm.
So nice having her, because I'll take care of a little dry eye, and it's like, you know what, this is a little bit too much, and, you know, goes to town. No, I understand that. Please don't even. No, I understand. I think that if you really want the, you have to do it. You have to do exactly what your clinic is doing, is you have to have those accoutrements, equipment, et cetera, that nobody else in your area has, and then you can, I think, justify it.
And there's,
And patients will sometimes, desperate enough, they'll do more than half of it pays out. Because it's so nice, you know, having one guy doing LASIK, me doing glaucoma, to have her to take care of the. Oh, yeah, it helps. We have some.
yes. Yeah, and that's a lot of that, like the BlephX can be delegated to, your technicians. Exactly. And so, the devices that we can use to do meibomian gland expression, those are some of those newer ones that are coming out. Sight Sciences is here. They've got the tear care, which again provides heat to the lids, and then you can go ahead and use these little paddles to squeeze the lid. So heating up the lids is another thing, but that's essentially LipiFlow does a combination of heating the lid as in the meibomian glands, as well as then using compression on them at the same time. Mm-hmm. Well, mhm. Yes, Sight Sciences. They're here, but they're here with their Omni device for glaucoma. Not for the eye, dry eye. Yeah. Tim, you had a question.
So I hadn't heard that diabetes is associated with dry eye. Could you explain maybe how that association?
Again, it has to deal with hydration. Okay, so basically, again, when your blood sugars are up, your eyes are getting dry, is at least what I had read. That was the key thing that I had taken away from that study, and I can't remember what the study was, but that's a good question. So what Tim was asking is, Dr. Winter was asking about the association with dry eye with diabetes, and as my reading was that it had to deal with some dehydration. Any other questions? Yes. I've used the Eagle plugs, and as far as the brand, yeah, that's one we've used is the Eagle one. That's the one I've always found seemed to work pretty well. The reason I like that one, it usually had I like the shape on it. Some of the newer ones have more of a little rib, and it seemed like more difficult to get in, and so that I just went back to the Eagle, which is just kind of almost like a triangle at the bottom. And the sizes go anywhere from a 0.5 to a 0.8 millimeter. Okay, yeah, I've never gone up that high, but that seems pretty good. Okay. Any other questions? Thank you, everyone. I appreciate it. Enjoy the rest of the conference.
All right, so good morning, everyone. So we're going to be going over recurrent corneal erosions today. So we'll start out with a case presentation. So 31-year-old male with a history of PRK in both eyes 1 week ago, presents with pain in both eyes. He's been using all of his drops as prescribed, particularly the artificial tears. He thinks his contacts are still in place after the procedure. He says that 2 days ago, he woke up with significant eye pain and tearing in his right eye. Yesterday, he reports the same symptoms in the left eye. Overall, he says his vision's doing okay, and the pain and tearing generally resolve within an hour or two. Denies any eye rubbing, any specific trauma to either eye. So on exam, his contacts are still in place. They're in good position. His vision is 20/30 in both eyes, and this is about a week after the procedure. He has trace injection in both eyes. So you go ahead and take his contacts out and put some fluorescein in his eyes, and this is what you see. So pretty normal appearance, nothing really that you can pick out here. But in general, anyone's got any ideas of what's going on besides obviously the topic of what's going on here? Yeah, so something like contact lens related issues. I don't know, maybe they've got a little bit of dryness, something like that. But obviously the topic of today is recurrent corneal erosions, and we can talk about how that can look really normal on exam. So, speak of the devil, it's me. So this person's me. I had PRK in January, so we'll kind of talk about that. So etiology of recurrent corneal erosion, trauma is most common. Fingernails, paper cuts, that sort of trauma is classic for recurrent corneal erosion. EBMD is the classic corneal dystrophy that's associated with it. Other corneal dystrophies can do it as well. Different kinds of corneal ulcers, infections can do it as well. The next three on this list are sort of contributors or ocular comorbidities that can contribute. And then the last one here, we have PRK and LASIK. In about 5% of cases, they say that recurrent corneal erosion can occur. Typically, the mechanism is it's outside of the treatment zone or the ablation zone where the epithelium is debrided. So that 1 millimeter strip outside of the ablation zone where the epithelium is debrided typically is where this happens and in those cases. So a little bit about the mechanism, going back to a little bit of OCAP stuff, but it's abnormal hemidesmosome formation. There's a shearing that happens that takes off the epithelium, particularly the eyelids can get kind of stuck to the epithelium, and when the patient wakes up, the epithelium will come off. There's an inflammatory cascade that involves MMPs that we can target for treatment. In general, hemidesmosome formation takes 4 to 6 weeks. So we'll keep that in mind too with the treatment. This requires a lot of compliance on the patient's part for treatment. Signs and symptoms. One thing to specifically ask for in your patients is difficulty opening their eyelids in the morning. They'll get pain and tearing upon awakening many times. They'll get photophobia, foreign body sensation, blurry vision. So there are two distinct sort of forms of recurrent corneal erosions. The microform lasts hours. It's more frequent. In my case, it was every few days that I was getting them, which is not great. You can get a normal exam with this, so that's important. So you can see the patient, and you'll really have to rely on the history to be able to have any sort of suspicion for this. This form is more associated with EBMD. The macro form lasts days, is less frequent. You can actually see the epithelial defect on exam, the loose epithelium, and it's associated with trauma. So exam for recurrent corneal erosion, like we talked about, you can have a normal exam, so you really have to rely on the history. You can have mild epithelial irregularities. You can have loose epithelium as well. So this is a pretty classic picture of heaped up epithelium. You can see some staining essentially there in recurrent corneal erosions. One thing that you can do at the slit lamp is you can use a cotton tip soaked in proparacaine, and you can kind of gently move the area of loose epithelium, and you can just test the integrity of those cells right there. These coexisting diseases you can look for as well. Some of these can contribute to the inflammatory cascade in this as well. So treatment, believe it or not, I've made it to the everything except for surgery. In my case, it's been a long road, and I'm still trying to treat it. But lubrication is the mainstay of treatment here. You have to have patients lubricate about every hour, preservative-free, artificial tears. You treat any sort of active epithelial defect just as you would an abrasion in the acute setting. From this algorithm here, you treat the dry eye aggressively. You can go ahead and put plugs in if they have a lot of dry eye. That's one of the first things that you can do. Moving down the list here, you can use doxycycline, 50 milligrams twice a day. You can also use topical corticosteroids. So all of that is just to reduce the inflammatory cascade that's going on. You can also put contact lenses. I have contact lenses in right now to reduce the adherence of the eyelid to the epithelium to allow everything to heal nicely. We'll talk about Mural 128 and other things like that. If you have a lesion where you can actually see the defect, then you can move on to something surgical. But if you can't actually see the defect on exam, it makes it really difficult to justify doing anything surgical. So superficial keratectomy, phototherapeutic keratectomy, those are things typically used for something that a defect that you can actually see on exam. So more about treatment. So we talked about contact lenses. Sometimes you can use these for up to 6 months in patients. So extended wear contacts you can wear for 3 to 6 months to allow things to heal. Autologous serum tears, those have worked well in my case. Here are all the growth factors that can be found in serum tears. Those help support epithelial cell growth. Amniotic membranes, Procare and Ambiodisc use both of those. So the mechanism for those is that it's thought that the membranes are similar to conjunctiva, so it kind of works like a Gunderson flap. So again, you're supporting epithelial cell growth. Other things to tell your patients: avoid fans, wear moisture chamber goggles at night. One other drop or ointment to recommend is Mural 128. This ointment's thought to reduce the contact of the epithelium to the eyelids, and it reduces the corneal edema that happens at night from the hypoxia overnight. It's a little bit of hypoxia that's they say can contribute to this. If the patient can catch this before it actually happens in the morning, they can go ahead and put an artificial tear in, and that helps prevent anything from happening. The long-term prognosis for this is generally excellent, in terms of the vision, but in terms of reducing the frequency of recurrences, this is definitely something that can persist 6 months to a year in many cases. So complications of recurrent corneal erosions, corneal haze and scarring can happen, infectious keratitis and decreased vision. And that's pretty much all I have. So, does anyone have? Yeah.
Sometimes I'll tell my patients before they wake up,
Mm-hmm.
if they're cognizant, like rub their eyelids a
Okay.
little bit before just opening them abruptly. Have you done that for yourself just to try it?
Nope. I haven't heard that one.
Okay, because you sort of rub them gently, and so you shear it so that you break the adhesion.
Uh-huh. Yeah.
I was wondering, 'cause you said you tried all those other.
Yeah. But the lubrication I've tried.
That's a good idea.
Did you mention anything about anterior corneal stromal micropuncture?
So it was that's one of the surgical ones that I didn't treat. So typically the stromal micropuncture is used for peripheral lesions when it's not in the visual axis, and it's used for the macroform version where you can actually see what you're treating.
I actually personally found it to be extremely successful.
Okay.
And I've used it in a center too.
Okay.
I mean, you're doing it's rather superficial. That's the advantage of it, especially if you get that specially made. You don't need to, but I'm just saying.
Yeah.
I get the one that's made just because I have students and stuff, and I let them focus on my eyeball oil. They love it.
Have you seen the form that has kind of a normal exam and you have to rely on the history, or usually you see a defect?
Usually I get them sent
Yeah.
to me by optometrists.
Okay.
Where they've tried all this stuff, and really they need somebody to go in there.
Yeah. Okay.
All right. Well, thank you very much.
All right, so we're doing a case report here on an interesting case of vision loss. No financial disclosures. Today's sponsored by Tractor Supply Company. You'll see why here in a minute. So we had a 59-year-old male engineer in the community who presented with vision changes and floaters in his right eye. He had some hypertension. Only past ocular history of any significance was LASIK 20 years ago. So his vision of his right eye at presentation was 20/40, left eye 20/10. So anterior segment exam was essentially unremarkable. He had a little bit of cataracts, but posterior segment, all we could see in the periphery were some peripheral punctate like RPE changes in that right eye. Everything else looked pretty good. So here was a photo of the right eye. You can kind of see in the periphery. Over here we got the RPE changes. Kind of non-specific, but that was kind of the only thing we saw on exam. So differential diagnosis at this point could be anything. So wanted to get some more answers, so ordered some labs. Really the only thing to speak of with the labs was ANA was positive. His FTA-BS was just minimally reactive, but his RPR was non-reactive. So kind of scratching our heads a little bit here. So so far we're just working with, he's got some possible retinitis and retinochoroiditis, pigment epitheliopathy of his right eye. And at this point it was just kind of idiopathic, wasn't really sure. So we had him come back a week later, and the lesions in the right eye resolved, and his vision essentially went back to his baseline. Just to make sure everything remained stable, we had to come back 6 months later. And vision improved to 20/25. He stated at that time that appeared to be his baseline, so we just had him come back as needed for that. Here's a photo at that time. You can see the lesions have resolved. Fast forward to 2 years later, so we just, like I said, had him come back PRN like that. The guy comes back again with pain this time in the right eye and some vision loss in that right eye as well, which was even more severe than his initial visit. So that right eye vision was 10/120, left eye 20/30, also a little bit down, but at that time he didn't even notice that. Pressures were normal. Looking at him grossly, you can see his right eye. He had a little hypopyon there, some redness as well, but left eye, again, we also noted hypopyon, so 10% right, 5% OS. He did have some vitreous haze posteriorly as well. And then in the periphery, he had some scattered retinal hemorrhages and superior choroidal detachment, actually in both eyes. So, interest of time, we'll just keep moving here. So we just started him on Pred Forte Q1 hour empiric Valtrex as well to cover any possible herpetic involvement. Again, still scratching our heads. Given the acuteness of this and still just no answers, we wanted to send him to the ER, so more thorough workup. So that's what we did. Again, not a whole lot of new news. The CRP and ESR were elevated. ANA was still elevated. RPR remained non-reactive. So in hospital, we got a CT of his chest, an echo, and blood cultures ×2, and an MRI brain as well. All that stuff was within normal limits. Decided to get ID on board, see if they had any help that they could offer. So this is kind of where it got interesting. So at this point, the guy was scared, and I think he just opened up a little more weak because we asked him the same questions at admission or the initial visit in the clinic. And anyway, so he admitted to testing positive for syphilis about 2 years ago, which was at his initial presentation. And at that time, he had an affair on his wife, was too ashamed to tell. Again, this guy was a professional in the community. He was an engineer, and so he was used to researching, and that's what he did. He did some research and found out you can treat it with penicillin. Didn't want to leave a medical paper trail, so he went to a Tractor Supply Company and bought some penicillin meant for livestock, and was self-treating with that. Here's some proof that we're not messing with you. It's right there, $39.99. You can get it yourself. 5 stars. 5 stars. So again, RPR still negative. FTABS was minimally reactive again. But because he already treated himself with some form of penicillin instead of treating with penicillin again, which is kind of the classic treatment, went with IV ceftriaxone, continued the Pred Forte, and then added some oral steroids as well. By the way, lumbar puncture was within normal limits. Okay.
So from here on out, I'll kind of be talking about kind of the sequelae of this clinical case. Dr. Hollicky did a great job presenting more of his clinical course. We'll talk a little bit more about that and some of the sequelae and a little bit more about syphilis. But after he was discharged at his 7-week follow-up, vision was noted to be improved to 20/25 OU, pretty much back to baseline. Physical exam, other than some posterior synechii OU, was pretty much within normal limits. He came back about 10 weeks afterwards with a significant drop in his vision in his right eye and a greatly elevated IOP at 50. He was count fingers. At that time, again, we're in retina clinic at this point, but some of the thoughts initially were, maybe is this steroid response, is this iris Bombay from the posterior synechii from his severe previous bouts of uveitis. And so he was sent to glaucoma, underwent a PI in the right eye, and had a good response with a reduction in his IOP and a baseline return with visual acuity. Here's a picture of the anterior exam. You can see that deep central anterior chamber with that Bombay, likely again from the posterior synechii that was mentioned. But not over yet. Unfortunately, this poor guy came back a year later for another acute drop in vision in the right eye. He was 120. OCT MAC, which was previously normal up to this point, as you can see, just shows significant full thickness macular hole there with some areas of edema in that cuff around that macular hole. So with this gentleman's significant history, it was decided to start with a little more conservative measures. He was placed on Acular and Pred Forte QID in the right eye, which was noted to close the macular hole after 1 month of treatment. Repeat OCT was obtained, and we see that that was closed up pretty nicely there. Patient began having symptoms consistent with cataracts, underwent cataract surgery, unremarkable. Everything went well, returned to baseline vision afterwards. But then 7 months after the full thickness hole resolved, patient had a recurrent macular hole in that right eye. At that time, he was treated with STK. We can see that hole again here, not quite as large of a defect as the first, but still recurrent after the STK, at which point it didn't close after 2 months, so he was taken back for a vitrectomy with an ILM peel, and post-op month 1 vision was 20/40. OCT at this time shows a closure again of that hole. And this was a Optos photo, some mild postoperative changes after the vitrectomy, but otherwise pretty well returned to baseline. We're not seeing any of those peripheral lesions at all anymore either. So, so from here on out, that up to this point, that's what we know of this patient's issue with syphilis. We'll see if he has any further appointments with drops in his right eye. Hopefully not for this guy. But we just wanted to highlight, we thought this was a great case that elucidated several important points about syphilis. First and foremost, you know, this kind of solidifies syphilis again as the great masquerader. We know it causes lots of signs and symptoms. And so the importance of a thorough history just can't be understated in this case. You know, there's a lot of shame and guilt that goes along with a diagnosis like syphilis, and so no matter how well educated or how you know, prominent position, maybe even those more educated and more prominent positions may be more likely to try and hide that fact from the clinician. But and up to this point, we don't have any recorded cases of literature of self-treatment with over-the-counter IM penicillin being effective in syphilis treatment. So. Oh, sorry, hitting the laser pointer. So just a couple brief notes on syphilis testing. The two main ones that we kind of think about and go to are RPR, which is the non-treponemal, which is often used as a screening test and used to follow treatment. You also have your fluorescent treponemal antibody absorption test, which is treponemal specific, and that can remain positive even after appropriate treatment. So that's more of a chronic marker. Some recommend doing the inverse, starting with the confirmatory marker and then using RPR to follow treatment more specifically, as that can remain positive well down the line. In the interest of time, we won't go through each of these scenarios in which one might be positive, one might be negative. But again, RPR we kind of think of as more of the acute phase and something to follow treatment with, whereas the FTA-ABS can be used in more chronic cases. So syphilis treatment includes penicillin, usually not from Tractor Supply. As described before, he had already tried some form of penicillin, so it was thought let's go with ceftriaxone. It has, although IV penicillin again is kind of the gold standard in treatment, multiple reports show the efficacy of ceftriaxone. Has great CNS penetration and a long serum half-life, lower frequency of dosing, which usually results in shorter hospital stays, maybe reduced cost, and maybe ease of therapy for the patient. Syphilis has been noted to be associated with rhegmatogenous retinal detachments and tears, and the thought there is a link between vitreous contraction post-treatment and PVD, which is maybe what led to our patient's macular hole. A brief discussion on macular holes as well, since this was part of our case. The Closure usually treated with vitrectomy, and the closure rate with a vitrectomy and a peel is about 90 to 95% success. But surgery does carry its risks, and this guy had a rough go of things. So this is a brief diagram of kind of the pathogenesis of a hole, which usually starts with some traction, leading to a cystic space in the fovea and the surrounding retina thickening, and then once that breaks free, you're left with that full thickness hole. But several recent studies have shown that a topical therapy can be very effective as well in certain patients. There's a couple of those and the recommended treatments for that were used in those studies. But in summary, those that may be good candidates for full thickness macular hole treatment with topical therapy are those that have smaller macular holes, less than 200 microns or so, with significant cystoid hydration, and that don't have current VMT at the time. And that was our case. We were fortunate to get to be a part of that, and very interesting as it relates to syphilis and the importance of gathering a thorough history and all the sequelae that could result from the Great Masquerader. But yeah.
No, I do think syphilis is coming back. I have not seen a case like in my whole career. I think I've seen 2 or 3 in the last few years.
I just saw one about 9 months ago, neurosyphilis, and I haven't seen one since my internship. It's definitely coming back.
And granted, our demographics in our residency clinic are probably a little different than a lot of practices, but there was at one point one day in clinic where we had just 2 cases of bilateral anterior uveitis, and at the same time, the very same day, in the room next to one another, both ocular syphilis. So anyways, we were trying to get to the bottom of that, but we weren't able to.
Making that.
Yeah. Okay, well, thank you very much.
Yeah, thank you.
Come on up. And this is, well, it's Dr. Patel. How do you say it?
Vishesh.
Vishesh. That sounds
Hi, everyone. Good morning. My name is Vishesh Patel. This is not a typical case presentation, so bear with me. I'm going to talk about contractual considerations in the private equity era. I have no financial disclosures, nor am I an expert in private equity or business-related stuff. So, quick introduction, the private equity industry prominence in healthcare has increased over the years and has reached into different medical specialties, including ophthalmology. While PE investments offer potential benefits for ophthalmology practices, such as more resources, it still presents with challenges for both practicing physicians and newly employed ophthalmologists. It's important to negotiate with these PE firms with careful considerations of the contractual terms in this era. Understanding the structure and obligations within PE contracts is essential for ophthalmologists operating in this evolving landscape. So what is a PE contract? It's basically a former merger agreement between the target and the PE acquisition firm. While these contracts foster strong partnerships, they don't guarantee future financial stability for healthcare providers, as each contract varies in intention and structure. Ophthalmologist investors have specific obligations outlined in the contract, aiming to optimize technology, recruit suitable managers, and enhance clinical quality. Before signing, it's important for ophthalmologists to seek a legal counsel to ensure that the contract aligns with the interests and addresses potential limitations or liabilities. So from a legal perspective, there are various legal conditions aimed at establishing clear investment patterns and mandates, yet these regulations have become increasingly complex. PE advisors may face regulatory reviews or investigations, and fund managers may encounter restrictions on borrowing and investment decisions. Limited partnerships typically last 10 years with options for extension, and partners must consider legal considerations such as investment decisions, type of investments, and limitations on liability. It is pretty much crucial to have access to financial information and to include exit procedures in the contract for potential legal risks. The rise of PE in ophthalmology. PE firms are typically interested in ophthalmology due to numerous factors such as the aging population, prevalence of chronic diseases such as macular degeneration, and the outpatient nature of eye care. These practices offer revenue opportunities and networking potentials, particularly in the rise of outpatient services and profitable cash pay operations. Ophthalmologists may seek PE investments as a means of portfolio diversification and stable growth, aligning with large capital funds PE firms have built up in healthcare investments. So the trends, studies have assessed PE acquisitions in various medical specialties, including ophthalmology. One study showed that 18,000 group medical practices, 355 of them were acquired by PE firms from 2013 to 2016, with ophthalmology representing 3.1% of these acquisitions. Another identified 29 platform companies acquiring 228 practices in ophthalmology and optometry, with a linear growth in acquisitions from 2012 to 2017 and a surge in 2018. However, there hasn't always been an increase in at PE acquisitions. One report suggests that there is a slight decline in acquisitions in 2019 as compared to 2018. So contractual considerations from a perspective of a practicing ophthalmologist, PE contracts can yield beneficial outcomes, offering an upfront payments for the sale of the practice, potentially increasing operational productivity and reducing time spent in the practice management. However, several contractual considerations must be addressed, including practice valuation based on EBITDA, openness to partnerships, changes in compensations, and consequences of leaving employment, as well as strategies for organic growth. Under a contract, ophthalmologists face fewer decision-making responsibilities regarding, for example, surgical services, capital equipment, staffing, accounting, and business decisions. And then typically after selling your practice, ophthalmologists have limited authority in decision-making, with the management company typically holding the final say. One study just showed that vitreoretinal surgeon fellows and senior ophthalmologist residents expressed concerns about PE acquisitions. Among them, 81.4% were concerned about the effects of PE acquisitions on career opportunities, citing worries about job security and loss of physician oversight over clinical operations. In that study, this 88.2% believe further research should be conducted on the impact of PE acquisitions in ophthalmology practices. These findings indicate a perception among vitreoretinal fellows that working for a PE-owned practice may entail less autonomy, emphasizing the importance of future ophthalmologists to understand the details of these contracts before joining the practice. There's another study by Novice for dermatology residents' perception on PE involvement. From 137 responses, the study found that 92% of residents were aware of PE's role, with 65% not open to working with PE-backed practices. Around 70% believe PE involvement negatively impacted the specialty for the same kind of reasons of autonomy, increased use of physician extenders, compromised patient quality of care, and long-term salary implications. Dermatology residents also have significant loan debt, and so they're wary of these PE involvements. Despite the growing PE ownership in dermatology, more than half of these participants in the study did not favor PE-backed practices. And ophthalmologists joining a like a new ophthalmologist from out of residency joining a PE-owned practice should consider several factors. First, they should understand the types of equity offered, particularly in the event of company bankruptcy, and evaluate different shareholder classes. Secondly, they should grasp the concept of investing and its implications for retaining shares or plans that are provided by the company. Third, physicians should be aware of the responsibilities when partnering with PE firms, including potential non-compete agreements in the contract. Last, they should be familiar with the effects of subsequent practice sales or inquire the contract transferability or renegotiation. Overall, the experience can be positive if you have supportive partners in management companies. And in summary, contractual considerations in private equity need to be carefully evaluated in order to ensure the agreement is in the best interest for clinicians, practices, and their patients. And these are my references. Thank you so much.
Thank you very much. Is there a fourth person here? Okay. Do they have your? Okay. And which one? Who are you?
Dylan Bailey.
Okay. So that you're the mystery guy. All right. Dylan Bailey, come on up. Oh, at the end, we're all going to take a photo for the association's Instagram next to the board up front here. So make sure you don't run away.
All right, so you can go ahead and advance to the next slide. So we had a patient who came in as a 44-year-old male who had gradual vision loss over the past 2 months. He didn't have any exciting event that he remembered. He didn't have any other symptoms associated with this other than a mild headache. He actually hadn't been to a doctor in 20-some years prior to establishing care with the PCP at the Family Med residency, a couple doors down from our clinic itself. And during that time, he had to work up with laboratory evaluations, imaging that was unremarkable. And then he continued to have basically symptoms of the mild headaches to where he would get kind of dizzy at times, felt like his balance was off. And the FM resident, after the second or third visit, actually did some visual confrontation field testing, things like that, and realized that he was missing a very large part of his visual field. So she actually called us and had the patient seen the same day because they had seen him a couple times and didn't really have any answers for him. You could go to the next slide, please. Yeah. So when he presented to the clinic, because we knew there was a visual field defect, we actually sent him straight to the visual field machine itself. He wasn't able to see well enough to complete a visual field, unfortunately. So we put him in a room. His visual acuity was 20/25 in the right eye. It was count fingers at 3 feet at the left eye with an eccentric gaze. Pupils were equal round reactive to light. There was no APD that was present on exam. His EOMs were normal. In the slit lamp exam, anteriorly was unremarkable. Posteriorly, in the left eye, he had pigment floating in the vitreous. He had a massive elevation of the macula with a mass that was extending from the temporal aspect. And with that, he had some intraretinal hemorrhages. He had basically an obscured view of anything outside of the temporal arcades, roughly from 2 millimeters to 3 millimeters around the optic disc temporally. And there was a questionable retinal detachment associated with that as well, but unfortunately the view was very poor because of how extensive this mass was. Next slide, please. So we take him to the fundus photography. So this is a picture of his fundus. I apologize for the quality. Our fundus photo camera in our clinic can be temperamental at times. So, but as you can see, there's a large temporal mass there in the macula, extending very close to the optic nerve. You do get a little bit of a view of the arcades itself, but you can't really see anything temporally. And on exam, you actually couldn't see anything temporally past this mass. Next slide, please. So we went ahead and did a B scan, and as you can see, there was a large mass associated with the vitreous cavity there. And unfortunately, we weren't able to get the exact dimensions of it at this time, but given the findings here, you know, the biggest concern obviously at this point was ocular melanoma, and so we had to refer the patient out to an ocular oncologist following this finding for further evaluation. Next slide, please. So kind of just a very brief review here. It's the most common primary intraocular tumor that's found in adults. There's a very strong tendency for this to develop mets, especially to the liver, if you have a choroidal melanoma because of the high vascular nature of the choroid. This mnemonic, there's some slight variations you'll see of this mnemonic, but this is the one that's commonly, expressed as to find small ocular melanomas. So these risk factors increase your suspicion that you do have an ocular melanoma situation. So thickness greater than 2 millimeters, subretinal fluid, symptoms such as visual field loss, flashing lights, floaters, orange pigment on the lesion itself, and then also being within 3 millimeters of the optic disc margin. And in our patient, he had essentially all of those symptoms. And then also they're going to have a low internal reflectivity, and drusen are typically absent. Next slide, please. So just kind of another brief table here in terms of sizing. When you look at the apical height as well as the basal diameter, it's used to classify these lesions into small, medium, and large. And then those recommendations are typically kind of used to filter into the correct treatment. In general, when you get to medium and large, and the COMS evaluation of this kind of talked about it in detail, but in the interest of time, I don't want to dive too much into that. But radiotherapy is typically the most commonly used treatment today. And then when you get to large lesions itself, the COMS proved that there was no mortality difference between enucleation versus pretreatment with radiotherapy followed by enucleation. And the enucleation, again, is typically reserved for large melanomas, and you have to make sure these patients also have a full medical oncology exam as well to evaluate for metastasis. So if you can go to the next slide, please. So in our patient's case, we thankfully were able to get him in pretty quickly for imaging. So the MRI, head with and without contrast, was unremarkable with the exception of the ocular melanoma. And then the CT, chest, abdomen, pelvis, was negative for METs. So he went to an ocular oncologist and medical oncologist at a large academic center at this point. The PET scan itself has actually been completed as of now, but unfortunately we don't have the official read on that yet. So hopefully that will come back negative for this patient as well. Next slide, please. The lesion itself on imaging measured 19.9 by 20 millimeters at the base with 10 millimeter thickness with a large associated inferior RD. So if you remember the classifications, 16.6 was considered large in the basal diameter. So we are well above that. And this lesion actually was too big to consider treatment with any sort of radiotherapy, unfortunately. So he is scheduled to have an enucleation completed in the near future. And hopefully with that, the PET scan will come back negative, and we can then look at what sort of prognosis he has going forward in terms of the rest of his life. But there's case, hopefully, over the next couple of weeks, we can have a few more answers for this patient. But he will have the eye removed here shortly, so go ahead. So do you have any further questions?
Oh, that's your last one.
Yeah.
How often, if they do negative, how often do you do a screen CT for liver metastasis after 5 years, 2 years?
So oncology-wise, there's a little bit of variation in terms of how often they like to follow patients. With him having no significant other medical history, typically they'll follow them every 2 years with imaging. Sometimes they'll split that down to 1 year or 6 months if they have higher risk factors. In his case, he does have a family history of some interesting cancers, which I didn't want to get into with this presentation, but the family history might kind of increase the frequency of imaging and things like that they're doing for metastasis. But again, it's going to depend on what comes back with the PET scan.
Yeah, just as a comment in general, it's always, if you practice long enough, it's always devastating when you find one of these. You have to tell your patient, I'm sure you have some, and then, so they're always look for. Well, I want to thank everybody. I think there's nobody else presenting, right? And we're even on time. That's like amazing. Good. So thank you. Round of applause for all the residents and students. Okay, so
COHNS Annual Clinical Assembly. We'll get started right away. We'll begin with Dr. Will Sawyer, a cornea specialist out of Texas. He will be followed immediately, without any further introduction, by, sorry, I got ahead of myself just a moment, by Dr. Andrew Strand. Thank you.
Good morning. Yeah, thank you all for having me as your keynote speaker this morning. I think that's what the first one is, right? So All right, I'm Will Sawyer. This talk is on neurotrophic keratitis. I have no financial disclosures. Our learning objectives are to learn the most common etiologies of neurotrophic keratitis, to learn testing for the disease, the staging, and review treatments. And the treatments is going to be the longest part of the talk. In fact, we're going to kind of go faster through the earlier stuff. So I'm going to put my phone because this clock is not going down here. So neurotrophic keratitis, I mean, in a real simple form, it's just reduced sensitivity of the cornea. It could be completely absent. It occurs in about 50 out of 100,000 patients, or, you know, if you like to reduce things like I do, about 2 out of 1,000. Is that right? I have to look about it. Anyway, this is damage basically at any level of the trigeminal nerve, anywhere along the path, all the way from the well, even in the brainstem to the eye itself. So just as a little review, the trigeminal nerve exits the pons right about there. It goes to the trigeminal ganglion in Meckel's cave and branches into the ophthalmic division, V1. That's the one we're going to be talking about the most. And then, of course, the maxillary branch, V2, and the mandibular branch. And you can see the dermatome patterns for each of these. So then it branches into, the ophthalmic division branches into the nasociliary nerve, which is the major cause of this talk, or the major point in this talk. Also the frontal nerve and the lacrimal nerve as well. The nasociliary nerve branches to the long ciliary nerves, which these provide most of the sensation for the cornea. The short ciliary nerves also provide sensation. They go to the ciliary ganglion, and there are connections between the nasociliary nerve and the ciliary ganglion. This is a little more in detail, the same type of thing. This shows the plexiform structure in the cornea. You have these larger subepithelial plexuses, which then go up into past Bowman's layer, into the subbasal plexus, and then up into the epithelium, all the way to the superficial epithelium. Anywhere along this, all the way from the epithelium to the pons, is a site for causing disruption of the trigeminal nerve and causing neurotrophic keratitis. So there's too many etiologies to cover all of them, for sure. The list just goes on and on. So we're going to talk about some of the more common ones that you can see in practice. So HSV, herpetic keratitis, very common. So this is the stats of when you do have a patient with HSV keratitis, 6% of them will go on to develop a neurotrophic keratitis. In zoster, of course, zoster is always worse. Zoster has a 12.8% chance of turning into neurotrophic keratitis. Chemical burns, of course, can cause it. Chemical burns can just trash all the nerves on the ocular surface and do even more damage. Long-term contact lens wear. This can also cause a neurotrophic keratitis, and this is going to be more at that epithelial area, or the actually usually above Bowman's layer, and just damage, wear and tear, and think of it as kind of denuding or depopulating the nerves in the epithelium. Corneal surgery, of course, can disrupt the corneal nerves. It's difficult to do a PK like that one up top without disrupting a few of the nerves. I've not been successful in saving the nerves on any of my transplants yet. But also other surgeries can do it as well. This is a superficial keratectomy on the bottom there, and that can also cause a neurotrophic keratitis. So anyone coming into my office who's had a trigeminal nerve ablation, I automatically assume they're there for neurotrophic keratitis. So I always wondered, how many of these, to me, I always thought, oh yeah, don't have that done. You're gonna regret your decisions in life doing that. So I looked it up. Only actually 2.8% go on to develop a neurotrophic keratitis with this procedure. Not as bad as I thought. It's it's patient bias. They're there to see me for their cornea, so I'm seeing that 2.8%. Surgical reductions of jaw fractures can also cause damage to the trigeminal nerve. Intracranial masses, basically anything that can press on the trigeminal nerve. So meningiomas and aneurysms, acoustic neuromas. You can see in this picture the tumor pressing up onto the trigeminal nerve. And I've got one of my patients later has this going on. Diabetes, of course, multiple sclerosis, leprosy, systemic diseases that can cause chronic wear and tear to all the nerves, including the corneal nerves. And of course, congenital syndromes, Riley-Day, dysautonomy, I can't say it, Goldenhar, Mobius. So Mobius is really actually agenesis of cranial nerve 6 and 7, but they can have agenesis of cranial nerve 5 as well. I had a patient in her 60s who came and saw me because she had never blinked in her entire life and her corneas weren't doing well. And she had Mobius, just that mask-like face, and she was esotropic, and she had no idea that her condition actually was a syndrome and had a name. And after 60 years, I told her what she actually had. All right, so this is kind of how you need to think of neurotrophic keratitis. The body has just quit loving the eye. It's just stopped loving it. So if anybody's a Lumineers fan, yep, sounds like I'm going to go on it. But it's better to feel pain than nothing at all. And the opposite of love's indifference, not hate. And that's really how you need to think of neurotrophic keratitis. The body doesn't get angry like in rheumatoid or iritis or things like that, but that's a bad thing. It just leaves the eye alone to fend for itself, just total neglect. Doesn't feel it, doesn't care if there's an infection, doesn't care if there's an epidefect, doesn't care if there's not, just doesn't love the eye at all. And so it's hard the treatment's extremely difficult for that because you're basically intervening and caring for something that the body's not caring about. There's lots of there's a few different grading systems with this. So the neurotrophic keratitis study group has a 6-stage grading system. The first stage is basically just any kind of altered sensation. And with that, you can extend your diagnosis quite a bit. There's a lot of people with altered corneal nerve sensation. Number 2 is going to be epitheliopathy without stromal haze. And then stage 3 is epidefects without stromal involvement. And then we get into the stromal problems with stage 4, epitheliopathy with or without, or basically with stromal haze, and then epidefects with ulceration, and then of course corneal perforation, which you want to avoid. Now, I don't know about you, but 6 stages is too much for me. I'm an American, I don't have time for that. I go with the old school stage in just 3 stages. You cut that thing in half for me. So this is much easier to think of it. Epithelial changes with stage 1. So anything just epithelial, basically, with stage 1. Punctate epithelial erosions. I'm old school, so I still call it SBK. Epithelial haze, epithelial edema. Stage 2 is where we get the epithelial defects, either recurrent or persistent. The sterile ulcerations. Now, especially you have to think of this on the superior cornea. It's very odd to get things on the superior cornea because the lid's covering it. And then stage 3 is corneal ulcer with stromal involvement. So basically stage 3 is now you're going to at least have a scar, if not worse. Scar, perforation, infections, that kind of thing. The diagnosis. So to diagnosis, history is the biggest thing. Taking good history and just knowing, okay, did you ever have shingles on that side of your face? Did you ever have an ablation therapy? Just all of these kind of things. But a good history is key to the diagnosis here, and it makes up most of the diagnosis. Asymmetric epithelial changes. If you're seeing one side just a whole lot worse than the other for no apparent reason, you have to keep this in the back of your mind. SPK, or ulcers on the superior cornea. Like we were talking about, the upper lid should be covering that area, so that should always be the area with the least amount of SPK and the least chance of getting an ulcer. So if it's got one there, you really have to think maybe the nerves aren't working in that area. Segmental iris atrophy, zoster can definitely cause segmental iris atrophy. So if you see that, you have to think this eye might have had shingles. You need to be careful on this one. And then epithelial defects that just don't want to respond to anything you're doing. Sometimes that's kind of one of the big keys is I'll have somebody who comes in and I'm trying everything and nothing will close their ulcer. And then I have to start thinking, okay, this might be neurotrophic. Testing. So you can use an esthesiometer, and this is the kind of central down picture is my wife. I highly suggest doing this for your marriage. If she tolerates this, she's a keeper. Oh, it changed the orientation. Well, rats. That didn't work so well. And then here is a patient who has neurotrophic keratitis in the other picture. Now the esthesiometer, I can't even say it. One, I can't say it, so I can't tell my staff to go get it. And two, I don't ever know where it's at. I mean, I don't ever use that. So in the clinic, I use a cotton wisp. I just pull the end, get a nice little tip going, roll the edge, and that's how I check sensation. And you want to check 4 quadrants of the cornea. It's a very subjective test. You just kind of say, okay, that seems like normal sensation. We'll call that 4+ sensation, and then just go down from there, where no sensation like we saw with that last picture, that'd be a 0. If they don't blink, that's odd. And you can really kind of start jabbing with that.
You map that out in quadrants specifically, or do you take it overall? You would always, textbooks say, always check the center, because that's where most of the nerves are.
Right. I do, and I usually start with the center, but it's very patient dependent, because you have some of those people who just see something coming at them and they get all antsy, and then I'm just like, all right, we're just going to check one area, and I'm going for center. And then you have other people who are very, very cooperative, and you can map it out then. So I map it when I can, but I don't spend too much time on it, to be honest. The other part with this is, I don't know about your clinic, but anyone entering my clinic, the first time I see them, they've already got drops. They've already got drops in their eyes. And so a lot of times I'll have this, I'll already diagnose them with neurotrophic keratitis, but I'll confirm it at a follow-up visit. And I'll tell them to come in. This patient can't have any drops, especially proparacaine or tetracaine. And I'll check them before we do anything else there. But the first time I see them, they're going to have drops before I actually see them. It's too much of a problem, at least in my clinic, to make an exception to that rule. So I'll just do a follow-up for that. The treatments. So with the treatments, we're going to go more on with cases for this. I feel like that's a little easier way to talk about the different treatments. So stage 1 disease. I had a 59-year-old male who had an AV malformation that had pressed on his trigeminal nerve. His vision was good, 20/25 in that left eye, and he just had SPK, but it was superior. Once again, that's really weird. And then, of course, not at the initial visit, but at a follow-up visit, I checked with a cotton tip, and sure enough, he did have decreased sensation. So Let's see. Dylan, what's good treatment for stage 1? That is a great way of doing it. So Dylan said, start with artificial tears with this. Punctal occlusion, punctal occlusion, artificial tears. This guy, his vision would get down to 20/15. And then, over time, he'd quit doing it. And I'd see him and say, you need to get back on your tears. And he would, and his vision would improve. So a lot of this is just a cheerleading session, which is important for follow-up because you will have patients that just quit doing it. I don't know about your patients, but if I'm not prescribing it, they don't take it near as seriously. And so when I tell people you have to use artificial tears, a lot of times they just say, nah, that's a suggestion. That's not a treatment. And you have to keep telling them over and over and over again. In fact, a lot of times, if I'm very serious about wanting someone to use an ointment artificial tear, I will prescribe erythromycin ointment because it's gentle. Nowadays, the resistance is so high, it's nearly worthless as an antibiotic, but it works great as an artificial tear ointment, and they'll take it serious if you write the prescription for it. All right, stage 2 disease. So I have a patient, 72-year-old female. She's had 2 transplants when I met her. The last one was 10 months ago, and she had this oval defect, 1.5 by 3 millimeters, that just will not close. And her doc has had her on tears and ointment and antibiotics and steroids. Now then, we're kind of bumping up our treatments now, getting into the little more complicated ones. Let's see, Dylan, what's a good treatment? Good. So yeah, he was saying punctal plugs, Restasis, Hydra, all these are good things. We're going to bump it up even a little harder though, and go to amniotic membrane grafts. So these are very easy to put in the office. Most insurances do cover them. Of course, you have to watch out for deductibles because these can be very high price if a patient has a large deductible. Most Medicare plans is pretty easy though. They come either cryopreserved, like the top one. That one, that's Procara. That's going to be a cryopreserved amniotic membrane trampolined over a plastic ring. And then down low, we have a dehydrated amniotic membrane graft, and there is a lot of different companies that make these now. Well, I guess they don't make them, they process them.
What's your membrane of choice for the dehydrated?
I use one from Ophthalmalogics, something like that. It's a company it's out of San Antonio, and one, they put their packaging in these little tiny sleeves so it doesn't eat up a ton of room with big boxes. And they layer it on itself so that there's no real right up or down. You don't have to orient it. You can just grab it and put it on. And then also it's competitively priced as well. So that's the one I use. But to be honest with you, there are so many of them, I'd probably base it more on pricing. I've used lots of different ones, and I personally haven't ever found one that I say, whoa, that one is superior to the other one. Now, in my mind, the cryopreserved was a lot better than the dehydrated. And so I would usually, we'll kind of come back in a second, I usually start with the dehydrated because it's a lot more comfortable for a patient. But if I'm not getting results, I go to a cryopreserved. Or if I just had a big bad disease, I'd usually just go right to a cryopreserved. This study here is very, very interesting though. This was for persistent epithelial defects. This wasn't just for neurotrophic keratitis. It was for persistent epithelial defects. And they compared cryopreserved versus dehydrated. Now, in these persistent epi defects, only 45.5% resolved with a single application. So kind of 50-50 it's going to work, maybe a little less than 50-50. And If you look, the cryopreserved was only 46.5, and the dehydrated was 44.1. So there was not a huge difference between if you were using a cryopreserved versus a dehydrated amniotic membrane. And this is kind of one of those things, you know, my anecdotal evidence in my office was obviously biased. I was just thinking that my cryopreserved, but when you take large numbers, the cryopreserved's not that much better than the dehydrated. And it costs a lot more, by the way. So multiple applications of amniotic membranes only raise the resolution to 50%. So, you know, you can definitely try putting them on again. They're an easy thing to do, but even multiple attempts is not that effective. And then neurotrophic keratitis. 67% of neurotrophic keratitis epithelial defects did not resolve with an amniotic membrane. Now, that being said, there's not great treatments. So I'm still using this a lot in neurotrophic keratitis. This is a very, very, very difficult disease. Once again, you're trying to love that cornea when the body doesn't care about it at all. Now, this is how I do the dehydrated amniotic membrane. This is my setup, just some little tips here. Is Austin Coleman here? So Austin Coleman actually taught me this. Plastics guys teaching cornea guys since 2011. And it's great. This technique is fantastic. So the top is the amniotic membrane, then we have a Weck cell, and then a bandaged contact lens, and then non-tooth forceps. Let's see if this video will play. I don't know. The first time it's ever turned sideways, sorry. So I put the contact on a Weck cell. I soak up the fluid with the Weck cell, and it just holds better. Then I take the amniotic membrane, and I just put it right in the contact. This is a good one because this was a more difficult one. Just the temperature difference causes these to curl a lot of times. It's super annoying. So you get it on there, and you just kind of flatten it on out with the forceps. But this is on the harder side right here. Now you can get a speculum, put it on the eye, put the amniotic membrane on, and then the contact. But I've had a lot of patients who have a very strong bells and can still bells up into the speculum and wrinkle up the amniotic membrane. Then you have to decide if you're going to eat the cost of that one or try to flatten it out, which can be quite difficult, trying to flatten out wet tissue paper. Here's how I put it on an eye. This will probably flip sideways when I click.
Look down. And look straight forward. Try not to close. Now close your eyes gentle.
Okay, pretty easy that way. That's a whole lot easier than the speculum and then trying to get the speculum off the eye and not take the contact. At this point, I usually have them keep their eye closed, and I take a tissue and put a little pressure to squish out any air bubbles, and that really works quite well. And then, of course, taking off the contact's a very easy thing to do. When I do these, we'll talk about this in a minute. I usually leave the contact on for a week, see them about a week later, and see how that's worked. It's different for everybody, though. Okay, so if you use a cryopreserved one, putting cryopreserved membranes on the eye is pretty easy. I just have them kind of look down and slide it up under their upper lid, and it's very easy. You can hold them with your hand to do it. Getting them out can be difficult, especially when the membrane dissolves. It will kind of suction cup onto the eye, and it can be quite difficult to get these out. So this is my technique. That's a muscle hook that I'm holding. Very slowly look down. Don't do it fast. Do it real slow. You get a little muscle hook. Just get under the inferior edge. Now very slowly look down. we go. So, and here's another one the same way. That's I use a muscle hook because it's got that rounded in and it's just very atraumatic.
Back and look up, and then when I tell you, I want you to very, very slowly look down, but don't do that till I tell you. Look up. Now very slowly look down.
Just very simple to get it out that way.
Good.
And
it itches.
the muscle hook's nice because the last thing you want to do is cause an epi defect when you've just closed one with a membrane. So, sometimes I don't. Depends. I mean, if their eye looks good, they don't like having these things on. Patients do, and so, yeah, nice segue into this. So this is one where it had dissolved, and then the patient had got it out of his eye, and he brought it in a Ziploc bag, labeled it eye torture device. So yeah, that plastic ring can be pretty awful on the eyelids. And so if the cornea is looking good underneath it, or sometimes it's been a while and I can't get a good view through the membrane, I go, well, I need to look at it. And so I don't always wait for it to dissolve. In fact, it's a lot nicer for the patient if it hadn't dissolved yet, because that's really when these tend to become a lot more painful. This is a patient who, a 50-year-old female who had contact lens problems, kind of a recurrent erosions from contact lenses, and then she developed a neurotrophic cornea centrally and neovascularization. It doesn't show up great in this picture, but that's actually elevated neovascularization, kind of like a pyogenic granuloma. And then, of course, in the fluorescein photo, we can see that she's got a central epithelial defect. This one I treated with amniotic membranes and then also Tobradex with a long taper. And this is kind of her progression. So she got better, and then I tapered her completely off of things, and boom, it popped right back. I mean, nearly the exact same as before. And so then I treated her with Tobradex and timolol, and I put her on oral atenolol, like you would with a capillary hemangioma. And slowly over time, the epithelial defect closed and it dissolved away. I recently saw her, and you could just see some haze where this was, but she had greatly improved. And so I just keep her on a low-dose regimen of the same thing. I don't stop it. This is the same patient, same progression, just in fluorescein instead. And we can see bad, got better, took her off, got worse, and then just slowly got better and better and better. All right. Still, though, with our transplant patient. So we've tried amniotic membranes. It didn't work in her. This is 10 months, and this thing has not closed. So what's the next good treatment? Dylan. Pardon? No, but that's not a bad thought. That's not a bad thought. So with her, I don't want to go there yet. He said Gunderson flap, and you're going to take away their vision whenever that happens. That's not a bad thought because it'll close the epithelial defect. You're going to bring blood flow to the area. But you take away their vision once that happens. So the next thing I tried in her was a good old tarsorrhaphy. So this is one of those procedures. There's a million ways to skin a cat. This is how I usually do it. This is a 5/0 silk suture, double-armed. I just take some of the styrofoam from the suture packaging and cut it off to make my bolsters. And I thread each needle through on one of them, just on one of the bolsters. And then I usually start on the lower lid. I don't know. You can do it however you want. Most of the time, I start with the suture that's going to be the nasal most suture, and I put that nearly dead center. And then my second suture, I will put more temporal. And so I know I'm going to have a little, you know, it's going to still close things, but it's going to be a little more temporal. Then I put, after I pass it through the lids, I put on the second bolster and tie it off. And I tie it very tight because I find that at first there's some swelling from the suture pass, and if you don't, sometimes it can open up and you can see a little thread, and the thread can scratch the cornea. So I actually tie it pretty tight. But you still can have enough room to get drops in nasally and have them look nasally and hold up the lid to see what's going on with the cornea. Those, usually I'll leave those in close to a month. Most lids, at least the way I do it, most lids can't take much more of a month with a temporary tarsorrhaphy like this. And it starts getting, you know, the lid starts getting very raw. Sometimes it cheese wires through, even with the bolsters. I did have one patient who his eye would do it for 3 months at a time, but that's the record. Most people, about a month is all they can take with these. All right, tried it, it failed. Still that ulcer is there. Still that ulcer is there. So, what should we try next? Dylan? Not yet. Not yet. All right, no, we're going to go with autologous semen tears. And so these things, you can put them anywhere from 20% to 100%, and they're not easy to get. It's hard to find compounding pharmacies anymore. But luckily I've had 3 of them. There's a company called Vital Tears where a patient can have their blood drawn at home and then mailed in. They compound it and mail it back to them. But it's more expensive, but it's at least a way of getting it to rural areas especially. There's not good studies on neurotrophic keratitis and serum tears, but all of the small studies I could find did show that every time it was used, it did improve things. So because after kind of doing this talk and researching it more, I'm actually a lot more aggressive with these. And now that I've found a few places that can do it in my area, I'm a lot more aggressive with these. Now, if that doesn't work with her, she's got a transplant. She's got an epi defect for over 10 months now, but she can see out of that eye. So probably what I'll do is keep her on a prophylactic antibiotic drop and a bandage contact lens. So when you're putting so there were some studies that showed if you did a Boston keratoprosthesis and you had a contact over it, that you could keep that contact in place for 3 months if you use polytrim or moxifloxacin just once a day. Well, I don't know if you've ever dealt with a Boston K-Pro. They're difficult things. So I feel like pretty much anything, then you can kind of relate that to anything. So I have a lot of patients that I keep in a bandage contact lens using polytrim once a day. And it seems to work well. And then I bring them in and change it out. Pardon? I don't. I just don't have that much familiarity with it. But yeah, no. But if you do, we can talk later and I can find out a little more on it. The bandage contact lens also works well with amniotic membranes. So a dehydrated amniotic membrane, you're putting a contact on their eye anyway. And that membrane will slowly dissolve away. I mean, most of the time in a week, that thing's gone. And so there's patients, I'll put that on, put them on a prophylactic antibiotic, and then keep them in that contact for 3 months and change out. All right, so that's what I'm going to do with her if the serum tears don't work. Okay, so here's another patient, 63-year-old female. She had zoster. I always tell my zoster patients, I may see you a few times, or I may see you every week for the rest of your life, and I don't know. And I might see you for a few times, not see you for a year, and then see you every week for the rest of your life. Because the zoster is just mean. It is just mean. So 7 months after the zoster, she had a large persistent epithelial defect, 6'5" by 6'5". Her vision was 2600. I did AMGs twice on her and it closed, and her vision was 2200. And she had some scarring with irregular epithelium centrally, which is why she was 2200. Now in this one, I used a Syningerman, also known as Oxervate, which is obviously easier to say. And it's been shown in studies to improve the nerve density in the cornea and also to improve the sensation. When it came onto the market, it was a big deal because it's really the first time we saw nerves regrowing with this. Just 6 times a day, 8-week course. The biggest problem with it is it's exceedingly expensive. And when it first came out, it was about $100,000 for a treatment. Now I think it's about 80. Still, that's a lot. I mean, it comes. We start getting into that talk of, depending on the prognosis of this eye, how much is it worth to do this? When we're talking these kind of numbers, at least in my mind, I kind of think we're a little bit irresponsible if we don't talk about things like that sometimes.
So I've used Oxervate a lot. Do you have a patient assistance program?
Yes.
Do you have the patient sign everything and you send it to, I haven't had a patient who $50.
Correct. The patients usually do not have to pay much. They usually will forgive the copay part, and it does work well. And don't get me wrong, I'm not a fan of insurance companies, so I don't mind when they get, but we also then start getting into, we're not getting reimbursed for things because the pharmaceutical companies are taking a huge portion of the pie with this. And so, I mean, the patients usually don't have to pay much of anything with it. But you do have to, I mean, once again, we got to think of the overall picture, I think. I still use it, don't get me wrong. I'm going to do what's best for my patient, but I do think about this every time I prescribe it. Now, with her, we did a course of this, and her vision improved to 20/40. I mean, that's fantastic. She went from 2200 to 20/40. You don't see a lot of times when people have that haze and scarring getting back to that. So her vision then worsened a little bit to 20/70, and we did a second course of it. And I just saw her recently. This is her eye recently. Remember, she was at one point 6.5 by 6.5 epi defect. Vision was 2600, and her vision is now 20/25 in that eye. So it works. It does work. But it doesn't work in everybody. It doesn't work in everybody. So here's a 65-year-old male who had zoster. This is actually not his picture, but it's just one I had of this. He had a persistent epithelial defect and did lots of different therapies and eventually did Oxervate, and the epithelial defect closed. But his vision was count fingers, and it never improved from count fingers. And in that case, I wonder, well, would the more responsible thing for me to do, would it have been to do a Gunderson flap? Because this is a much more cost-effective treatment, but it's hard to say because how are you going to predict if someone's going to have a count finger scar or if their vision's going to get back to 20/25? It's a difficult decision, and people don't like having Gunderson flaps. They can't see out of them, and cosmetically they don't like the way they look either. Now you can do partial flaps. This is a partial flap, that's why I wanted to show it. If an epithelial defect is more towards the edge of the cornea, you don't actually have to cover the whole thing. You can just bring the conjunctiva down over that area and make sure it's well covered. And then of course, this can progress on in stage 3 to perforations or desmetaseals. This is where things get real intense. And unfortunately, I've dealt with a lot of perforations, And so when I can get away with it, I like to glue these. I've glued enough of these to develop my own technique with this. The way I do it is I get a medical cyanoacrylate glue, Thermabond or such. With Thermabond, you break the tube, and I get a TB syringe and an 18-gauge needle, and I just shove the needle in there and suck up a little bit of the glue. You don't need much at all. I mean, you don't need much at all. And then I take off that 18-gauge and I put a 30-gauge needle. Now you need to clear out some of the epithelium around the perforation, or else the glue won't stick. And if there's any leak at all, I mean, if it is not dry, it won't work. If there's a leak at all, there's going to be a little channel that forms under the glue, and you'll just see the leak at the edge of the glue. So, it kind of depends on the situation. Some of them, the AC is collapsed, and so there's no leakage, and you can just go on ahead. You can put a small air bubble in the perforation sometimes and get it to stop leaking, or viscoelastic. Doesn't always work, but it can. I've even had some that I intentionally flatten the AC to get the glue to work, and then, how long does it take to reform the anterior chamber, Dylan? 100 minutes. It takes 100 minutes. So you can have them actually, hang out for a couple of hours, and you'll actually see it then reform. But if it is not bone dry, this won't work. Of course, you want to put a bandage contact lens on top. That glue is very rough on the backside of the eyelid, and the eyelid can scrape it off, and you don't want that. So with that 30-gauge needle, you can deliver a tiny little area. You can deliver it too small sometimes and have to add a little more. The other ways I've done it, by trying to put a drip on different ways, usually puts a large glob that you can't control very well. So I like this technique a lot. Now, how long do you leave the glue on? I leave the glue on until the eye spits it off. I don't ever try to take that glue off, really, as long as something weird's not going on and I don't have to. But usually once the cornea scars underneath, it will push, and the epithelium grows underneath, it will push the glue off for you. Gunnarsson would be a great one also in this. This would also be a great one for a Gunnarsson. Patch graft, cornea transplant. One of the big problems with cornea transplants in these eyes is even though the central cornea is going to be is not going to have nerves, at least the periphery usually does, and sometimes cornea transplants don't survive well on these eyes. At least a lot of them don't. It's a little bit, it's tricky. But yes. Here's a patient who got sent to me. Now, she came in because she really did not like, she had an extended depth of focus lens placed in her left eye and really didn't like her vision out of it. But it looked great. The surgery looked great. Well, when I got to looking at her, this main yellow is actually just her pupil, but if you can see, she's got a large amount of SPK. And when we look at our topography, it's very irregular centrally. And then also our Myers are very, very irregular down low, inferior cornea. And so I got to taking more history, and she had had trigeminal nerve ablation. And hers actually was a neurotrophic keratitis. I actually ended up putting an extended depth of focus lens in her other eye to match this, and she liked that. So it was the cornea causing the problem the whole time. Now with her, this is only stage 1 disease. She has no scarring, just epitheliopathy. And I've tried heavy dry eye therapy, amniotic membranes, oxervate, and her vision just basically kind of wavers from 2025 to 2030, and she'll basically tell you there's never been any improvement. Now, on topography, with all these treatments, we do see improvement. The cornea is more regular centrally. This was kind of during mid-heavy treatments, and this is her last one. And you can see it improves, and then it gets worse. It doesn't quite go back to as bad as where it started. So that's also one of the big problems with this disease is even in mild disease, sometimes it doesn't want to respond to anything you do. It's a very, very difficult disease. Now, these are some treatments that I have not tried, but they're coming out and showing some real promise. So topical insulin. Topical insulin is a very interesting one because it's definitely been shown to be very effective in closing resistant epithelial defects. It's also been shown to reduce scarring after corneal ulcers. In research, this is a very promising thing, and it seems like a very easy thing to get, and I have not been able to find a compounding pharmacy who will make it for me yet. If anyone has used this and knows where to get it compounded, I would love to know because this has really been shown to work quite well. And it's worked in eyes that are resistant to contacts, membranes, tarsorrhaphes. And then corneal neurotization. This is where you actually you surgically bring nerves back to the cornea. You can put the nerve, you're taking a nerve elsewhere in the face that's still working and routing sensation over to the eye where the nerves are not working. You can use well, let me go to this next one. So you can either do a direct approach where you take a nerve like the supraorbital nerve or the supratrochlear nerve and take a branch and put it down around the cornea subconjunctivally near the limbus and let it and kind of reroute the sensation. You can also take a nerve graft, either from the patient or from a cadaver, and connect it to one of these nerves and bring it over to the limbus area. This is a very interesting thing. I've seen some talks on it. I personally don't have a patient that's had it. Has anybody here had any patients who's had this done? Have you? Did it work well? Yeah, it's a very interesting thing. It's very interesting. So you're basically creating, a new, just a new conduit for these nerves to grow back through a lot of times with this, if you're doing the indirect approach. That's a great question. Pardon? Okay, he said at oculoplastics, which makes sense, getting to the, yeah. The only places I've heard it done is large tertiary centers. I don't know for sure. Is yours, no? How about that? How about that? Wow, yeah. That's fantastic. But yeah, that would make sense, getting an oculoplastic doc to do it. That's a great idea. And this is in one of the studies from neuronization where you can see corneal with normal nerves, and then after neuronization, they're regrowing into the center. All right. So the studies with this have shown that sensation improved in 80 to 83% of patients. Sensation was not fully restored. There was still a deficit, and it took about 6 months for the sensation to improve, which makes sense when you're trying to grow nerves. So just once again as a reminder on what this disease is, kind of how to treat it, the opposite of love is not hate, it's indifference. This is by Eli Wiesel, and he was a Nobel Peace Prize recipient. References. Get that later. Questions? Yeah, that's a great question. So the question was, if a patient has had an ablation for trigeminal neuralgia, would oxervate work well? I agree with you. This is not a surface neuropathy, it's deeper. It's back at the trigeminal nerve ganglion. So I don't know for sure. I haven't read anything dividing it out with that, but I agree with you. I think that oxervate would probably be less effective with that than when you're talking about things like zoster or things that attack more the nerves at the eye. Yeah.
Great talk, Will. What's your experience with scleral contact lenses in patients with neurodermatitis?
That's also a good one. Scleral contact, I love scleral contact lenses. I do. They provide, and it kind of depends on the fit, of course. There's all kinds of different ones. But they can provide basically an underwater environment for that cornea. Now, those work well on the eyes where tears work, but patients can't keep them up. In some patients, that like the patient with the cornea transplants, I doubt it would close her epithelial defect because just nothing's worked on it. But my plan with her is going to be a bandaged contact lens and a prophylactic antibiotic. You could put a drip of antibiotic in a scleral contact lens and put it on the eye, and that would create the same effect as a bandaged contact lens, but have better vision because at least the fluid underneath the scleral contact is going to fill in the irregularities from the epithelial defect and create a more smooth surface. But yeah, I like the scleral contact in these eyes where the epithelium does close with treatments. Does that make sense? When the epithelium just won't close, I still like it, but I'm going to try some other things first.
So how long would you go, what length of time would it open for a non-closing epithelium? How long would you go until you try something more,
So the question is, how long would you go with a non-healing epithelial defect before you try something more? I don't have a regimented answer on that. It's very different in different ways. So for instance, my transplant patient that hers won't close, her eye is always quiet, and that epithelial defect never gets worse, it just doesn't get better. And it's been there for 10 months before I ever met her. Before I ever met her, it was there for 10 months. So with her, I don't really want to do a Gunderson flap because that's going to take her vision away completely. Now, if she starts ending up with infections, I'll change my mind on that. But so far, she's had 0 infections. They've all just been sterile ulcers. Yeah, but yeah, that's a great question. It's really patient dependent. Extremely patient dependent. And that's the other problem with this disease is the sensation's different in each of these patients. Some of them have 0 sensation, some of them have a little, and it kind of changes how things go. I've not used it. So in mine, I guess I don't find it in mine, but I just don't have experience with it. Yeah, so I don't have a great comment on that. I'd like to hear yours of it after the meeting or after the talk, and so we go with that. Yeah. Oh yes. Yes. Sorry. Do you ever see reactivation of HSV after a membrane graft. Yes, but I can't tell you it was from, I don't know if it was from the graft or not. They can just reactivate anyway, and especially, HSV tends to kick you when you're down already. And so these eyes that you're putting amniotic membranes on, they have a problem to begin with. They've got an epithelial defect, or maybe they've got a bacterial infection from one. And so I've definitely seen reactivation of HSV after an amniotic membrane graft, but I don't know if it was just going to happen anyway. Now, if I put on an amniotic membrane and that eye does not do well with it, I'm likely not going to just keep doing that. When that happens, then I go, okay, well, let's not do amniotic membranes. Let's try other treatments instead. Oh, we got 3 minutes.
So you're talking about the zoster simplex. What's your course of antivirals?
Oh yeah. With HSV, I keep people on antivirals long term. If they just have one reaction, I will eventually take them off of antivirals, but I usually leave them on there for many, many months. One reaction, at least my patients, I usually keep them on it for at least 6 months. Lots of different ways, and a lot of it depends on costs. Most of the time, the treatment for it for valacyclovir would be 500 milligrams. I usually use a gram, and I use it 3 times a day. And I just give them the zoster dose, even with HSV most of the time. It's well tolerated. Those pills, Famvir, acyclovir, and valacyclovir, seem to be very, very, very well tolerated. I have to watch out if somebody has renal disease, but not so much because it's going to cause a problem, but you could overdose them because they can't eliminate it. But those drugs, I basically will keep people on them unless they get a side effect from it. But I keep a lot of people on it, just constantly. You have more than one episode, I'm going to try to have you on it for years, maybe even the rest of your life.
You're saying that when I use it, you got 800 milligram acyclovir, you got 400 milligram acyclovir. You're trying to do it twice a day?
So with an activation, like the valacyclovir, I'll do 3 times a day. But then once the epithelium is closed, I lower it down to once a day. Now with acyclovir, the HSV dose is 400 milligrams 5 times a day. The zoster dose is 800 milligrams 5 times a day. I'll lower them down to twice a day. Some patients lower themselves down to once a day with acyclovir, and if it seems to be working, sometimes I ride with it.
Now, for prophylaxis, if you have recurrent HCV with the valacyclovir, if you're going to put them on that for a year, are you doing like 1 gram a day or 500 milligrams a day?
I'll usually start with 1 gram a day, and then eventually, with refills, I'll lower them down to 500. But I'll keep them at 1 gram for a long time. Yeah. All right. Well, thank you.
I have no financial disclosures to discuss, and I would thank everyone at Regeneron for their help with the study, as well as for helping put together this slide deck here today. So let's just jump right in here and review our VEGF signaling pathway. VEGF A, B, and placental growth factor are members of the VEGF family of angiogenic factors that can act as vascular permeability agents on endothelial cells. They act via 2 receptor tyrosine kinases on these endothelial cells. Placenta-like growth factor itself only acts on VEGF receptor 1. So elevated levels of VEGF is strongly correlated with disease progression, vascular leakage, and hypoxia. Aflibercept is a fully human recombinant fusion protein that inhibits the activation of VEGF receptors by binding VEGF A, B, and placenta-like growth factor. Overall, this is a fully human recombinant antibody fragment, and that's thought to blunt immunogenicity. Overall, aflibercept has a pretty high binding affinity compared to other anti-VEGF agents on the market. And you can see up there, there's just a cartoon demonstration of that molecule. Again, binding of aflibercept to VEGF A, B, and placental growth factor reduces pathological activation of these VEGF receptors, therefore blunting hypoxia, neovascularization, retinal ischemia, and macular edema. Overall, 2 milligram aflibercept has demonstrated efficacy and safety in over 11 clinical trials for AMD, DME, and vein occlusion. So let's kind of jump in here for the nidus of Regeneron's 8 milligram program here. And basically, increasing molar doses of anti-VEGF may improve anatomic and visual outcomes with greater durability. And this was shown with drugs like brolucizumab when we compare ranibizumab 0.5 versus 0.3, as well as with aflibercept and now faricimab. So basically, in preclinical data looking at rabbit models with induced hypoxia and specifically looking at fluorescein angiographic leakage, using a 4-fold higher dose of aflibercept blunted a response or a return of vascular leakage by about 5 weeks. So this was the nidus then for this aflibercept 8 milligram program, which I'm going to run down for you here. The phase 2 study that kicked it off was the Candela study, which was a multi-center randomized single-masked 44-week trial, proof of concept comparing one-to-one treatment-naive patients, comparing 2 milligram aflibercept with 8 milligram aflibercept with 3 monthly loading doses, and then treatment at 20 and 24 weeks with PRN treatment. Overall, through this phase 2 study, there was favorability for 8 milligram aflibercept when it came to vision, central retinal thickness, and had an overall comparable safety profile. So that brings us with what we're going to talk about today, which is the results of the Pulsar and Photon studies, the phase 3 clinical trials for these drugs. And of note right now, enrollment is undergoing for the Quasar study, which is high-dose aflibercept for the treatment of macular edema secondary to retinal vein occlusion. All right, let's jump right into it. And guys, this is going to be data heavy, but I'm going to try to get through both of these talks quick so we can get to our break and back outside here. So Pulsar was a multi-center randomized double-masked control trial. Patients were randomized 1:1:1 to receive aflibercept 2 milligram every 8 weeks, 8 milligram aflibercept every 12 weeks, or 8 milligram aflibercept every 16 weeks after 3 monthly loading doses. Of note, the 2 milligram group, that's the current FDA label. Primary endpoint of the study was at week 48, looking for non-inferiority and best-corrected visual acuity. The study went out to 96 weeks with a current extension study that's still going on. We're not going to belabor the inclusion criteria here, but these were patients over the age of 50 with an active choroidal neovascular membrane, intraretinal fluid and subretinal fluid that was present, overall good vision. Exclusion criteria is up there for your own edification, but anything that would confound the results of this study. I think a key thing to understanding this study and the utility of this study is the dosing schedule and the dose regimen modification that was built into this study. And this is kind of just diagrammatically showing what we already talked about. All patients received 3 monthly injections, but patients in the 2 milligram cohort remained fixed through 96 weeks with injections every 8 weeks as the control, whereas the patients in the 8 milligram cohorts were extended out to this 16 and 12-week cohorts. However, beginning at week 16 in year 1 and year 2, patients were eligible for dose regimen modification, meaning that if compared to week 12, they lost 5 or more letters, had active disease, and had some increase in central subfield thickness by 25 microns, they would have their interval shortened to 8 weeks. After week 24, everyone else could have their dosing regimen interval shortened by 4 weeks to a minimum of 8 weeks throughout the entire study. At year 2, patients were eligible for dose regimen modification with extensions, wherein if they lost less than 5 letters of vision, had a flat macula on OCT, they could have their extension intervals go out to 4 weeks for a maximum of 24 weeks. Overall, when we looked at randomization, it was pretty equal among all cohorts. Average age was about 75 in this cohort with a slight predominance of women. Overall, 86% of the patients completed this study through 96 weeks. Looking at our primary efficacy endpoint here at week 48, both aflibercept at 8 milligram groups achieved non-inferiority compared to 2 milligram aflibercept dosed every 8 weeks. And this was carried all the way out here through week 96. Again, non-inferiority throughout the entire study. When we look for clinical relevance, what we would expect if someone was on an extended dosing interval, we would expect fewer and fewer injections with time. And you can see with this dose regimen modification schedule out to week 96, this is when we really start to see a gap in the number of injections given per year. I think when we look at the ability of this drug to allow patients to maintain their dosing intervals through week 48, and again, this was before patients were eligible for dose extension, 79% of the patients assigned to the Q12 cohort were able to maintain that interval. 77% of the patients in the Q16-week cohort were able to maintain that interval. And these effects were carried out with time all the way through week 96, with 87% of the patients receiving higher dose aflibercept assigned to that 12-week cohort, maintaining 12 weeks or more, with 41% of these patients being able to have a last assigned interval of greater than 20 weeks for treatment. Again, this was seen, this great result, with the 16-week cohort. 78% of these patients were able to maintain this dosing interval, with 53% of the patients being able to get out beyond 20 weeks or assigned to 20 weeks for treatment. Again, this is just a summary slide of what we just looked at, that last assigned group. But when we looked at the very end of the study, or last completed visits here, overall in the 12-week cohort, 31% of patients were able to have a 20-week visit. Among the 16-week cohort, 48% of the patients were able to have a visit out to 20 weeks, which kind of shows great durability. When we look at secondary key endpoints here, central retinal thickness fluctuations were pretty equivalent throughout the study. Safety is almost a sure thing we need to look at, especially after brolucizumab came out and scared everyone. But overall, there were no cases of severe hemorrhagic vasculitis. There was one case reported of ischemic optic neuropathy in the 2 milligram cohort. Rates of intraocular inflammation were pretty equal among all treatment groups. And then finally, I don't know if many people give injections here in the room, but 2 milligram aflibercept is dosed at 0.05 mLs for an injection. 8 milligram aflibercept is a 0.07. So a key concern here would be IOP spikes. But when we look at the proportion of patients pre or post injection with IOP spikes greater than 35, it was pretty equivalent among all groups here. So in summary, for just the pulsar portion, aflibercept 8 milligram maintained similar vision and central retinal thickness through 96 weeks compared to 2 milligram aflibercept dosed every 8 weeks. 87% of the patients in the 12-week cohort achieved dosing intervals of 12 weeks or more, with 41% of these patients being out greater than 20 weeks. In the 16-week cohort, 78% of these patients were able to achieve that 16-week cohort, with 53% of these patients being out over 20 weeks. Overall, a very safe, comparable profile compared to the standard of care 2 milligram aflibercept. I know really data heavy here, and let's jump right into Photon. Very similar study design. Patients were randomized 1 to 2 to 1 here to receive 2 milligram aflibercept every 8 weeks, and then higher dose aflibercept every 12 or 16 weeks. Key difference here is if you guys aren't giving these injections, the FDA label for indication for DME is 5 monthly injections and then recommended dosing every 8 weeks. Again, primary key endpoint here is change in best corrected visual acuity, non-inferiority at week 48, extension study out to 96 and beyond. So this study included patients over the age of 18, type 1, type 2 diabetics, had to have DME with a central subfield thickness of greater than 300 microns. Overall key exclusion criteria: anybody with proliferative disease, anyone who had laser or prior anti-VEGF agent in the last 3 months, or a periocular or intravitreal steroid in the last 4 months were excluded from this study. This is a very similar graph that you're going to see here, and this just harps on, again, this dose regimen modification that was included in this study to really highlight and tease out the durability of higher dose aflibercept. So again, in this study, the 2 milligram cohort received 5 monthly loading doses followed by a fixed interval of every 8 weeks, wherein the higher dose groups were just pushed out to 12 and 16 weeks. Beginning at week 16 and week 20, patients were eligible for dose regimen modification, wherein if they had lost 10 letters of vision or more and had an increase of 50 microns on OCT, their intervals were shortened to the 8-week interval, and then at year 2 were able for extension. When we look at year 2, everybody in the study was eligible for dose regimen extension if they lost less than 5 letters compared to week 12, as well as had a central subfield thickness of less than 300 microns. These patients were then able to have their intervals spread out 4 weeks at a time for a maximum of 24 weeks. Again, good randomization here. Overall completion rate in this study was about 81%. Again, this included treatment-naive and treatment-burdened patients. Overall, 84% of the patients in this study had vision worse than 20/40. Looking at our key primary endpoint here, change in best-corrected vision, non-inferior to 2 milligram aflibercept at 48 weeks, as well as all the way out to 96 weeks, showing sustained efficacy. Some very similar graphs as we saw in our talk for wet AMD here. Anyone who's on extended interval should expect to have fewer injections, but with this dose regimen modification, we really see at 96 weeks this separation in injections, about difference of 6 if you look at the fixed cohort from 2 milligram to our 16-week cohort. I think the key here is the durability. At week 48, 91% of the patients who were assigned to that 12-week dosing were able to maintain their interval. 89% of the patients in the Q16-week cohort were able to maintain that interval, and these effects were carried out all the way through week 96, with 88% of the patients in the Q12 cohort being able to maintain that interval, with 43% of these patients having a last assigned injection of 20 weeks or more. In that 16-week cohort, 84% of the patients maintained this 16-week dosing, with 47% of the patients having a last assigned treatment interval of greater than 20 weeks. Next slide again on the right-hand side is just a summary of what we talked about, but I think the key take-home point here is that you people aren't practicing in the vitreoretinal space here, as we're doing such frequent injections on patients. Anything to get an extension here is a godsend. But looking here at the proportion of patients here last assigned to treatment greater than 20 weeks, specifically when we look at this 16-week cohort, 47% of these patients being able to be extended out that far. One thing we'll notice here with secondary endpoints here is change in central retinal thickness. And the one thing I'd like to point out here is when we look at our 8 milligram cohort, every 16 weeks, we do see this larger peak and trough effect on OCT central retinal thickness. And that's what we would expect with a longer duration between visits. However, we do see with time this up and down peak and trough does start to flatten out. Overall, safety was comparable among all groups. Comparable intraocular inflammation among all cohorts. No cases of severe hemorrhagic occlusive vasculitis were reported. Similar IOP spikes all the way through week 96. And we're going to go over some real cases here, but again, really data heavy, so I know this is really boring. But aflibercept 8 milligram every 12 weeks and 16 weeks achieved similar results with vision and central retinal thickness through week 96. Through week 96, 88% of the patients in the 8 milligram 12-week cohort were able to maintain their dosing interval. 84% of the patients in the Q16-week cohort maintained their interval, and a large proportion of these patients were able to have their intervals and dosing extended out even further. So right now, the FDA approval for 8 milligram aflibercept is to provide 3 monthly loading doses, followed by dosing as frequently as every 8 to 16 weeks. But I think the key strength here is that this study demonstrated a large amount of patients were able to have greater dosing intervals than 12 to 16 weeks. So as a practicing retina physician and surgeon, this is key and vital. And I think it's key to understand, this study wasn't aimed or powered to look at non-inferiority out at 20 and 24 weeks. However, it does give us some pretty good clinical guidelines for dosing our patients. So before we jump on to our more controversial topic, I'm just going to share a few cases with you on how this drug is doing in the real world. So we'll start off with some diabetic cases here, and I kind of picked out some of the toughest of the tough recalcitrant patients. First one is a 78-year-old white male, history of PDR. Currently his A1C is very well controlled. This gentleman has a prior history. I had to take him for a pars plana vitrectomy, for endo laser, for a history of a vitreous hemorrhage. But kind of just check out his resume here. He's had 18 prior bevacizumab injections, 32 prior 2 milligram aflibercept injections, and then 3 injections of faricimab or Vabysmo, perpetually on this 4 to 6 week treatment interval. I thought he would be a great case for a high-dose aflibercept. Looking at the top, this patient at visit 1, vision is 20/30, and we see this large amount of edema. Injected him, had him back 4 weeks later. Vision improved, and we can see we already have some resolution of this edema. And just like in the real world, I said, hey, bub, come back in 4 weeks. He showed up 8 weeks later. We had a return of this edema, but his vision was maintaining. Gave him his 3rd injection, but I decided to keep him on a 4-week interval since he really didn't stick to protocol. At that 4th visit, his vision had improved to 20/20. We really see on this OCT he has near resolution of this edema, so we decided to give him a trial of pushing him out to 8 weeks per label. Pushed him out to 8 weeks. His vision is doing great. Symptomatically, he's doing well, but we do see there is some return of this edema here. So in a patient like this, I'm probably going to keep this guy dosed at about an every 8-week interval. I'll try to extend him out to see how he does with that edema. But again, this is a very recalcitrant patient here. Dr. Hypes, you're hoping to get patients extended out, aren't you? Case number 2 here is a 58-year-old Hispanic male, history of PDR, very poorly controlled. This gentleman's on home dialysis, has gastroparesis, and actually works at the gas station next to our clinic. He was in one of my former studies for Kodiak Sciences, this KSI 301 intravitreal injection. This study got terminated early. And after that, he had a huge regression here. His insurance mandated through step therapy that he go back to bevacizumab. Had to do 5 Avastin injections until I could get approval for 2 milligram aflibercept. But during that time, we lost so much ground. This patient lost so much vision. So by the time I had him certified for high-dose aflibercept, he was really behind the 8 ball, and we can see vision had decreased to 200. He had a minor vitreous hemorrhage. We have a large amount of subretinal fluid on the top OCT, as well as a large amount of edema. I injected him with his first dose of 8 milligram, came back 4 weeks later, and we can already see some of this subretinal fluid is resolving, some of his edema is resolving. Had him back for another 4-week visit, vision is maintaining, subretinal fluid still persistent but improving, edema improving. And then per protocol, pushed him out to 8 weeks, and with extension here, his vision is maintaining, resolution of that subretinal fluid, but he still has persistent central DME. So again, a case like this, very recalcitrant. I'm going to keep him on an 8-week schedule and then hopefully get him extended out more and more. But this is just showing in the toughest of patients you might see in your clinic the efficacy of this higher dose molecule. Want to finish this talk with just 2 cases, one treatment non-naive patient with wet AMD, 86-year-old white male, very aggressive treatment history, 12 prior bevacizumab, 23 prior 2 milligram aflibercept, perpetually on a 6-week interval, couldn't get extended out any further with return of intraretinal fluid and subretinal fluid. Just like the real world, this gentleman from health was lost for 5 months and came back with decreasing vision and fluid. I thought he would have been a great case, but I couldn't get approval for 8 milligram aflibercept until December. And here you can see there's not a massive amount of subretinal fluid at his first visit, but he's got poor vision, shaggy photoreceptors, and a small little PED there. Gave him his first injection, vision declined, and we see a shift now in this subretinal fluid pocket temporally. Had him back again, vision declined again, but we have resolution of this subretinal fluid. Had him follow up with his optometrist to get a manifest refraction, and that probably did more than the 8 milligram aflibercept, brought him back to 20/60. But at least this gentleman here is remaining without fluid. He's at an 8-week interval, and I'm going to try to get him extended out. But again, just showing in these chronic recalcitrant patients, we're getting pretty rapid resolution of subretinal fluid. Finally, this is a patient I saw relatively recently for his last visit, sent in for new onset wet AMD in his left eye. Baseline vision of 20/40, and we can see that this patient has a large fibrovascular pigment epithelial detachment, large amount of subretinal fluid there. Injected him for his first visit, and lo and behold, didn't really do too much. He actually has worsening subretinal fluid on that second OCT. Told him to stick with the game plan. We'd have him back in 4 weeks. At that third visit, you can see that pigment epithelial detachment's collapsing and that subretinal fluid is resolved. So that was his 8-week visit. I've already kicked this guy out to 10 weeks, and I'm going to probably be doing pretty typical, like a treat and extend type of protocol here for this disease. So we'll move on here. I'll take any questions on high dose of aflibercept if anybody has anything. Otherwise, we're going to get into a more controversial topic. Hypes you use in any of this drug? Go ahead, sir.
So what's between Eylea and Eylea HD? Is there a cost difference?
Yeah, about $250. But if you look at the cost savings, right, on the free. Yeah. Sure, yeah, and that's the true difference. But I think, when we talk about these high-value drugs, the biggest thing we have to remember is the cost to Medicare and Medicaid. And I hope with drugs like this that at least we'll be getting some health care savings, if we can get patients extended out, more and more. Sure. Sure. So when I counsel my patients on this, I tell them this is the exact same drug. It's just a 4-fold higher molecular dose, right? So biggest with any intravitreal injection, 1 in 5,000 to 1 in 10,000 injections, risk of endophthalmitis or retinal detachment. However, through these clinical studies, there wasn't any cases of, basically a vasculitis. And I think this comes down to specifically aflibercept is a fully recombinant human, molecule, right? So we don't get that. And when you look at brolucizumab, when this drug rolled out, right, we had several cases of people having severe occlusive vasculitis who lost vision. And, drug's still on the market, but that's pretty much, the death of that drug when you see that in the retina community. So I've probably given 300 or more injections with this higher dose medication. I haven't seen any signs of intraocular inflammation. Yeah. That's a great point. It's a great point. Because of FDA labeling, right, you can't dose that any fewer than 8 weeks. And so in our clinic, luckily, we're able to stock a huge supply of samples. That's just our nature. So I'll try to keep people on that higher dose of medication if they can. But otherwise, most patients, I'm just going to switch back to that 2 milligram or add on ancillary, Ozurdex, Iluvien, things like this to try to get patients extended up. But that's a great point. Hypes, you using any of this yet?
Yeah, so we were a clinical trial site for all of our studies. So I've injected it a lot, and it's available, still injected a lot. It's great for durability. For me, if you can't get someone to 8 weeks on HD, I take them back to 4 weeks at 2 milligrams. Yeah, because to me, it's a durability thing, right? That's the most important thing for me is that we're trying to get people's shots moving apart because Eylea, for the most part, almost everybody was great.
Mm-hmm.
So the whole point is to try to get more distance between the injections, so if you can't do that.
Yeah, and in the clinical data, there's pretty much a subset of patients, probably around 8% or 10% of patients who are just the worst of the worst recalcitrant patients that probably can't get out.
But this did bring up a good point, too, because you kind of see that peak and trough of
Sure.
CST,
Mm-hmm.
and for a lot of us, we're used to, if you see fluid come back at an extension that's, say, too long, short it back up, to try to get that OCT looking better. For you, since we have this data, have you started tolerating a little more fluid on the OCT if the vision's stable at an extension period?
So I think specifically when you look at diabetic macular, DME, versus AMD, I'll tolerate fluid if, vision, remains well. And that goes for even looking at people, if you look at, protocol V, right, looking at patients with good vision and diabetic macular edema, I'll observe edema for 2 years without treatment, if they don't need to. But in your case specifically you're talking about, I'll tolerate a little bit more fluid if vision maintains. But you also bring up a great point here, they had a pretty aggressive dose regimen modification here. And in the real world, you're not going to probably stick to that, clinical protocol, but for sure in wet AMD, there's, zero tolerance for subretinal fluid or intraretinal fluid. And in most practices, that's pretty much the standard of care.
Just a quick question.
Yeah.
I'm a comprehensive, but I'm seeing mostly my patients need Vabysmo rather than high-dose Eylea.
Mm-hmm.
And so can you
Mm-hmm.
Is there any like mix and matching of these agents? Like
Sure.
are they 8 weeks and then 8 weeks later do a Vabysmo or?
Sure. Usually I think the thing is we don't have one blanket statement, treat, every case individually. I mean, I have patients who are getting faricimab in one eye and Eylea in the other eye just based on their response, alone there. So yeah, we do follow that mix and match. And I think when you're talking about, which drug do you choose faricimab versus higher dose of aflibercept? And really it just comes down, one, these days with what insurance will pay, mandated step therapy, right? These drug companies typically pay insurance companies to put them on their formulary at the top of their peer. If you look overall, I think Regeneron and Eylea is the industry leader. They probably have the largest market share, and that's just based on their long-term history here. Personally, with faricimab, when faricimab came out, I was all gung-ho looking at Tenaya and Lucerne for wet AMD in these trials. I was all pumped. But I've been underwhelmed overall by faricimab. I think it works great in some patients, but in other patients it's no better than 2 milligram aflibercept. I personally don't think there's an Ang2 inhibition there. Personally, my opinion is Ang2 probably doesn't do anything whatsoever. The studies weren't designed to actually specifically look at Ang2, but I could talk forever on that. But if I can, yeah. If I have carte blanche to treat whatever I wanted, that's what I would put in my own eye if I had it, because it has just that rapid drying effect. So if insurance approves it, I do, yeah. All righty. Let me try to get out of this. All right. So this next topic, we'll try to keep this light and go through it. How many people here are aware that there's now 2 intravitreal injections that are available for the treatment of geographic atrophy secondary to AMD? Okay, so people are aware. All right. Do you guys refer many patients in for that treatment? And are there providers you're referring to engaging in these treatments? So. All right, it's a very controversial topic here, and we're going to kind of go over this in a little bit of greater detail, but pretty much the summary is that there's 2 camps of people, or 3. 1 is I wouldn't put that in my eye. 2 is that snuffing out any form of GA is the most beneficial thing possible. And then the 3rd camp is watch and wait, because this is the wild west of retina right now. And again, this is an 8-bit theme. Mike Tyson's Punched-Out theme, and if you don't understand the reference, you might not have grown up and played video games in the 80s and 90s, so I'm sorry. No financial disclosures here. Let me give you the quick roadmap here. We're going to review AMD and complement inhibition, briefly talk about the clinical trials and the highlights here, and then talk about the safety of these things, because as King Hippo says, there's no such thing as a free lunch. So let's get down to it here. Age-related macular degeneration is the leading cause of vision impairment in the developed world among patients over the age of 50, characterized by drusen, RPE pigmentary changes, and then in the late stages, geographic atrophy. There's been very extensive research into this field and subject. However, to this point, we have very, very limited therapeutic options. We know that there are genetic associations with this disease, and we're going to be kind of harping a little bit more on complement factor H here. Other genetic alleles probably account for about 75% of the risk overall for dry AMD, as well as environmental factors. Just remember, geographic atrophy is chronic, it's progressive, and it can be the end stage of either the exudative or non-exudative form, characterized by the sharply demarcated areas of RPE dropout. Just remember, this is a progressive disease, and among patients with it, about 31% of patients can have rapid vision loss with 3 lines of vision loss in 2 years. Over the age of 50, the prevalence of this disease quadruples every 10 years and accounts for about 20% of blindness. And in case you've lived under a rock or never looked at a retina, up here, a photographic representation of early AMD, intermediate, and on the far right, an example of geographic atrophy as well as a choroidal neovascular membrane. This is kind of here for your own edification. There's many grading scales for fundus autofluorescent lesions with GA. On the bottom right here just shows a clinical patient that has progression on fundus autofluorescence, and you see this evolution of this geographic atrophy lesion surrounding the fovea, and an OCT showing subfoveal atrophy above that. So complement systems here, this dysregulated pathway plays a huge role, and this is the whole thought of why we should target this pathway for drugs. We all remember from medical school we have the classic alternative and lectin pathway that basically all converge down to the formation of a membrane attack complex. That's what actually causes apoptosis and cell death. We know that patients with AMD have these elevated or increased levels of complement components. Here's that dreaded pathway that we all had to remember at one time here. But the key thing here is everything converges on this C3 pathway to this downstream effect to the formation of this membrane attack complex. Today, the drugs we're going to be talking about, one is called pegcetacoplan. Industry name is Syfovre. That's a C3 inhibitor. ACP, or avacincaptad, also Izervay. This is a C5 inhibitor, and we'll go over this here a little bit in greater detail. I don't know why I thought it was so fun to make this slide if you ever played Tyson's Punch-Out. But overall, pegcetacoplan was the first to the market, also the first to red flags with reported cases of severe occlusive vasculitis. To date, over 60,000 doses have been administered. Avacincaptad, or ACP, came out in August of 2023. It has a J code as of April Fool's Day 2024. Next two slides I have here are really busy. These are just key summary slides, or the slides that if you were to take a photo of, it would tell you everything about these two drugs in 2 minutes, and then you could completely tune out for the rest of the day. But again, I just want to belabor pegcetacoplan, C5 inhibitor. ACP is a C5. I might have mixed it up. Pegcetacoplan is C3. Overall, looking at all of these clinical trials, the summary is they do show reductions in geographic atrophy based on fundus autofluorescence, albeit very, very moderate. Other key takeaway point here, executive summary slide, no such thing as a free lunch. When we inhibit complement, we induce choroidal neovascular membrane formation. And this is one of the scariest things about these drugs. As you look here, with time, the proportion of patients who develop wet AMD or choroidal neovascular membrane increase. And we're going to belabor a little bit later in this talk, specifically with pegcetacoplan, the 14 cases of severe retinal vasculitis as well as ischemic optic neuropathy. So retire, give up, make a run for the door. Nah, just go train with Al Roker. Type in your Regeneron password for the Wi-Fi and turn out. I don't know, I always thought that his trainer looked like Al Roker growing up. So again, pegcetacoplan, FDA approved February 2023, first on the market C3 inhibitor, very large, very bulky molecule, FDA approved for injections every 1 to 2 months. ACP, avacincaptad, approved August 2023, this C5 inhibitor. Again, a very bulky molecule, but one key note to take in here is that the labeling right now per FDA is every month treatment for 1 year, and you might be like, well, why the heck would you ever design or have a drug like that? It's because they were trying to get this drug, from my understanding, to the market and submitted 1-year data. Right now, they're submitting 2-year data, and this labeling should change very shortly here in the near future. So let's briefly run down these clinical trials, and we're just going to hit the key highlights to get everyone out of here. But in the pegcetacoplan trials, Oaks and Derby were parallel double-masked randomized clinical control trials. 4 arms, 2 active treatment arms with intravitreal injections every month, every other month, sham monthly or every other month. Primary endpoint was just change in geographic atrophy based on fundus autofluorescence. One key differentiator to the GATHER1 and GATHER2 studies that we're going to talk about is that this involved subfoveal involving lesions and non-subfoveal involving lesions. Another key point in this clinical trial is that they did allow patients to remain in the study if they developed choroidal neovascular membranes. However, they required intravitreal injections of anti-VEGF agents. Again, the rationale for including both subfoveal and non-subfoveal involving lesions is that it's thought that non-subfoveal involving lesions advance more rapidly. We compare and contrast this to the very busy organization from the GATHER1 and GATHER2 trials with ACP. GATHER1 study was a combined phase 2, phase 3 study that had 2 arms, basically dose escalation study at looking at 1 milligram, 2 milligram, and 4 milligram treatment, dosed every month for 12 months all the way out to 18 months compared to sham treatment. GATHER2 study looked only at 2 milligram ACP dosed every month versus sham for 12 months, and then after 1 year of completion, patients were re-randomized to either remain on monthly treatment or go to every other month. Again, primary endpoint is change in geographic atrophy lesion based on fundus autofluorescence. One key differentiator for this study I want you to put in your back pocket is that if patients developed a choroidal neovascular membrane in this study, their data was censored, meaning that they were not included in further analysis. Again, this just highlights in the Gather 1 and Gather 2 did not involve central involving lesions. And so I guess this is where the controversy starts, and I'm just going to add in my key points and issues with some of these studies that get approved by the FDA. At 12 months for pegcetacoplan, the OAK study showed a 21% reduction and 16% reduction with monthly and every other month treatment compared to sham. Very modest reductions. However, the Derby trial failed to meet its primary endpoint. And in any other clinical trial, right, if one of your parallel arm studies does not meet significance, well, then back to the drawing board. However, a priori, they designed this study to allow pooled data among both Oaks and Derby. The FDA approved it, and they did show a 17 and 14% reduction with monthly and every other month treatment with this pooled data that then led to FDA approval. We now have 24-month data from Oaks and Derby that show continued reductions here. 22% and 18% in Oaks with monthly and every other month compared to sham, and 19 and 16% with monthly and every other month compared to sham. Again, sustained reductions, very moderate, but I think what you can start to see even on the graph there on the right is that our sham treatment arms are continuing this linear slope of GA progression, whereas we're starting to see a blunted response with active treatment. And then they've completed the 3-year study, Gale Open Extension, where 80% of the patients remained in this study. Patients remained in the same treatment arm. However, patients who were in the sham cohorts were now eligible for treatment every month or every other month. Overall, they showed sustained reductions in GA of 35% and 24% with monthly and every other month treatment compared to sham. And this is just a graphical representation here. But I think one thing we really need to remember here is how this actually applies to our patients. When we look at the graph here at key secondary endpoints, every cohort lost vision. So if you were getting treatment every month, every other month, you still lost vision, and it's pretty comparable. When we look at the results very briefly from the Gather 1 trial, a very small number looking at 2 milligram ACP, about a 35% reduction versus sham treatment. But the key thing here to remember is that the 2 milligram ACP group still lost nearly 8 letters. Sham group lost nearly 9.3 letters. Looking at the results from the Gather 2 study in year 1, a modest 17% reduction versus sham. And when we look at the 2-year data for ACP, where these patients were re-randomized to continue on monthly or every other month, the every month cohort showed a 14% reduction, and the every other month showed a 19% reduction versus sham. And you may say, why would you be seeing a greater effect with every other month? But we just have to remember these studies aren't designed and organized nor powered to actually detect these differences, nor is it reported as significantly different. But I think the key point here, 2 different things. You always got to read between the lines when you read clinical data, and if you're a trainee here, I really would implore you not just to take everything that you're given with a grain of salt from talking heads in the industry, read data yourself, but basically look at the secondary endpoints of vision loss. We had 7 letters of vision loss with 2 milligrams of ACP versus 6 with sham here. The other thing that really I wanted you to put in your back pocket was the fact that data was censored in this trial. So if you were someone who developed a choroidal neovascular membrane, you're going to need additional treatment. You likely had further worsening anatomical outcomes as a result of developing a choroidal neovascular membrane, but that data is censored, so it kind of muddies the water here overall with these results and their true efficacy, and that's just my commentary and personal opinion. Let's break it down with safety here, and then we'll get done. Again, as we mentioned before, I'm not going to belabor these statistics, but if you just look with time with complement inhibition, the rate of choroidal neovascular membrane formation is going to increase. Then you're going to have these patients who are also getting treatment with these drugs as well as anti-VEGF agents. And if you look at the Gale 3-year data for the every month cohort, the rate of CNV formation was as high as 16%. Final key point I want to belabor here is rates of intraocular inflammation, specifically with pegcetacoplan. When we looked at 12 months for Oaks and Derby, there was a 1.7% chance of developing a non-arteritic ischemic optic neuropathy with monthly treatment and 0.2% in every other month. When this data first came out, I called our medical science liaison to get any further idea of what the cause and effect is. Basically, this diagnosis was based on the sole discretion of the treating provider. There was no ancillary studies that were needed to confirm this. And basically, the response that we've gotten from industry is just that, hey, these were just people with disc at risk, but you would think randomization would tease that out. At 24 months, 5 cases of endophthalmitis with this drug. And then the most important thing is this drug launched early in 2023. And by the time we were all getting ready to meet for the annual meeting in July for the American Society of Retina Specialists, case reports were coming in of severe occlusive vasculitis and vision loss. And so as of December 2023, 14 patients confirmed from the REST committee have had these severe cases. Usually happens after the first injection with pegcetacoplan, 7 to 13 days after. These patients prior to treatment were seeing 20/60, and after that on average were 2300. 57% of these patients had greater than 3 lines of vision loss. 43% of them had greater than 6 lines of vision loss, including 2 eyes that actually had to be enucleated from this drug. ACP had no cases of ischemic optic neuropathy or vasculitis. There was 1 confirmed case of endophthalmitis. In the GATHER1 trial, there was 1 case of mild vitritis that resolved without treatment. And in GATHER2, there was 1 case of vitritis that was mild and resolved with topical steroids. So in summary here, I think we just have to take everything with a grain of salt and read between the lines here. We have 2 FDA-approved treatments for geographic atrophy secondary to AMD. But let's just remember, we have a high frequency of treatment burden, high cost to society for these drugs, high rates of choroidal neovascular membrane formation, and then let's just remember at the end of the day, everybody still loses vision. So this is where the real controversy is, and I'll be honest with you, I do use these medications very sparingly. I can count on my hands the number of patients who use them. Overall, these are very highly motivated patients who come into your clinic, usually blind in one eye from GA, losing in the other eye, secondary or advancing GA, and are willing to put up with these risks overall. But I'd like to just finish here with a quote and an editorial that was in the Blue Journal of Ophthalmology about a month or 2 months ago from Dr. Lucian Del Priore, in an editorial titled, "To Treat or Not to Treat GA, That is the Question." And just paraphrasing, he says, "The treatment question remains in the minds of many patients and their physicians because of the treatment burden, costs, and complications. The effect of both of these drugs is limited to slowing the growth rate of GA with no detectable effect in visual function at 2 years. Furthermore, the potential cost to patients outweigh the benefits because the treatment effect is so small, and many patients eligible for and receiving intravitreal treatments may never lose vision without these treatments in the first place." Like I said, the other whole camp is that, hey, we need to snuff out GA. Anything we can do to blunt this response and with time will help save vision. I think it's fair to always offer patients any treatment option that's available as long as you have a very, very thorough and informed consent process. In my personal opinion, I'm a big statistics guy. I would want to see something on the order that we use often in medicine to look at the efficacy, number needed to treat or number needed to inject, wherein we would say, well, how many injections do we need to give? How many patients do we need to inject to, say, save 5, 10, 15 letters of vision loss? And I think until we get that data, I don't think we have some great rules or guidelines for treatment. Other people in the retina community may disagree. I'm more conservative, and I get asked the question every day, well, doc, if it was your eye, would you put it in your eye? And overwhelmingly, my response is no, but I don't try to bias people. Like I said, I do use this medication. And at this time, I would feel free to take any questions or comments. Shoot.
In your opinion, would you suggest that someone who has a different risk can benefit from one versus the other? That's something that you're looking at choosing?
Sure. I'll tell you just first and foremost, you know, when I take a look, I discuss these drugs with patients. I think because of the risk of the severe vasculitis that occurred with pegcetacoplan, I would steer patients away from using that medication in general. It's just my personal opinion. As well as hypothetically, when you look at C5 inhibition versus C3 inhibition, C3 right inhibition, we still have all of these other pathways that follow, and that's the presumed or hypothetical reason why we have more inflammation. So I steer towards C5, but when I look at disc at risk, I don't really put that as a risk factor because it was so spurious. Shoot. Yeah, I would have to think that there's drug reps are here. I use these drugs so infrequently, and we don't stock them very often. I have some samples, and then I order it if patients want to, but I don't have a price point for you, but they are expensive. Probably equivalent to high-value drugs like, aflibercept, faricimab, They are covered by insurance. I think it hasn't been, what's that? Some insurance. I think red, white, and blue Medicare, Medicaid typically cover. There's been some slower adapters, but again, I tell you, I can count on the number, patients I use these drugs on so infrequently. Hypes, are you using it very often? Not a lot. What are your safety concerns when you look at ACP versus pegcetacoplan?
So from a safety standpoint, if I had to pick one over the other, that is a little more compelling to use just Izervag over Syfovre.
Sure.
But the Syfovre had the benefit of getting there first.
Sure.
It was the first one that was, patients would come in and say, I saw a commercial that said you guys can now treat dry eye and daily.
It was the Fonz. Arthur Fonzarelli was, yeah, he was promoting. He jumped the shark and then sold out.
So to me, I think educating patients is the most important thing. Having, honestly, fundus autofluorescence pictures, serious fundus autofluorescence pictures, especially where you can show them the hyperreflectivity around the lesion and progression of that lesion over time. And it being non-central, because that's the other issue that we run into is these patients, by the time it's central, the jig is up. There's no benefit of it. What you're trying to do is keep this big lesion from encroaching the fovea. And if you can show them progression and educate them, I usually say, I'm going to see you every 6 months for this condition no matter what. So
Mm-hmm.
this packet and everything we talked about today. If you want to come back soon and get started, call me. If not, see you soon. I put it on the patients. This is a decision I can't make for you.
Yep. And that's key. That's key. I think one thing when you talked about serial FAF, if you are monitoring these patients in your clinics, every 6 months, get a fundus autofluorescence, and if you have like a Zeiss or equivalent OCT, you can actually do RPE macular change analysis, which is a very cool tool where you can actually see these islands of GARPI increasing in size. So it's a really cool tool, if you do see it, and you can basically objectively measure these changes. I do that in our clinic.
So I'm general on peds, and we follow these patients over a long period of time. We start to see geographic atrophy, not only in just macular degeneration, but also in things like Stargardt's and things like that. When do you want to see these patients? When do I refer them to you? When I first start seeing that geographic atrophy and the autofluorescence, or do I, because I have some Stargardt's patients with a small
Mm-hmm.
central island or 20/20, but they have huge geographic atrophy. Do you want to see them at that point, or I wait until their vision goes down? Like, when do I see
Well, specifically for Stargardt's, if they haven't seen or aren't following with a retina specialist, just following, for an annual exam. Again, FDA labeling, this is not indicated for geographic atrophy. And Stargardt's discussing off-label use. One gentleman in Texas did go blind from ACP because he was injected for Stargardt's with this. So, I think, delving into those waters would be pretty darn, risky at this point. But I think if they're not established with a retina care provider, just getting them in and then just annual follow-up. And I think the bigger key in the future with these inherited retinal diseases is going to be gene therapy. You've got Luxturna and these other drugs that are already FDA approved, which are showing benefits. So I think that's the route I tell the inherited retinal disease patients to go down, if that answers your question.
problem with the Stargardt's patients is that they just get told year after year after year,
Mm-hmm.
there's nothing I can do,
Mm-hmm.
their vision declines. They stop seeing you guys.
For sure.
So,
No.
and then I'm like, okay, it's time to go back and see another doctor. They're like,
Like, why? They're going to tell me the same thing. And that's a fair point. And I tell those patients, if it's a huge frequent burden, as long as you're seeing someone, I don't care, right? Because we can get, other secondary things, with Stargardt's as well, too. But yeah, as long as they're following with someone, I'm okay with that. Please. Yeah, great question. Knock on wood. I haven't had anybody have that happen yet, but theoretically, I think I would have a treatment paradigm of one of two things. Hey, you developed this membrane here. Do you still want to continue treating at this point for the geographic atrophy? And if you do, then you're saying, okay, well, how frequently, right? because we do have data from both Oaks and Derby and Gather 1 and Gather 2 that you could go out to every other month and, stagger that way. But I'm just thinking when this happens in the real world, patients are going to be really disappointed and they're going to be like, I got to get another shot, and it's going to be going down that. Yeah, no, it's tough, and that's part of it. Pipes.
So for these patients outside of the trials, every other month, I'm not doing any month.
Yeah.
It cuts the risk enough and the outcomes are so similar that
Mm-hmm.
every other month. And so the other thing that's interesting about the CMDMs that form with this is they tend to be kind of eccentric along the edges of the lesion, so they're not always centered, which is kind of nice. But for me, that also gives you some flexibility with anti-VEGF treatment. So we've had a couple cases where we still stay in Q4, but we're just alternating the eyes are there. So instead of coming in every month for 0.1 of the eyes, actually kind of makes it a little easier.
Yeah, good point. Gibson, are you using any? No. No. Okay. All right. Well, cool. Well, thank you, everybody. I know that was very data-driven lectures here, but thank you for your time. And I think we have a break here, and everybody get out. So thank you so much.
All right, guys. It's around 9:30, so we'll go ahead and get started for the second session of the morning. I'm Dr. Austin Taylor. It's a pleasure to be here. Today we're going to be talking about some glaucoma cases and hopefully get some crowd input as well. I have no financial disclosures. Little background about me. Did my undergraduate training at the University of Virginia's College at Wise, Lincoln Memorial University, DCOM for medical school. Completed my Larkin Fellowship in 2018. Trained in glaucoma at the University of Kentucky in 2019. I've been in private practice since 2019. In Central Appalachia, a split time more or less between Abingdon, Virginia, and Pikeville, Kentucky. So let's jump straight into it. So case one, we've got a 61-year-old female. The patient came to me seeking a second opinion prior to starting drops. Visual acuity was 20/20 in both eyes. The pressure in the right eye was 28, pressure in the left eye is 19. Now, fundoscopic examination, the optic nerve I graded as 0.3 in the right eye, 0.2 in the left eye. She had healthy appearing rims with no hemorrhages noted. On anterior segment examination, this is more or less what we saw. As you can tell, there is some flaky material, some white material there at the pupillary margin. You're probably already kind of know where we're going with this. And then on the dilated examination, you see the very clear presentation of an anterior bullseye. So we are dealing with pseudoexfoliation in this patient. Just very quickly, speaking about fibrilin. Fibrilin is, as mentioned, a flaky material from the lens, but it's found everywhere throughout the entire body. It's found in the skin, heart, lungs, liver, kidneys, and elsewhere. In the eyes, we know that it's associated with glaucoma. We also know that it's associated with zonular weakness, which can cause problems when it comes to cataract surgery, as all of you are aware. Systemically, though, it can also be affiliated with myocardial infarctions, cerebrovascular events, and systemic hypertension. On gonioscopic evaluation, we see a picture very similar to this. It's kind of cloudy there, but you may be able to see that there are 3 dark bands there. Knowing your anatomy, we know that there's generally only 2 dark bands, being the trabecular meshwork and the ciliary body band. That very anterior band, known as the Sampolosi line, is actually pigmented Schwabe's line. And if you remember, Schwabe's line is the termination of Descemet's membrane. The reason this is important when it comes to SLTs and when it comes to MIGS, when you're operating on these types of patients, either in pseudoexfoliation or in pigment dispersion syndrome, having the Sampolosi line, it's very important to know your landmarks, because if you're targeting Schwabe's line, you're in the wrong place, especially when it comes to MIGS. So you're actually hitting cornea at that point. So if you are seeing Sampolosi's line, be certain that you go just posterior to that to find the trabecular meshwork, and make sure when you're doing your surgical procedures or your SLTs that you're targeting TM and not the Schwabe's line. On gonioscopic evaluation, I don't know, how many in here are students? Any students? How many are residents? Any residents? Okay. So the best way to really find TM is to do the cone of light, more or less make the slit beam very, very thin, put on an oblique angle. Your anterior portion is going to be your cornea, your posterior portion is going to be right there, and where those two meet, that's going to be basically Schwabe's line. So just posterior to that is going to be your TM, so that's important. Back to this patient though. This is basically her OCT. As you can see, pretty healthy appearing optic nerve, a little bit of borderline superior thinning there in the right eye, very robust appearance there in the left eye. And I don't have the visual fields, but her visual fields were normal as well. So currently, the pressure was 20 and 16, so that tells you that I did something, so we're going to get into that now, okay? So, question, and please raise your hand. I kind of want to get your all's interaction here. Glaucoma is a very boring topic, so if we can have more of a conversation, that may help our hour pass a little quicker. But what would you say is the correct diagnosis? As far as pertinent information that I want you to be aware of, the pressure initially was 28 in the right eye, it's 19 in the left, the visual acuity is 20/20. OCT was relatively normal. Fundoscopic examination revealed a small, healthy nerve without any thinning. So who would say that this is primary open-angle glaucoma? Just show of hands. Anybody? Good. How about ocular hypertension? Okay. How about low-tension glaucoma? Okay. And how about secondary glaucoma? Okay. All right. So I would say that this was actually ocular hypertension. And the reason for that, in order to know that, we have to know how to distinguish what ocular hypertension is versus glaucoma. Ocular hypertension is high pressure with a healthy appearing nerve, as opposed to glaucoma. Glaucoma is optic nerve damage, specifically thinning of the optic nerve, historically cupping, that leads to a reproducible visual field defect due to optic nerve damage with or without elevated eye pressure. Before we had OCTs, more or less we diagnosed glaucoma strictly as fundoscopic evaluation with a high pressure. We now know that normal tension or low tension glaucoma exists. So when it comes to pressure, even though pressure is the only thing that we can actually modify in this treatment or in this disease, pressure doesn't necessarily key you in that this is glaucoma. It's the damage. And then a glaucoma suspect, the way that I think about a glaucoma suspect is an enlarged cup-to-disc ratio or elevated intraocular pressure. So you can have an enlarged cup-to-disc ratio with a healthy rim, but you can still have high pressure. So that patient would be a glaucoma suspect with ocular hypertension is how I would more or less specify that patient. But with ocular hypertension, let's get into the ocular hypertension treatment study. So the ocular hypertension treatment study, they took 1,636 patients with pressures between 24 and 32 in one eye and 21 to 32 in the other eye, once again without glaucomatous damage. So the optic nerves were healthy in these patients. The goal of the treatment arm was to reduce the pressure to less than 24 with a minimum of a 20% reduction from baseline. And I think it's important to note that the treatment arm was strictly topical medications. We're not talking about surgeries here. We're not talking about lasers. We're strictly talking about topical medication. And in the OATS trial, at 60 months, the cumulative probability of developing glaucoma in the medication group was 4.4% versus 9.5% in the observation group. I'm pretty backwood, I'll say. I'm from Central Appalachia, so I try to speak very clearly to my patients. And when I'm trying to talk to my patients, I basically tell them in ocular hypertension, basically in the study, they found that if we didn't treat you with a high pressure, you have a 10% chance of developing glaucoma. If I do treat you, you've got a 5% chance of developing glaucoma. So therefore, if I treat you with this condition, I manipulate the data and I say I can reduce your risk by 50% if I treat you for glaucoma. With that, though, I think it's very important that you look at the patient as a whole, not just based on pressures. So in the OATS trial, it also helped to establish the risk factors for developing glaucoma. And those were older age, a larger vertical or horizontal cup-to-disc ratio, a higher intraocular pressure, a greater pattern standard deviation on the visual fields, and a thinner central corneal measurement. So looking at the patient as a whole, I think it's important to include all those factors in determining whether you would need to treat this patient or not. Even though the patient was 60 years of age, the pressure was 28 in this eye. So therefore, I did opt to treat, so that kind of gives you a hint as to what question 2 is. But what would you do with this patient? How many people would observe this patient? Okay.
What's the corneal thickness? Did you say before?
I did not. Let's say that the corneal thickness was 540 average. Okay. And that is a very good question. Sure. Yep. That's certainly appropriate. Let's say that for argument's sake, the corneal thickness is 540, so average corneal thickness. So how many people would observe? Okay, a couple in the back. How many people would do an SLT first line? Okay. And then how about drops? Okay. And then anybody do surgery as a first line treatment for this patient? Okay. So I chose to do an SLT, and the reason that I chose to do an SLT in this patient is because of the LIGHT trial. The LIGHT trial was published in September 2022. They published their 6-year data, and with the LIGHT trial, this was virgin treatment, so these patients had never had any type of treatment for pressures. They subjected the patients to SLT versus drops. And at 3 years, they found that the SLT arm, 78.2% of eyes receiving SLT required no drops. At 6 years, 69.8% of eyes in the SLT group required no drops. It is important to note that in the LIGHT trial, they did allow for a repeat SLT. In the 3-year data, they allowed 1 repeat. In the 6-year data, they allowed an additional repeat of the SLT. And they also found that greater progression was noted in the drop group as opposed to the SLT group, both in the OCTs and the visual fields, and also showed that there was a greater number of surgery needed in the drop group as opposed to the SLT group as well. The European Ophthalmology Society, based on the LIGHT trial, they actually now recommend that the first-line treatment for glaucoma or ocular hypertension is SLT. The American Academy of Ophthalmology has now made the statement that SLT is the equivalent of drops and therefore is also approved for first-line treatment. So let's get into kind of the SLT treatment. So we've got a few different options here. Some people choose to treat 180 degrees. Some people choose to treat 360 degrees. How many in the room treat 180? So a couple. How many treat 360? Okay, so that's pretty even, to be honest. I'll kind of let you know how I do it, and then we'll get into the studies that say why. I choose to treat 360 degrees, and some people choose to pre-medicate. Is anybody using pilocarpine before these cases? Sometimes, sure. How about brimonidine? How about aproclonidine? Anybody? Okay, so that's kind of spread out. Anybody post-medicate with steroids? Okay, NSAIDs? How many do nothing? Okay, and then as far as pre-medication, I do not pre-medicate these patients, and as far as post-medications go, I tend to do nothing. I tend to just watch them unless there's a pressure spike afterwards. That kind of gets us into the pressure check after an SLT. I tend to check my patients prior to the SLT. I'll get a baseline pressure, perform the SLT, and then I'll hold them for 15 minutes. If that pressure did not go above 10 points, or if it's below 30. So if it's below 30, I let them go home. If they started above 20, and as long as they don't increase more than 10 points, I let them go home after 15 minutes. And then I'll generally see them in a month. If they did increase above 30 or more than 10 points, then at that point, I'll drop them with iodine, check them back in 15 more minutes, and then if it's still elevated, then at that point, I'll intervene. There's been one instance, and it was a pigmentary dispersion syndrome where anterior chamber paracentesis had to be performed. That's happened once in the last 3 years. So it does happen. You do get these pressure spikes, so that's something to be aware of. So the reason that I treat 360 is because of this study here. We were kind of doing it before, but now we've got a study to back it. You'll notice that this was just published last month in March of 2024. This is, I don't know if it's been pegged the OPSALT, but that's what we're going to call it. So we're going to call it the OPSALT, the optimal performance of selective laser trabeculoplasty. The design of this study was to determine whether 180 degrees or 360 degrees was more beneficial. And they found, they also wanted to study whether high dose SLT versus standard dose SLT was more appropriate. High dose was seeing the cavitation bubbles or the champagne bubbles 50 to 75% of the shots, and then the standard dose was considered just under the threshold, so you were not seeing the cavitation bubbles at that time. So that's kind of the two treatment arms, high versus standard. In the study, it found that the 360-degree high was the most beneficial. It also showed that there was a greater reduction in pressure and for longer periods of time to retreatment in the 360 high group as well. And the IOP reduction 1 to 6 months after the SLT group was 5.4 millimeters of mercury in the 360 high, compared to 4.2 in the 360 standard. And then when you look at the 180 group, it was hitting 3.4 in the high and 3.2 in the standard. Furthermore, the success rate after 6 months was significantly higher in the 360 high. It was at 58.3% compared to 41% at 360 standard. And then when you get in the 180 target range, they were at 30.2 and 29.3. So there was a significant, there was certainly a significance there with 360 high. The only problem with the 360 high was that the postoperative discomfort was a little more common, but symptoms were generally mild and transient. So I always tell patients they may have a little bit of light sensitivity, they may have a little bit of an achiness and things like that, but generally they're very mild and they improve quite quickly. So the SALT trial, and this is kind of getting into the steroids versus NSAIDs versus observation. The SALT trial took a study group of 18 years of age or older, and the pressure was greater than 18 in these patients. The three treatment arms was ketorolac versus prednisone versus saline tears. And they did the SLT, they put the patients on these drops 4 times a day for 4 days. At 6 weeks, there was no statistical difference. However, at 12 weeks, the SALT trial showed that there was better IOP reduction in the ketorolac and the prednisolone arms as opposed to normal saline. However, that was only at 12 weeks. There's been other studies such as the Kaiser, Thrain, Champagne, and Genepria, can't pronounce that name, that did a much longer follow-up, and their follow-ups were at 6 months to 12 months, and it actually showed that there was no statistical difference in using the ketorolac or the prednisone. It showed that more or less saline tears was equivalent. In other words, there's no right answer when it comes to postoperative treatment. I think that whatever you're comfortable with or whatever you want to do is appropriate, but there are some studies that are investigating that right now. The verdict's still out, though. So case 2. We've got a 50-year-old male. Was called to the emergency department due to a bungee cord injury to the left eye. On examination, he's got a layered hyphema. He's got an 80% field anterior chamber, visual acuity is hand motion, and the pressure is 38. So initially, with management, I placed this patient on everything that we had, timolol, bromandine, dorzolamide. Also put him on atropine and dexamethasone. 2 days later, I saw this gentleman in my clinic. Pressure was 20, but 10 days later, his pressure had shot up to 34, still on the same medications, and I thought that he had probably had a rebleed as well. He was complaining of a headache. At that time, I did perform an anterior chamber paracentesis at slit lamp, and I started him on Diamox 250 milligrams twice a day as well. He was unable to tolerate the 500 milligrams extended release. 35 days after this initial injury, the pressure was still at 32, although the hyphema had resolved. Where the hyphema had resolved, his vision had improved to 20/80. And now that the hyphema is resolved, we see this. So he's got an iridodialysis, as you can see. And my plan at that time was to, the pressure was still more or less elevated at 32. And then also, once the hyphema had cleared, I had a much better view of the fundoscopic examination. And I noted there was a large degree of cup to disc asymmetry. The right eye was at 0.3 grade, and I graded the left eye as 0.8. My previous partner had seen this gentleman 3 years prior to this injury, and he had been told that he was a glaucoma suspect. This is the OCT. I don't think you can see the date, but that's from 2012, I believe, and this injury happened in 2021. So on the OCT in 2012, it looks very healthy. You can see that there is some cup to disc asymmetry at the thickness map there, but very healthy appearance of the OCT, both on GCC and the RNFL. This is what we see now after this injury and now after the blood's cleared. Granted, the left eye does have some artifact there, but you can see that there is a big difference there in the left eye as opposed to previously. I do not have a visual field from what it was previously, but this is the visual field after the injury. Right eye, once again, was a robust nerve. We wouldn't expect to see any visual field abnormalities in the right eye, and we don't. But the left eye does have early inferior arcuate and leading into a superior arcuate as well. So at that point, I feel like it's certainly appropriate to go ahead and be aggressive with this patient. Some concerns that got brought about as far as this presentation goes was the hyphema. So when should we be considering to do an anterior chamber washout with these patients? Well, approximately 5% of patients with traumatic hyphema will actually require surgery. The patient can typically be monitored for the first 4 days with medical treatment alone to allow for spontaneous resolution. However, after those 4 days, surgical intervention may be indicated in the setting of uncontrolled glaucoma. And uncontrolled glaucoma is defined as greater than or equal to 50 millimeters of mercury for more than 5 days, or greater than 25 millimeters of mercury for 24 hours in a patient with sickle cell. So that's what was defined as uncontrolled glaucoma. You should also be considering an anterior chamber washout if you see any evidence of corneal blood staining, a large or a total hyphema, or if there's active bleeding. At that point, go ahead and take them to the OR to do an anterior chamber washout. Fortunately, that was not the case for this gentleman. And once the hyphema had cleared, the pressure was still elevated on maximum medications. What should we be thinking about now? And that brings us to question number 3. So the pressure's at 32 despite maximum medical therapy, including acetazolamide. How should we proceed? So who would continue to observe this patient? He would, I think he's around mid-50s, yeah. How many people would do a tube shunt? Okay. How about SLT? How about trabeculectomy? Okay. How about cyclophotocoagulation? There was a lot of no answers there. Okay, all right. So with this patient, so you're still in my thunder, Leo. We're going to get to that. But, yeah. So the plan with the iridialysis, and I get to that in about 2 slides. So I made the decision to go ahead and place a tube in this patient. So I placed the tube. Initially, after the tube, the vision improved to about 20/30. The pressure at that time also improved significantly. But because of the trauma and because of the iridialysis, the cataract continued to progress. And he was also very light sensitive because of the iridialysis. So I did send him to the University of Cincinnati. Dr. Snyder operated on him. He got an iris prosthetic, and he also had cataract surgery in May of 2023. Currently, his visual acuity is 20/25, the pressure is 11, and he's on Timolol still twice a day. But as far as monitoring him, I'm still monitoring him on a 6-month basis, doing annual testing, and he's been relatively stable since we put the tube in, and he's much more comfortable now that he's had the cataract surgery with the iris prosthetic. Yes, sir.
Just be a tough one to answer, I guess, because he was lost to follow up by your partner until the injury.
Correct. So my partner saw him 3 years prior to the injury, and then I came into a practice that didn't do a lot of testing. So the last testing that I had was from 2012.
The question is, the large change we saw in his OCT in that left eye.
Is it related to the trauma, or is it related to the...
His pressure was only high for 2 weeks.
Correct. But the pressure remained high. It was still at 32, 35 days after the surgery. And we couldn't get it down. We tried. We had him on everything, with the pressure still at 32.
I refer to that change in the OCT. Don't you think that was more of a process?
May very well could have been. I don't know what his pressure was prior to the injury either. So it would have been nice to know those things, but when he showed up, it was kind of one of those things that we had to handle it. So some people said trabeculectomy, some people said tube. Of those of you that did answer, yes, sir. Do you have a question? So as far as anterior segment iridodylisis repair and things like that, I don't really do those, to be honest. Dr. Snyder, I think that he's kind of an iris specialist at Cincinnati. I've used him several times. I felt that that was better served in his hands, so that's why I sent it to him. But if you feel comfortable with an iridodylisis repair, then by all means. So some people said trabeculectomy, some people said tube. It really doesn't matter at that point because of the tube versus trabeculectomy study. It was in 2005. In the tube versus trabeculectomy study, it was trying to determine which was more beneficial, tube versus trab. And it showed that there was a higher rate of complications in the early postoperative period with trabeculectomy, but they also had a lower intraocular pressure. At 5 years, there was no difference, though, in a tube or trabeculectomy in regards to complications or IOP management. Then you take the 2022 study, the primary tube versus trabeculectomy study. Once again, this was virgin treatment who had never had any type of eye procedures done to maintain pressure. At 5 years, the failure rates were similar. The pressure was also lower at 1 year in the trabeculectomy group, but it was very similar between the groups at 5 years. It also showed that the medication usage was higher in the tube group versus the trabeculectomy group at all times. It's also important to note that in these studies, the TVT study in particular was only dealing with Bearvelt tubes. These were not investigating valve tubes such as the Ahmed. But case 3. So we've got a 65-year-old male consult from the emergency room for loss of vision and severe eye pain. Visual acuity is 20/40 in the right eye, 2200 in the left. Pressure was 12 in the right and 64 in the left. He's also got 2+ corneal edema in the left eye. We tried to get a gonio view. This is not his. This is from a Google image, but this is something that we saw similarly. As you can see there are no angle structures visible. So we're dealing with acute angle closure here. And my thoughts on this patient was initially to try to reduce the pressure to potentially clear the cornea. So I asked the emergency department to put him on everything that he had and send him immediately to my office. So he was placed on topical medications available in the ER. And then once he got to my practice, I did have a view in order to perform the LPI. In my opinion, if you can see to perform the LPI, go ahead and do it. That will potentially reduce the pressure, therefore buy you some time to get to the operating room if still necessary. So when it comes to LPIs, we've got a few different options here. So as far as placement goes, who here places the LPI superiorly? Okay. Who places it somewhere other than superiorly, either laterally or temporally or nasally? Okay. Who pre-medicates pilocarpine, aproclonidine? Anybody pre-medicate? The majority. People put them on steroids, NSAIDs, etc. Who post-medicate? Good. And then follow up. Do people tend to dilate or not? Okay. So generally, I do not pre-medicate. I do post-medicate with a steroid. And at follow-up, I want to make sure the PI is open before I dilate these patients. And then if I feel like it is open, you can do provocative testing. So check the pressure before dilation, dilate them, check them after the dilation. If it goes up more than 10 points, then at that point, you should be considering either taking them to the OR or performing another PI. Yes, sir.
What's the stop timeline from doing a 20, 30 gauge corneal, paracentesis to lower the pressure a little quicker?
You can certainly do that. That'll help to clear up the cornea. I had a view at that point, so I was able to more or less do it. But if you need to do the paracentesis to clear the cornea, it'll clear fairly quickly in that regard to get the pressure down immediately. And sometimes that's still necessary. Even with a PI, if the pressure remains elevated even afterwards, certainly consider doing a paracentesis. So there was quite a bit of different responses as far as placement goes, and this is the reason that there's that type of argument. So over the past few years, there's been an area of discussion about where the best place to place the PI is. In my training, I was with multiple different attendings. Some felt like the superior position was the best. Others felt like the temporal placement was the best. Some didn't really have a preference as long as you're targeting iris crypt. The reason there's even a question as to where to place the PI is due to the visual dysphotopsias, which have been reported in 2 to 16% of patients. You need to understand that these dysphotopsias are highly nonspecific. Give me 1 second here. and occur in up to 10% of patients even before the iridotomy. And those that reported dysphotopsias before the iridotomy, it actually showed that 12% of those patients said the dysphotopsia is resolved after the LPI. The reason for that could be due to relief of the pupillary block, but it's also unclear as to why they notice improvement at that. So we basically have two places the majority of ophthalmologists will target, either the superior placement or the nasal and temporal placements. In rare instances involving silicone oil, we would place the LPI inferiorly. That's for a different lecture. So what are the benefits of superior placement as opposed to nasal and temporal PIs? Studies showed that the superior placement actually required more energy. The temporal location, though, was associated with greater subjective pain. Some studies have said there are more dysphotopsias with the superior placement due to the prismatic effect at the limbus, and others have said that the temporal placement actually causes more dysphotopsias due to direct exposure to the LPI. Article that was used to develop this slide reported no difference in the occurrence of dysphotopsias, whether superior or temporal, more or less when performing an LPI. In my opinion, place it in a crypt, therefore using less energy, and be sure that you penetrate the iris, making it a complete LPI. Beware, temporal placement, though, may cause more pain, but the temporal placement also may require less shots. So that's one of the reasons to kind of justify what you do there. There's no right answer there. When we talk about angle closure, the reason that an LPI may not work is because lens extraction is the definitive cure in primary angle closure. And the EAGLE study, the effectiveness in angle closure glaucoma of lens extraction study that was done in 2011, tries to determine whether lens extraction versus LPI is more beneficial. So lens extraction, as mentioned, is a definitive cure for primary angle closure, not to be confused for secondary angle closure. So we're talking about primary angle closure here, but surgery also has risk. LPI and medication result ultimately in more follow-ups, more medication, and potentially more complicated surgery in the long run if they sneak down. The inclusion criteria for the EAGLE study was age greater than 50 years. They had to be phakic, obviously, and primary angle closure glaucoma with a pressure greater than 21, or primary angle closure with a pressure of 30. It has to be a new diagnosis with no previous treatment, and they had to have greater than 180 degrees of iridotrabecular contact. In the context of angle closure with a pressure greater than 30 and angle closure glaucoma with a pressure greater than 21, no visually significant cataracts, early lens extraction was proven to offer better results, a better quality of life, and a lower IOP with fewer medications or ongoing glaucoma interventions when compared to LPI and medical treatment. But surgery does have risk. In my opinion, performing an LPI on a 20/20 patient is more appropriate than going to the surgery and doing cataract surgery in someone that's not visually significant. I can't really justify doing cataract surgery on that patient. So in my opinion, an LPI, as long as it's not a visually significant cataract, go ahead and do the LPI, see if it resolves, and then if it doesn't resolve, consider doing the lens extraction at that time. Case number 4. You've got a 42-year-old male. This was an outside referral from one of the optometrists. He's noticed a significant decline in vision in the right eye and a painful left eye. Visual acuity was 20/70 in the right eye, and he's got hand motion vision in the left eye. Pressure was 18 in the right, 46 in the left. Optic nerves were graded at 0.95 in the right eye and a 0.99 in the left eye. And he's got Zen gel stents at 11 and 1 o'clock in both eyes. So yes, that's 2 Zens in both eyes. And his current medication is bimatoprost, nighttime, both eyes. This is his OCT. You can tell that he's got very thin realms in both eyes. And he was hand motion vision in the left eye, so we didn't do a visual field. But this is his right eye. You can tell that we're operating with a pixel of vision left. So what is your plan in this gentleman? So in the right eye, I plan with the Zens are taking the whole superior quadrants here. So the superior placement is not an option. We decided to do a tube shunt inferiorly. You certainly don't want to do trabs inferiorly either, so we put a tube inferiorly, and we combined that with cataract surgery. In the left eye, the initial plan was to make him comfortable. So we did a CPC. He returned 2 weeks later after the CPC, and somehow he had vision of 2200. I told him that, not sure how that happened. Scientifically, I can't explain that. I believe in miracles, so I told him that that's more or less what happened. And since he had 2200 vision, we needed to protect that. And after the CPC, I took him back to the OR 2 weeks later. I did another inferior tube. Once again, he had 2 Xens taking the superior quadrants there, so that was out. Couldn't go that route either, but also combined that with cataract surgery. His current status, pressure is 6 in the right eye, and it's 13 in the left eye. Vision is still 20/25 with a pixel of vision remaining, 2200 in the left eye. And he's currently maxed out on medical therapy, bimatoprost, timolol, brimonidine, and dorzolamide. I've told the guy he's relatively young. He's got good understanding of this disease. He's aware there's no cure for it. He's also aware that he will eventually probably go blind, but we're going to do everything we can to protect it. And we'll do that as long as we can. I did an Ahmed on him. Ahmed is, in my area, being in Central Appalachia, I feel like I'm more protected with an Ahmed because they are not going to follow up regularly. So that's the reason for the Ahmed. I suture them in, yeah. So the temporal area is the only thing remaining. So, well, I'm sorry, I put it infranasal. So infratemporal is still available. Yeah, so, correct. My preference is to go supratemporal first for my tubes, and then I'll go infranasal generally, is my placement preference. So let's get to case 5. In this patient, you've got a 77-year-old female. This was a referral from my partner who's been following her for 30 years. She's got no light perception vision in the right eye due to a previous retina attachment. The pressure is 3 in that eye. She's not having any pain in the right eye, though. And the left eye reports to follow. It's important to note that she is intolerant to everything. She's intolerant to travoprost, timolol, brimonidine, dorzolamide, and she's been on these branded medications as well without any success as far as tolerance goes. This is her OCT. You can tell that there is an inferior thinning there, and the inferior thinning corresponds to her visual field, showing a very dense superior arcuate defect involving fixation. So the first time I met her, once again, she's only on bimatoprost. Visual acuity was surprisingly 20/20 in that left eye. Pressure was 22 though, and we are in trouble because that pressure needs to be a whole lot lower in this patient. So I'm sorry, she was on no medications when I first started seeing her. So what was the first step? And once again, she is intolerant to everything. Well, the first change was to try to get her comfortable. My thought was that she's probably allergic to preservatives. So I did put her on tafloprost or Zioptan, and also put her on brimonidine, specifically Alphagan P. Generally, when we're talking about intolerance to medications, generally that's due to the benzalkonium chloride preservative. Alphagan P is preserved in a different preservative. It's preserved in purite. Still not preservative-free, but it's not benzalkonium chloride. And it can tend to be a little more gentler as far as the intolerances go. After those initial steps, pressure was reduced to 19, still too high. I then added nitercidal or Ropressa. Pressure at that time dropped to 16, still too high in my opinion for this patient. Then we went with the timolol route, Timoptic preservative-free, and the pressure remained around 14 for about 6 months, and then it started to creep back up. We were up to 19 at that time, but visual acuity is still 20/20. So as far as how do we handle a monocular patient with 20/20 vision that still needs pressure reduction? Some people would say go ahead and do surgery in a monocular patient. I'm not a big fan of that. In my practice, I generally put that on the patient. I'll offer that to them. I like to wait until the patient basically becomes illegal to drive because there is always a risk for surgery, both cataract surgery, and there's a little higher risk for glaucoma surgery. But I always like to put that in the patient's hands. If they want it done, I'll certainly do it, but I tend to be a little conservative in that approach. So I thought that the better response was to perform a micropulse on this patient. So we did a micropulse that maintained her current pressure around 12. And then I think it's very important to have the conversation with patients that glaucoma, there is no cure for it. This is a war that we're never going to win. We'll continue to fight the battle, but sometimes glaucoma will win. Once again, there's no cure for it, but we'll fight the battle as long as we can. And then it comes down to function versus comfort. And this patient has a very good understanding of her disease. She knows that the drops cause her to be uncomfortable, but she also understands that with the drops, she still has function of her optic nerve, and therefore she's willing to deal with those drop sensitivities. Yes, sir. So we did do an SLT. We did not get a good response. With an SLT, I'll do it one time. If I don't get a good response, then I do not repeat it. But yeah, we did do an SLT on her. Very, very good thought, though. Yeah. So case 6, we've got a 60-year-old female. She is an uncontrolled diabetic. Welcome to Central Appalachia. Hemoglobin A1C is 12.7. She came in on bimatoprost, dorzolamide, bromandine, timolol, and acetazolamide, and the pressure was 12 in the right eye, 24 in the left eye. Visual acuity was 20/60 in the right eye, and she's count fingers in the left eye. This is more or less what her presentation looks like. She's got neovascularization of the iris. She's also got neovascularization of the angle. And the first step for her is to get her to our retina colleagues, so because she'd never been seen by a retina specialist. So send her to a retina specialist. She got Avastin injections and PRP. There was some improvement in the NVA and the NVI, and vision also improved off after those injections, but the pressure remained elevated. Visual acuity was 20/30 in the right eye. It improved to 2200 after the injections. She's got bilateral cataracts graded as 1+ PSC and 2+ NS bilaterally. It's also important to note that she is intolerant to acetazolamide. The pressure is 13 in the right eye, 17 in the left eye. Here is her OCT. The visual field is a little unreliable, but you can see that we're also dealing with pretty severe disease here. In the left eye, she's got the dense inferior arcuate. The right eye, she's got a superior nasal step also with the inferior arcuate, even though it's unreliable. If you look at the false negatives, it's a little unreliable. Still felt like that was consistent with her presentation. So question 4, what's your surgical plan? How many people would do cataract surgery as a standalone procedure? How many would do cataract with an eye stent? I did not, no. I'm not certain. Let's say 540 again. Yeah, she's pretty open. She was open to trabecular mesh work, but there's no iridocorneal touch or anything like that. So. Last pressure was 13 on the right, 17 on the left, and she's on everything with the exception, she became intolerant to the acetazolamide, so she's on everything that we got. Pressure was 13 in the right, 17 in the left. Yeah. Say that again. Correct. So we did decide to do a combined tube on this patient. And the reason for that is understanding the severity of glaucoma and the indications for your MIGS.
Why are you saying you can't do ECP?
Because they're neovascular. You can try ECP, but when pressure is high and they are intolerant, they are not to medical therapy and intolerant to diamonds, the chances that your ECP will bring the pressure down long term are pretty low. So you will do an ECP with cataract, and most likely they will still need a tube. So from my experience with neovascular glaucoma, the best is 2 shots, and they do also well for years.
Correct. Sure. Thank you, Joey. One of the reasons for the other answers there, talking about MIGS, it's important to understand what the severity of glaucoma is and what the indications for those procedures are. So severity, the American Academy of Ophthalmology says that mild glaucoma is optic nerve damage without visual field defect. Moderate is optic nerve damage with a visual field defect that is not involving the center portion of the vision and also not involving both the upper and the lower hemisphere. And then severe glaucoma is optic nerve damage with a visual field defect involving the central fixation or optic nerve damage with a visual field in both hemispheres being upper and lower. Once again, your MIGS are only appropriate for mild to moderate stage glaucoma. It is not approved for severe stage glaucoma. So with your MIGS, though, you've got iStents and you've got Hydrus, you've got Cahook, you've got the Cahooks, you've got ABIC, you've got ECP, Omni, you've got all those available to you in the mild to moderate stage glaucoma. It's important to note that iStent and Hydrus have to be combined with cataract surgery. They are also only approved to mild to moderate. Your Cahook, Omni, ABIC, ECP has no severity indication. So they can be done in ocular hypertension. They can be done all the way through severe glaucoma. With the iStent and the Hydrus, basically, if an implant's left behind, it has to be coupled with cataract surgery. If an implant's not left behind, such as in your Omnis, Cahooks, ABICs, and ECP, it can be performed as a standalone procedure. And as already mentioned, we put tube shunts bilaterally in this patient because it was a neovascular case. So case 7, and I think this is the last case. Thank you all for hanging with me today. We've got a 74-year-old male. Current medication was dorzolamide twice a day in both eyes, latanoprost at nighttime in both eyes. This was an outside referral. Current vision was 20/30 in the right eye, but he glared down to 20/60. He did have ADL compromised. And the optic nerve interpretation, I said that the right eye was a 0.3, left eye was 0.4, had relatively good rims, and also no disc hemorrhages were present. Pressure was 22 despite his current medication, so he's actually on 3 medications and the pressure's still 22. And the highest pressure previously reported was around 32 in both eyes. The OCT, he certainly got a little larger of an optic nerve than what I graded based on the thickness map, but the right eye was relatively robust. The left eye, you can see that there's a little bit of superior thinning there. And then on GCC, he's got a little bit of dropout in that left eye. Right eye looks pretty good, though. And then the visual fields, the right eye, I said that was potentially an early nasal step versus nonspecific changes, and the left eye more or less said that he had nonspecific changes in the left eye. So for him, he's already on 3 medications, and the pressure's still a little high. It's at 22, and he's got a visually significant cataract. So the question is, what do we do at that point? Give me 1 second here. Sorry. So let's talk about that really quick. As far as discrepancies between testing versus your fundoscopic examination and your visual fields. So basically look at the patient as a whole, take everything that you have. OCT's technology that we have is not always reliable. It can have artifacts and myopic eyes. We also know that the RNFL can be a little unpredictable and unreliable. So in myopic eyes, it's generally better to look at the ganglion cell complex. And the presence or absence of disc hemorrhages, even in the face of a healthy optic nerve, is also very important. If you're seeing a disc hemorrhage there, certainly be aware that there's probably optic nerve damage occurring. Also look at the visual field. If you're seeing visual field loss, you're probably done with glaucoma at that point. And consider the age as well. If this patient's 90 years old, you're probably not going to do too much. But if he's 50, you should probably be thinking about treating this at this point. And I treated him as ocular hypertension versus primary open-angle glaucoma mild stage. He was a personal friend of mine, so I don't operate on family or friends, so I sent him to the university, and they performed a goniotomy with the eye tract combined with cataract surgery. The pressure was 16 in the right eye, and it's still 23 in the left eye, but he's not on any medications. So are we safe at this point? Do we need any greater IOP control in the left eye being at 23? And how often should we be seeing this patient and repeating the testing? So the treatment goals when it comes to presentation, we saw that there was a 20-30% reduction from baseline. His pressure was initially 32. And I'm following this patient about every 6 months, doing annual testing on him. And it really comes down to whether the testing's stable versus whether it's not stable. If it's stable, then I think that the pressures are appropriate where they currently are. But if I start to see some changes there, we need to be a little aggressive to get that pressure down to protect the optic nerve. And I think it's very important if your patient is complaining of a subjective change in vision, even though you may not be seeing it on your testing, if they're complaining of a subjective change, that can certainly be key, letting you know that there's more optic nerve compromise than maybe you're aware of. So when it comes to adjusting treatment, you should think about adjusting treatment if the target pressure is not achieved and the benefit of change in therapy outweighs the risk. If you're seeing a progressive optic nerve damage despite achieving the target pressure, certainly lower your target at that time to get the pressure lower. If the patient's intolerant to your prescribed medical regimen, whether it be from preservatives or just corneal toxicity from the drops, think about changing the medical regimen. Can always keep in your back pocket. You've got preservative-free medications as well. If there's any contraindications to individual medications that may develop, such as COPD or asthma or bradycardia, dealing with a beta blocker. And then if you've got a stable optic nerve and a relatively low pressure for a prolonged period of time that's currently taking ocular hypotensive agents, you may want to try to reduce them, see if they can maintain goal pressure, still try to reduce the burden of the drops. But if you're seeing some changes, certainly put them back on those drops. And when should you be thinking about a downward adjustment of the medications? Consider a downward adjustment if the target pressure can be made in the face of progressive optic disc damage, changes on imaging, or changes on the visual field. Certainly lower your target pressure and get them to that new goal. And consider an upward adjustment if they've been relatively stable, and if the patient requires or is requesting less drops. See if they can tolerate it without any compromise to the nerve or compromise or worsening of the testing. So here are my references. You all have been a great audience. I certainly appreciate the attention. Are there any questions? Thank you. Talk about the SLT settings? Sure. Yeah, so generally I'll start everybody at about 1, okay? And I'll start on, I do 360 degrees, I'll start them at 1, and I will increase to the point to where I see the cavitation bubbles. If I hit the first time, and basically there's pigment and cavitation bubbles that go everywhere, then I'll adjust it down. And pigment dispersion in pseudoexfoliation patients, I'm probably around 0.5, so I'll lower it significantly to try to prevent a pressure spike. Also, if I'm seeing a lot of pigment and a lot of cavitation bubbles, I'll actually tell the patient, hey, you may very well be one that has a pressure spike. I'll let my staff be aware of that, and I'll want them to kind of tell me what the pressure is 15 minutes later so that I'm aware of that. But I start 360 degrees, start them at 1, and then kind of titrate to where I see the cavitation bubbles. The highest, we have a fairly new laser with good power, but when I was at UK, at one of our satellite clinics, I titrated up to as much as 3 to get the cavitation bubbles. So it was a fairly old laser though, but up to 3. Yes, sir.
Two questions. One, was there actually a study to find out if the ketorolac was used to lower the pressure?
No.
Or was used to just control any inflammation post-op?
Correct. So the SALT trial was trying to determine if it's more efficacious from a pressure standpoint. And the ketorolac, say that again.
You would still give it anyway, regardless of whether it...
For inflammation? In my opinion, I think that's your all's preference as providers. That's why medication's an art. I don't think that there's ever 100% correct answers. I don't prescribe steroids. I don't prescribe NSAIDs after an SLT. I let them know that I give them my call number and tell them to call me if they have any questions or concerns. But from the SALT trial was trying to determine whether it was efficacious for pressure, not for discomfort.
And the other part was, as far as the SLTs go, what's the consensus on the maximum number of treatments you would give and how far apart would you decide to give them?
Personally, I don't like to repeat for at least a year and a half. I tell the patients that it is repeatable. It does tend to lose its effect every time it's repeated. In the LIGHT trial, in the 3-year study, they allowed a repeat. They did not specify how long that they had to wait for a repeat. And then in the 6-year trial, they repeated up to twice. So in the 6-year trial, the patients had 3 SLTs within a 6-year period. I don't like to repeat personally for at least a year and a half, and I will not repeat unless I saw a good response from the first SLT.
I have some patients that I've given, I'd say, 8 treatments over 10 years.
Yeah.
Is that like other people do, or is that...
I think if you're still seeing, and this, there may be some people that disagree with this, but if you're still seeing a response, I think it's appropriate. SLT does not cause damage. It's not causing scarring. It's not putting holes in the eye like an ALT. What it's doing, we really don't know what it does, but we think that it basically gets macrophages to the area. It acts like Drano is what I tell the patients, is it cleans up the angle to try to reduce the pressure. Yes, ma'am.
So what is your workup and or management for people who are continuing to have progression
So I tend to follow those patients with testing about every 6 months. Generally, if they are unstable and still showing progression, they generally don't get out of my clinic for at least, I'll see them more or less every 4 months at that point with testing every 6. If they are unstable, and I think I'll quickly mention this, if I'm making a change in the medication or a change in the treatment pattern, I see them back in a month to make sure that that change is appropriate. But in these patients with relatively low pressures already, I have the conversation that this is not a curable disease. The only modification that we have in this disease is lowering the pressure. And sometimes getting the pressure even down to 8, sometimes in those patients is not enough. And that's the unfortunate thing about glaucoma.
Thanks to Austin for setting up the glaucoma portion of the conference. And thanks for everyone for being here. Really appreciate the opportunity to speak to a group of so many friends and mentors and past students. So it's funny, you know, you come to these meetings and you haven't seen people in a while. People say, "Are you still in Detroit? Are you still with the Seagulls?" And the answer is yes. I'm at a glaucoma specialty practice in the Southeast Michigan area. I have the opportunity to work with residents through Michigan State and through Oakland University, William Beaumont School of Medicine. So talk about glaucoma surgery and talk first about angle closure glaucoma, no financial disclosures. Multiple sources were used to put together this talk. So, like many things in our field, things are not static, and our understanding has grown and continues to grow. And it's always seemed to me like angle closure glaucoma should be a singular event where people were diagnosed, treated, and cured. But the more that we find out about the disease and the more we deal with it, we understand that it's a lifelong disease and a lifelong process in many of our patients. And as our understanding has grown, we've developed the ability to do different things to manipulate the disease and to cure it and to treat it. And certainly development of the laser was a huge step forward, but also understanding the role of cataract extraction and the role of iridotomy going forward has changed. And we have 2 major studies that have come out in the past 5 years, or rather the Eagle study is a little bit older than that, but the data keeps coming from that, which show the benefit of cataract extraction and when and if to perform an iridotomy. Now, acute angle closure is, we're going to diagnose it with gonioscopy, but it's important to remember to always treat the fellow eye. There's a high incidence of angle closure in the fellow eye, and you have to have a treatment plan when these patients present. Indentation gonioscopy is going to be a crucial tool for us when we're treating these patients and seeing them in the office, making the diagnosis. And it's surprising that gonioscopy is so limited in the clinic. And I'll show you some evidence of that. The gonioscopic technique that I use involves a 4-mirror lens with a small diameter. It's not the only lens available, but I think it's a good one. It's important to realize that if you use a large diameter lens, that you won't open the angle when you compress, and that it's harder to do dynamic gonioscopy. So while a larger diameter lens, like a Goldman 3-mirror lens, may be appealing because the view of the angle may be better, it doesn't allow for the clinician to examine the angle in the same fashion. And I would stress the importance of doing gonioscopy in the clinic. It's a low-tech tool, but something that's definitely available, reimbursable, but extremely underutilized. So a group in Ann Arbor looked at patients who went into angle closure. They looked at Medicare data, and they pulled about 1,200 patients who had acute angle closure. In those patients who had been seen within the previous 2 years, only less than a quarter of them had undergone gonioscopy. And half of the patients who had undergone gonioscopy were diagnosed as narrow angle, which is great. However, those patients were left untreated. And so the conclusion was that there's a large number of patients that we're seeing, especially in the Medicare age range, that have risk factors for angle closure that are being missed. And they're being missed because, number one, we're not doing the necessary examination, but number two, we're failing to adequately prophylact and treat. And part of that may be from kind of this mixed data and messaging about angle closure that comes out of the ZAP study, which we'll talk about in a few minutes. When patients have acute angle closure, most of us are very familiar with the medical treatment, but I would say that in terms of early treatment of patients with angle closure, they almost all certainly warrant at least some medical therapy before laser or surgery. In terms of surgical treatment, someone brought up a paracentesis early. Certainly it was reasonable, but laser iridotomy almost always has a role. We can use topical glycerin to clear the cornea. Cataract surgery has a role, but I would say in my experience that cataract surgery, while is a reasonable option, should be undertaken after the patient has had a chance to settle down in terms of inflammation and have the cornea clear. And tube and trabeculectomy are certainly options for patients who have angle closure, but I think those are reserved for I know those are reserved for patients who are refractory, and certainly with our understanding of the role of cataract surgery, those more invasive interventions can be reserved for patients who have refractory angle closure after cataract extraction. The pathophysiology of angle closure is, our understanding has evolved over time, and when I was a resident, people would talk about relative pupillary block, which I always was confused about. But basically, in angle closure, you have an inability of the fluid to migrate, or aqueous fluid to migrate through the pupillary margin, and you have a relative closure of that space. Many patients with pupillary block will respond to iridotomy and miotics, but not all. And the mechanism of the response to lens extraction is likely because of the deepening of the angle and the clearing of that transpupillary space. Primary angle closure describes angle closure with without an underlying mechanism beyond what's been just described. In the secondary angle closure, you do have a cause. I think that when we talk about secondary angle closure, it's frequently a mechanism that is overlooked or missed, and it's easy to understand as a clinician why that happens. There's a lot of excitement when these patients come in with pain and pressure, cloudy corneas, but it's important to always consider a secondary mechanism. Well, choroidal swelling and choroidal effusion is one of those common mechanisms, and certainly inflammatory. So recently had a patient come in who was diagnosed with primary angle closure, and he had all the signs and symptoms of it, including a swollen cornea, elevated intraocular pressure, but the other eye was quiet and deep. So we put him on topical steroids, and once the eye settled down, it became clear that he had a secondary angle closure secondary to uveitis, which had formed because of posterior synechii. In secondary angle closure, there are many mechanisms. A frequently missed mechanism of secondary angle closure is neovascular glaucoma. Again, in terms of frequency, it's very common, especially with many diabetics and older patients who develop vein occlusions, that a sudden onset of angle closure glaucoma can be from neovascular glaucoma. Again, the tip-off would be looking at the other eye. What does the other eye look like? Is it a shallow anterior chamber at risk of angle closure? Is it an open angle? So in pupillary block, the flow is impeded as it tries to make its way to the anterior chamber, and there's a pressure gradient that develops, and this is just a very simplistic slide of the flow of aqueous from posterior and anterior, and what happens when we have pupillary block. The classifications of angle closure are acute, chronic, and intermittent, but there is a significant overlap in these conditions, and there's a spectrum of disease. And it's here that I think a lot of us have a tendency to be amazed at this disease process, with chronic angle closure having many of the characteristics of open angle glaucoma. This is frequently missed, and again, because we don't, as clinicians, use our gonioscope as frequently as we should. With intermittent angle closure, patients have periodic episodes of blurred vision, halos, mild to severe pain. IOP is normal in between attacks, and the gonioscopy will lead us in the direction of this diagnosis. We can see pigmented angles or peripheral anterior synechii. It can be confused with Posner-Schlossman syndrome, but routine gonioscopy and careful history will allow for the diagnosis. So this is an interesting case that presented a Chinese male was presented after he had made a trip to Taiwan. So on his way to Taiwan, he had developed pain in his brow, and he called his family in Taiwan from the plane and said, "I'm having a problem with my eye." He was immediately seen when he got off the plane and immediately treated with a peripheral iridotomy. If you ever talk to an ophthalmologist from China or Taiwan, they'll tell you they're very familiar with angle closure because of the higher incidence of the disease. Patients had stated that he had had these episodes in the prior years leading up to this event, and what had happened was he'd go home after a day of work, go to sleep, and what appeared to happen was that the symptoms would resolve. When he gets on the plane and flies 20 hours from Detroit to Taiwan, he doesn't have that episode for the closure to resolve, and he stays in angle closure. When he comes to the office, he's on multiple medicines, he's on pred, and he seems to be stable in terms of his IOP, but his vision is poor from corneal edema, and his angle really does not open in the left eye. Over time, the edema resolves, and he basically turns into what would be considered a chronic angle closure case. We did a LPI on the other eye. We wanted to make sure we didn't forget about that, certainly at risk of angle closure. We monitored him on drops, and over time, his vision worsened because of cataract, and his pressure creeped up into the 20s. We did a cataract surgery, which was essentially unremarkable. Cataract came out, patient seemed to do well with it. So I won't bore you with the case, but the post-op IOP was controlled and his vision improved to 20/40. You can see the difference in the visual fields, and what's interesting is if you look at his optic nerve, the normal versus the abnormal eye and the amount of cupping. And the OCT of the anterior segment, which is, this is the untreated eye after iridotomy, the eye that did not have the cataract surgery. You can see the angle versus the angle of the eye where the cataract was removed. And you can see that it's much more generous angle. The key point is that angle closure is a spectrum of disease. It'll present in different ways. It doesn't necessarily resolve once the iridotomy is performed and the acute attack is resolved. Patients, after they've had an attack, oftentimes require time to resolve the inflammation and the swelling, and the history and exam will help us make the diagnosis of intermittent angle closure, but it will not necessarily resolve the need for follow-up care. And of course, we know that there are patients who are at higher risk of angle closure, patients who are elderly, women, hyperopic patients. Family history is an essential piece of information that we want to keep in mind, and something that I frequently ask patients that I feel are at risk of angle closure. Pseudoexfoliation, ROP, and retinitis pigmentosa are all risk factors. Patients who have a shallow anterior chamber, less than 2.5 millimeters, and more so as the anterior chamber becomes more shallow, thicker lenses, short axial lengths, and the prevalence increases as the lens grows. But that doesn't mean that angle closure is confined to these groups. In terms of assessing the anterior chamber depth, there's obviously your clinical exam at the slit lamp, but also you can use the OCT, and an IOL master is helpful. So there's many sequelae of an acute or intermittent angle closure glaucoma. So this is not a disease without, or not a problem without disease and sequelae. And the optic nerve can become damaged, obviously, the most obvious, but there's also retinal vascular occlusion, scar tissue in the anterior segment, cataract formation, corneal edema, and acute nerve swelling. So we're all pretty familiar with the signs and symptoms of angle closure, but even so, we frequently will miss these when patients are giving us their history or when we're examining the patient if their intraocular pressure is controlled and their vision is good and we're seeing the patient and we're hustling through a busy day. So this is an interesting patient who presented. She's on the young side for angle closure. She's 27 years old, so white female. She's quite verbal, and she presents to her optometrist with an episode of blurred vision. She says her vision's down. 10 days ago, her vision was quite blurry. She's playing a video game. She vomited several times, kind of racked it up to food poisoning and thought maybe I should go get checked out. Went to the emergency room. She's diagnosed with sinusitis, kind of no big deal. Vision improved, but not back to normal. So she gets in to see the eye doctor, the optometrist. Her past medical history is significant for depression, and she's taking Lexapro. So on initial examination, her vision is 20/30 in the right eye, so it's a little bit down, but no big deal. At least that's what the examiner feels. The left eye, the vision's better. The intraocular pressure is 12 in both eyes. The pupils are normal, and they do a dry refraction, and she's got a little bit of astigmatism and a little bit of hyperopia, which is probably felt to be latent, and she refracts to 20/20. So they went ahead and dilated her and did a refraction post-dilation, which is interesting to me. In my office, I don't generally do that many refractions, but I'm not checking people for glasses. And then her post-refraction, or her post-dilation refraction shows this significant latent hyperopia. She's almost a plus 5 in the right eye and a plus 4 in the left eye. And the dilation showed her basically a normal posterior segment. And the diagnosis was hyperopia. So the assumption was that the patient symptoms were related, her visual symptoms were related to her undiagnosed hyperopia. So the story doesn't get better from here. 2 days later, she returns. She's seen by her ophthalmologist, who diagnoses her with acute angle closure. The intraocular pressure is high in both eyes, and the corneal is hazy. Iridotomies were done, and the patient was sent home. She came back. She was the feeling was maybe the LPI wasn't patent. It was repeated, which is perfectly reasonable. Her intraocular pressure stayed elevated. She was on maximum medical therapy. She seemed to be getting better. Her vision did improve. Her pupils stayed persistently dilated, and her intraocular pressure was 18. She's referred over for evaluation, further assessment, and her intraocular pressure had increased back up to 44 in the right eye. Pupil remained dilated in the right eye. Again, LPI was repeated with the idea that perhaps it wasn't completely patent. On the gonioscopy, her angle was closed, did not open. So the question was, to what extent was this a aberrant angle closure with synechial closure, because it's pretty rapid progression to total synechial closure in the right eye versus some other case. Lexapro has been described as causing uveal effusion, and a UBM was ordered to rule out uveal effusion. The UBM was done and was normal. The IOL master was performed at this point, and after a long discussion with the patient, decision was made to proceed with lensectomy combined with ECP and goniosynechial lysis. This is the anterior segment, and you can see it appears narrow, but it's not, crazy Bombay or by any means. The optic nerve, there is some cupping relative to the other eye, but it's not an extreme amount of cupping. We did an IOL master which showed a significantly shortened eye, and the anterior chamber depth, you can see, is 2.47 millimeters on the right eye, which again is not totally within normal, but not extremely narrow. And so we did her cataract, and this was an easy one because it was a 27-year-old lens. We expanded the wound for thicker IOL, did ECP. So that's the ECP probe going in. And here we're coating the cornea, and we're gonna view the angle, which is closed. You can see the iridotomy, iridotomy there. I'm gonna go in with micro forceps and try to tease the angle open. Surgeon has a very shaky hand. And you can see there's some blood formation, but if you watch carefully, you can see the angle open, and now the viscoelastic shows the angle open back to the scleral spur. So there's some discussion about the benefit of goniosynovitis in patients with angle closure, whether it's beneficial or not. I think that the big study that was done that showed that there was not benefit did not look at patients like this, where there's 360 degrees of synovial closure. And so in her case, I think it was definitely made sense. You can see the nerve changes post-surgery, so whether or not this is nerve swelling or actual reversal of cupping, I think only time will tell. I think the history is important. So as all of us are familiar with, patients come in complaining of eye pain all the time, and it's frequently dry eye, it can be migraine, but we have to be alert to the possibility that it could be angle closure, and that could be intermittent angle closure. And the best way to tell is by not only looking at the slit lamp, but by doing gonioscopy on patients. And so if you're not doing gonioscopy frequently, I would encourage you to do it more frequently, to practice. It's a skill that comes with repetition for sure. And watch out for medicines. In that study that where they looked at the Medicare patients, many of those patients were on medications that put them at risk of angle closure. And so we're all aware of the risk of medications causing angle closure, but there's a tendency for us to ignore these even though we are aware of the risk. And finally, cataract removal is certainly helpful in the management of these patients. So there's a study, the ZAP study, which is a single-centered study that was done in China, where it looked at patients who were very high risk of angle closure. And the study showed that the incidence of angle closure, even in these high-risk patients in a high-risk population, was quite low. So that few patients in either group progressed, 19 in the treated group versus 36 in the untreated group. And basically, patients were randomized either to get an LPI or not. Angle closure was noted in 5 untreated patients and 1 who had an LPI. And this is a key point, dilation is a precipitating event for 4 of the eyes. So does this match what we see clinically? My tendency was, after the study came out, to be much less aggressive with prophylactic iridotomies, because after all, the study shows that even in high-risk patients, the incidence of angle closure is quite low. But I saved this slide to show after 2 incidences of angle closure cases were presented to point out that, number one, this is a very significant and devastating disease, and that prophylactic iridotomies are quite, benign is not exactly the right word, but quite safe and reasonable to perform. So I think that as clinicians, we have to take data and put it within the context of the greater concept of what could happen to our patients. So the incidence of angle closure is much lower than what we would expect in these high-risk patients, but it's twice as common in untreated eyes. And again, dilation is a major risk factor. So then you have this patient come in. She's a 50-year-old Chinese patient. She presents for evaluation from a local optometrist who noted narrowing in the anterior chamber. Patient denied any ocular problems or blurred vision, headache, or brow pain. She also states that there's no family history of ocular disease or specific glaucoma. Patient noted to have a normal IOP, shallow anterior chamber, narrow angles by slit lamp examination. Gonioscopy reveals 4 quadrants of trabecular meshwork only visible with compression. So this is what I would call like a grade 1 angle. So a grade 0, grade 1, where you can't see any meshwork except when you compress with gonioscopy. So the question is, how do you approach this patient? And I'll tell you how I would approach it, and I'm certain that people may have different ideas, but I would generally say to this patient, you have these narrow angles, you're at high risk of angle closure, and your options are either to have an iridotomy or to watch this. But if we watch it, you're going to have this hanging over your head basically for your life until you do something like a cataract surgery. So my recommendation generally would be to perform the iridotomy. And then if the patient chooses to proceed, which they generally would after that kind of recommendation, I think it's a reasonable course forward. So in terms of performing an iridotomy, I generally use an iridotomy lens. I know that not everyone does this. I think using a goniotomy or using an iridotomy lens with goniosol decreases the amount of heat that's produced. It could reduce the risk of a corneal burn. The button magnifies the view and spot size on the iris. And I think it holds the eye open as well, stabilizes the eye, and makes the procedure easier. Well, right. Right. So there's workarounds, but right, some coupling agent. So preoperatively, we use tetracaine. We usually pre-treat with brimonidine. We use pilocarpine ×3 to bring the iris down, find a good crypt. And what I would say is that it's worth taking a minute or two to really assess the iris to find where a thin area would be, especially in patients who have darker irises. People have pre-treated with argon laser. I generally don't find the need to do this. Power settings will vary from patient and practitioner. So what I would say about the power settings is this. When I was a fellow, we used 6 millijoules of power on every single patient. Now, as a fellow in Detroit, where most of the patients were African American, and they had very dark irises. But I would also say that patients really felt it. It was very uncomfortable. And what I've done at this point is turn down the laser power to 3 millijoules in most patients. Even if they're African American, I find that I'm able to get through in 95%, if not more, without a problem. If I do have a problem and I'm not able to get through, let's say there's a lot of bleeding, I'll generally go to a different spot. If I feel like the eye's been traumatized too much or the patient's not tolerating it well and there's bleeding, I feel like I can't get through, I'll have the patient sit back and I'll say that I feel like they need to come back for a second treatment, which I think I've not had a problem with patients being resistant to this, and generally they quite understanding. But finding a crypt is helpful, and using less power, I think, is also helpful. I generally do not stop blood thinners. I never have. And what I would say about the bleeding is that it's almost always self-limiting. Dr. French, who's in the crowd, who I see, taught me that if there was bleeding after an iridotomy, you could hold pressure with the lens, and that's pretty effective, and I still do that. So where should the iridotomy be placed? Dr. Taylor went over some of the studies, but basically, is there a good place versus a bad place? I'd say that what I get from this space study that was done is that you should avoid an area that's going to be partially covered. Either you should pick a fully covered area underneath the eyelid, or a fully uncovered area temporally or nasally. And avoid like kind of that 10 and 2 position where you are more likely to have a tear film meniscus getting a prismatic effect for dysphotopsia. And the thing is that we see that there is some deepening of the chamber after an iridotomy, but it's usually not dramatic. And certainly removing the lens gives us, as many of us have seen, when you remove the lens, the anterior chamber just becomes so much deeper. And that's, at least part of the genesis of the EAGLE study, which is the effectiveness of lens extraction in patients who had angle closure. And Dr. Taylor went over this, but in patients who had elevated intraocular pressure and they had angle closure, whether it was acute or chronic, the study didn't differentiate, but patients had better IOP reduction and better long-term outcomes with cataract extraction versus iridotomy. It doesn't mean that patients won't benefit from an iridotomy, and it doesn't mean that that's not an appropriate treatment at times. And so a lot of it's going to depend on what's going on with the patient, their comorbidities, their ability to tolerate something like cataract surgery. So all those things go into it. So just because you have a study that says that lens extraction is better than iridotomy doesn't mean that that's 100% appropriate at all times. So here's a 65-year-old patient. She presents for a routine diabetic eye exam prior to dilation. It's noted her anterior chamber is shallow. On gonioscopy, trabecular meshwork, again, is not visible in any quadrant. IOP is 28 with a central corneal thickness of 55. But let's say the IOP was normal. I don't think it would really impact how you would proceed. Cupping is observed to be 0.4. Cataract is noted to be 2+. Vision is 20/25, and the patient has mild visual problems when driving at night. So the question is, how would you proceed with this patient? And again, I think this is a patient that you'd have to have a conversation with. Is this seems perfectly reasonable to proceed in a couple different fashions here. But you could perform a peripheral iridotomy, or you could go right to cataract extraction with IOL. Certainly you wouldn't do pilocarpine. I would not recommend dilating this patient, even though the incidence of angle closure is quite low. Does anyone, you want to do a show of hands? Who would do iridotomy on this patient? Okay. And who would do cataract surgery? And then I guess there's a follow-up question is, who would do an iridotomy with the idea that you do the cataract surgery soon? Right, so a lot of people would do that.
I think I would do iridotomy and then cataract follow-up, because I do want to look at the peripheral retinal
Right.
cataract surgery, and I would feel safe dilating unless I knew I had an iridotomy.
Right, so the point is, in a patient who you need to do a good fundoscopic exam prior to cataract surgery, and you want to dilate them, doing an iridotomy gives you a level of security and safety in dilating that patient prior to cataract surgery. So that's a great point. So in a patient, so now you do your IOL master, and you've got the patient ready to go for cataract surgery, and you see this little surprise, which is the anterior chamber depth in the right eye is 1.47, and the anterior chamber in the left eye is 2.35. So the lens thickness is equal in both eyes, and the axial length is pretty comparable in both eyes. So in this case, you may want to do an iridotomy and dilate the patient and look for any kind of abnormality in the anterior segment that you wouldn't be able to appreciate. So we went ahead and did this patient's cataract surgery. And it's, unfortunately, it's not the best centered videography, so I apologize. But you'll see the main point. When we went in to do the capsular rhexis, you see the capsule wrinkle. And watch as we pull down on the capsule here. It's just quite a bit of laxity there. So this is consistent with zonulopathy, and certainly, again, it's not unreasonable to take out the cataract, but in a patient who's 20-25, I'm sure there's people in the audience who would say this is overly aggressive. I just want to show one thing on the video. We ended up putting a capsular tension ring in, which is not hugely impressive, but just of interest. So we'll go on to the next slide. But the capsular tension ring went in no problem. And as far as I could tell, there wasn't any evidence of pseudoexfoliation, so it felt like this was more likely some remote trauma. So to finish up the conversation on angle closure, I wanted to bring up aqueous misdirection or malignant glaucoma. And so there's a lot of discussion in the glaucoma community about what exactly is the mechanism of aqueous misdirection or malignant glaucoma. But I think the overriding importance is that you be able to identify this as an entity. These are patients that will look like angle closure but won't resolve with treatment typical for angle closure, and they maintain high intraocular pressures and shallow anterior chambers. The original proposed mechanism is that you have aqueous pooling in the back of the eye, forcing the eye shallow and anterior. And there's firstly the medical treatment, which resolves half of these cases, and so it's important to avoid miotics to dilate these patients and to use aqueous suppressants. And this ciliary block for surgical treatment is firstly to try to disrupt the anterior hyaloid face, and then secondly, if patients are refractory, to consider doing a pars plana vitrectomy, but most importantly, to create a unicameral eye So you're going in, and you may not be doing this, and I certainly wouldn't be doing this, but to do a vitrectomy, but to make sure that the vitrectomy creates a unicameral eye. And I really enjoy this slide because it shows the incorrect procedure being performed. So you have a vitrectomy being performed, but not not going through the iris and not creating a unicameral eye. So as a early in practice glaucoma surgeon, I had a patient with aqueous misdirection. I sent the patient to the retinal group that we work with frequently, and they called me after the vitrectomy and said that the aqueous misdirection had been resolved on the patient. And the next day I saw the patient, they were right back in aqueous misdirection, and they had performed a vitrectomy in this fashion outlined on the slide and not done the zonulectomy and the iridectomy. And so it's important that whoever's doing the vitrectomy goes through the iris and goes through the zonules to create this unicameral eye. So I've got just a couple minutes left, and I want to show just a couple quick this may be pushing what's reasonable, but probably everyone would rather see and talk about some surgery rather than anything else. So minimally invasive glaucoma surgery is definitely a big area of interest now, and I'm sure everyone in this room has a different approach to what they're doing with MIGS, and I thought I would just kind of highlight what I'm doing in my practice. And so I don't have any financial disclosures and multiple references. So the issue for us is that, you know, if you're a general person, you're seeing glaucoma that you want to manage, and you don't want to make the step to doing these procedures you did in residency or you do infrequently and have all kinds of complications, including trabeculectomy and tubes. And so the MIGS space gives us an opportunity to intervene in glaucoma less aggressively, but still be treating the patients and hopefully decreasing the burden of disease. So people have kind of made fun of MIGS by calling them minimally modest glaucoma surgeries, but I think we're seeing more, you know, just many examples of benefit from MIGS procedures. And so again, these are patients who generally have more mild to moderate disease, who don't need trabeculectomy, who don't need tubes. They could benefit from a modest intraocular IOP, or rather a modest IOP target. And so there's many, many options. And I would say that in general, to this point, I have stuck with MIGS procedures which don't involve leaving a device in the eye. But that doesn't mean it's the right approach. It's just the approach that I've taken to this point. This is a study from 2017, nationwide, almost 180,000 glaucoma surgeries performed, 22,000 trabeculectomies, and about the same number of tubes were put in. So that leaves about 130,000 MIGS were performed. And so we know that there's several areas we can target with our glaucoma surgery, and we can go for Schlemm's canal, we can go into the suprachoroidal space, we can go at where the aqueous is being made, and we can go subconjunctivally. So we can treat the ciliary body, we can treat it internally or externally, and this is the micropulse probe. This is treating it externally. And so just give you an idea of what this looks like. Kind of placing the probe on the outside of the eye and treating it with this sweeping fashion. And I will say that I've been underwhelmed by my results with micropulse. I don't have a lot of confidence in it, but it may be something related to my technique. But I've moved significantly to doing low-powered cyclodiode, photocoagulation with the diode, and I have that is easily accessible for me. But again, I think this is a nice procedure, and you can see you don't have to make an incision. There's no risk of infection with the procedure. And then this is ECP. Usually you've removed the cataract, and we're treating the ciliary processes from the inside with a laser probe. And this is quite easy for a cataract surgeon to perform. And it helps to have a good assistant who's operating the probe at the level of the machine, who's kind of following you and rotating the probe as you go along. A good assistant is helpful, and it's not that hard to train them to do that.
I know the way you do it, but sometimes they show a technique where you just sweep, and I think that
So Leo said he's seen a technique where you just sweep, which I think you certainly can do. I don't think will make a difference in terms of your outcome. I would say in terms of the management, it's similar to cataract surgery alone with the ECP. I do use intracameral dexamethasone, which I think is very helpful, even though it's very short in duration. And I do leave patients on steroids for longer. So I use topical steroids in all my cataract patients. I know many people don't. But so if my typical postoperative course was a month of topical steroids with a taper, I'd probably do 2 months in someone who had ECP. And if they were African American, probably 3 months.
You know, I've switched to using that stanza,
Uh-huh.
and then having them just use twice a day, 1% Forte, and I have had no increase in inflammation. It sort of cuts down how long you have to use the drops. Just an idea.
No, I think the management of steroids is definitely kind of one of the tricky areas when you're getting into any of these MIGS procedures and figuring out, because some of these patients are more sensitive and you'll see a steroid response early. So there's a tendency to want to get them off the steroids early. But in the case of ECP, I think the management of the postoperative inflammation is going to be important if you're adopting this as a new procedure, and definitely something that needs to be modified versus cataract surgery alone. So doing goniotomy at the level of the trabecular meshwork, when I graduated residency, I thought goniotomy was just for kids. Now it's for adults too. So, and the Cahook is one way to achieve that. There's other blades available. There's the Scion blade. And so here's a film of a goniotomy with a Scion. So what's nice about the Scion, it's got this little anterior foot plate, so it's easy to tell where you are once you get into Schlemm's canal. Kind of pull that around. And so you can go from the outside in, and then you just actually go in with a forceps and remove what you've excised. But generally, I just leave whatever I've excised in the eye, and it doesn't tend to be problematic. And then there's other canal-based procedures. There's the Omni, the eye prime, the eye track, and then so-called GATT procedure, where you would go in with a illuminated probe, and you're trying to get this outflow pathway opened up. So the Omni is a device that's pretty convenient and easy to use. You can hold it in one hand. And so here's a little schematic of how it works. And then here's an actual video. It's not very convincing that you're in the canal here, but watch as we go the other way. So the idea is that you can go 180 degrees one way and 180 degrees the other way. So there you're, more convincing that you're in the canal. And then you can come out and then go back in and actually tear the trabecular meshwork out, open up Schlemm's canal completely. In my experience with the Omni, there's a lot of bleeding. So if you don't tear, you won't get that bleeding. So if you want to just do the viscocanalostomy, it's perfectly reasonable. But if you do tear, you will get bleeding. And so generally what I'll do is be pretty aggressive in tamponading the area that I've treated, and I'll leave the pressure quite high when I leave the OR. The way that I manage that is by giving the patients Diamox in recovery, and then Diamox to take at night and when they're wake up first thing in the morning. So typically, even though I'm leaving the pressure high, I don't see high post-operative IOPs on day one. I give them oral Diamox. I give them 500 milligrams in recovery, and then 500 milligrams to take that evening and again in the morning. I always stop blood thinners on all my angle-based procedures. My partners do not necessarily do that, but I think the bleeding is such a significant problem in these patients. And if they do hemorrhage heavily, their visual recovery is so delayed. It's very frustrating for the patient. So I do always try to stop the blood thinners if I can. And so one last thing is getting into the subconjunctival space, and Dr. Taylor talked about this with the Zen stent. I personally have found the Zen stent to be a nice additional therapy. And so the Zen is what I would consider a light modification of a trabeculectomy. So you're getting a bleb, but you're not, the bleb is not as aggressive, and it's more posterior. So this is a borrowed video where you go ab interno, and there's a variety of modifications to this ab interno. And I just want to show, I've switched in many patients to using an ab external approach, where I open up the conjunctiva, and then I'll put the Zen in externally. So I know we're out of time, but I want to see if we can get the pleasure of watching the Zen go in here. But anyways, you open up essentially like a trab, and you don't, I actually have found that you don't need to be quite as aggressive as this in opening up the conj, and you can make a very small conjunctival opening, but this just illustrates where we're at. Measure back about 2 millimeters. It's not 100% necessary to mark quite that much. And then here's the Zen inserter. I do use Mito, and usually I'll inject Mito at the end of the case, like adjacent to, but away from the bleb. So what's nice about putting these in ab externo, in my experience, is, number one, you really get a good sense of where the tube is, or where the Zen is, and you don't have the positioning issues that you have doing an ab interno. But obviously it's more traumatic to the conjunctiva. So with that, we'll end. Thanks for your attention.
Okay, yeah, whenever.
Good morning, everybody. Thank you for attending this Pediatric Ophthalmology What's New. Hello, I'm Maya Kohara. Presenting, I'd like to introduce Mary Lim, who is from California, Shauna Berry, who's from Florida, Austin Bach from Florida, and Nicholas Sela as our guest panel. So before we dive in, I'd like to show you how we cherry-pick the scientific papers we're about to discuss. There was a total of 28 journals and 267 articles related to pediatric and strabismus, and they were reviewed by APOS members. Of these, we picked the top 2 or 3 articles of each subtopic, and we will be presenting the all-star papers today. You may find a copy of the articles in your app. It'll be under the information section, the very bottom. So I'd like to have Mary Lim come up.
Good morning. I'm curious here, how many pediatric ophthalmologists are there in our audience today? 1, 2, see a few hands. I've always been curious about the osteopathic docs doing that. I'm Mary Lim from San Ramon, and I will be talking about what's new in amblyopia and refractive error, and I have no financial disclosures. So the first article I'm going to talk about is the risk of recurrence after cessation of dioptic binocular treatment of amblyopia. And this journal was published in October 2023 in the Journal of APOS. So with a little background, if you weren't here yesterday for Dr. Sela's lecture, on the left is a device called luminopia, and on the right is a device called CureSight. And these are versions of dioptic treatment, and they're designed to promote binocular vision and reduce the suppressive interactions in the visual cortex by rebalancing the visual stimuli between eyes. And you can see in the pictures of luminopia by blurring out the stronger eye, and similarly with CureSight, a central blur, essentially. So this study looked at the long-term effects of visual gains from dioptic treatment because there are many studies that show that it's effective to treat childhood amblyopia in comparison with the traditional methods of patching and atropine. And again, with the theory that it reduces that intraocular suppression, are these more sustainable compared to those other methods? So it looked at the risk of amblyopia recurrence after cessation of dioptic treatment and aimed to examine the relationship between the risk of recurrence and factors like child's age, amblyopic eyes' best corrected visual acuity, stereo acuity, ocular alignment, treatment after trial completion but before recurrence. It was a prospective study done at the Retina Foundation of Southwest in Dallas, Texas, and it looked at 100 children aged 3 to 10 years old who were successfully treated with contrast rebalance treatment, and they were diagnosed with amblyopia that were secondary to strabismus, anisometropia, or both. And part of the criteria and you can read below, baseline amblyopic eye, best corrected visual acuity, and then with interocular difference, greater than 0.2 logmar, and the alignment with surgery or spectacle correction to within 4 prism diopters of orthotropia. And so again, these children had been successfully treated to greater than 2 logmar, 0.2 logmars improvement, or greater than or equal to 0.2 logmar best corrected visual acuity with the contrast balanced binocular treatment. And they were observed at 6-month intervals until the recurrence of amblyopia, or for a maximum of 3 years after the cessation of this binocular treatment. And the study included children who only had binocular treatment and those who had binocular treatment followed by additional treatment for the residual amblyopia. Few more data points here. The mean age at completion was about 6.9 years. The mean best corrected visual acuity at the end of binocular treatment was 0.24 logmar, with mean improvement of 0.21 logmar. The mean follow-up with no recurrence was 20.4 months, and they capped it at 39.9 months. 38 of these children had no additional amblyopia treatment, and 62 children had residual amblyopia after 4 to 8 weeks of binocular treatment, who then had additional patching, atropine, or binocular treatment, or a combination of the above. So the results show that there was a 24% recurrence risk by 36 months for all children. The mean recurrence was at 11.8 months. And if you look at figure 1, it just shows that at 6 months, the recurrence risk was 9%, 12 months, 15%, and then so on and so forth, and you get 24% by 24 months. There was no significant difference in recurrence risk for children that had additional treatment versus those that did not, and this was 19 and 32% respectively. So the risk of recurrence was similar between children who had no additional treatment after binocular treatment compared to children who had no additional treatment after patching or atropine, and this data was from other pedic studies, and with the percentages at 28 and 24%. And there was no statistically significant associations between the recurrence of amblyopia and the factors age, best corrected visual acuity attained, stereo acuity, ocular alignment, and treatment after trial completion. So some limitations of this study was that lack of standardization in treatment protocols, and then they had some challenges with follow-up as well. So in summary for this paper, the overall recurrence risk was 24% during the 3-year follow-up, and it contradicts the preliminary hypothesis that vision improvements from contrast or balanced dichoptic treatments are more sustainable than monocular treatments, and highlights the need for continued monitoring in these children. The next article that I'm going to be talking about is on the topic of refractive error. And the paper is Effect of Atropine, Orthokeratology, and Combined Treatments for Myopia Control, a 2-year stratified randomized clinical trial, and it was published in the British Journal of Ophthalmology in November 2023. As a little background, atropine and orthokeratology can slow myopia progression. And there are studies that show that combining both can have better efficacy than monotherapy alone. But there are not many studies looking at the long-term effects of this. So this was an age-stratified randomized control study aimed at comparing the long-term, which they've set at 2 years, efficacy among atropine, orthokeratology, and combined treatment with the axial length as the main outcome. So this study included 164 children in Guangzhou, China, ages 8 to 12 years of age, with a spherical equivalent refraction of -1 to -6 diopters. The inclusion criteria included having no more than greater than 1.5 diopters of astigmatism, no more than 1.5 diopters of anisometropia, and the best corrected visual acuity no worse than 20/25 in both eyes. Normal intraocular pressure and binocular function. They excluded children who had other ocular pathologies such as strabismus, allergic conjunctivitis, dry eye, or who are already undergoing treatment for myopic progression such as ortho-K, atropine, multifocal lenses. Sorry, hit that. Or if they had other systemic disease that limited their cooperation in the study. These children were then stratified into two age subgroups, 8 to 10 and 11 to 12 years old, and two spherical equivalent refraction subgroups, -1 to -3 and -4 to 6. And then they were randomized to one of these four groups. So the control group had spectacle and placebo eye drop treatment. Atropine group had spectacle and atropine 0.01%. Ortho-K group had ortho-K and placebo drops. And then the combined group, ACO, had ortho-K and 0.01% atropine drops. So the results showed that at 2 years, the axial length change with time was significant for all groups. It was significantly different among fall groups at the 6, 12, 18, and 24 months. Compared to control, all of the interventions reduce axial length elongation at all time points. And the combined group, the ACO group, had significant reduction in axial length at 2 years compared to either the atropine or the ortho-K group. When they looked at the age effect, what they found was that in the younger age cohort, the axial length elongation was significantly reduced in the combined group, ACO group, compared to the atropine group, but it was not significantly different from the ortho-K group. And then in the older subgroup, the opposite was found. So the axial length elongation was reduced in the combined group compared to the ortho-K group, but not significantly different from atropine. And in terms of their secondary aim, they found no interaction between spherical equivalent outcomes. So one of the limitations with this study was that it had a relatively small sample size with a large dropout rate because they did it during COVID. Part of the limitations I felt too was using 0.5 tropicamide for cycloplegia and using an autorefractor for refraction data. And in summary, from the paper, they found that combined treatment was better than monotherapy in these children aged 8 to 12, and they recommended monotherapy with ortho-K for younger children, which I do find is a little controversial because most pediatric ophthalmologists do not use ortho-K. Thank you.
Next, I'd like to introduce Dr. Austin Buck.
Hi, I'm going to actually cut into my time and make a quick comment about that last paper. There's a bunch of papers coming out basically showing how 0.01% atropine doesn't work for all kids, and we should be using higher, like 0.025 and 0.03, and that may have been why that study got skewed a little bit more towards the ortho-K. So for those of you who don't know me, name is Austin Bach. I practice in Southeast Florida, the program director at ACA Bayonet Point. I work with a number of other residencies. I have one resident here at least. So we're going to be talking about a few different things. I have 2 different lectures back to back. So these are my disclosures. None of them are relevant for this talk, though the next one is. The first thing we're going to talk about is the outcomes of inferior oblique myectomy versus recession when they're combined with bilateral lateral rectus recessions and V-pattern exotropias. So this was a study that compares the outcomes of combining a BLR, bilateral lateral rectus recession, together with bilateral inferior oblique surgery, whether it was a myectomy versus a recession, in patients that had V patterns and needed the second procedure together with the lateral rectus recessions. This was a retrospective review of children under the age of 18. It was done over about 1.5 years from December 2020 to May 2022. And they had a minimum of 6 months of postoperative follow-up, which is one of the major issues with this study, is that there's a very, very short follow-up for kids, especially when we're doing strabismus surgery. They'll basically have 2 to 3 follow-ups in that time and not much more with most of us that do these surgeries. So for those of you that remember from residency, do I get a pointer? I don't know. Maybe. Get something. There we go. So a recession of the inferior oblique is basically taking it from next to the lateral rectus and moving it closer to the inferior rectus. Let's see. Versus a myectomy, which is basically just cutting it off. Some people do myectomies, myotomies. Some people cut off part of the muscle versus just cutting it off and kind of letting it go. We'll see how this goes now. The outcome measures were horizontal alignment, inferior oblique function, stereopsis, and postoperative exotropia control score, as well as the need for additional strabismus surgeries. So the patients were stratified beforehand based on the V pattern of having between 10 to 14 prism diopters versus greater than 15 prism diopters. It was a total of 50 patients. They were basically split between the myectomy and the recession of the inferior oblique. Between those 50 patients, there was in the stratification, there was no real difference between age, sex, or follow-up duration, nor were there notable preoperative differences in stereopsis, primary position, horizontal or vertical deviations, the inferior oblique overaction. The recession group happened to have greater V patterns than the myectomy group, 18 prism diopters versus 14 prism diopters. It's statistically significant, though I'm not really sure how clinically significant those numbers really are. At final follow-up of at least 6 months, but the average was well over a year, both groups had a decrease in horizontal deviation and V pattern magnitude, as well as inferior oblique overaction. The greater than 15 prism diopter group, the myectomy showed that it had superior results in reducing the V pattern at distance versus the recession, which was statistically significant. And overall, and within the V pattern subgroups, the bilateral inferior oblique myectomy had better control of the residual strabismus at distance compared to the recession group. So what this study basically showed was that it seems to have been a better procedure, even though it was somewhat of a small study. Once again, it was retrospective, very small follow-up, and an uneven distribution of the exotropia types. You also had multiple surgeons within a small group. And the takeaway, as I said before, is myectomy may have better results with larger V patterns. All right. So the next one, which I think Dr. Salad mentioned, was one of the PEDIG studies, which was an 8-year outcome of results from a previous study that had finished at 4 years of whether doing a bilateral or lateral rectus recession versus recess-resect procedure is better for childhood basic type of intermittent exotropia when compared to divergence insufficiency, convergence insufficiency, or excess. So basically what they did was they reported the outcomes for 8 years of patients who were randomly controlled into either bilateral procedures or or recess-resect for an intermittent exotropia. The data is basically for years 4 through 8 because the first set of data came out for years 4 already. 123 out of the 197 patients that were originally put into the study were reported on and finished the 8 years. What they defined as suboptimal surgical outcomes were exotropia of 10 prism diopters or more by prism cover test at distance and near, or an esotropia greater than 6 prism diopters, loss of stereopsis by 0.6 logmar of arc seconds, and the secondary outcomes that they looked at were the need for reoperation at 8 years, as well as complete or near complete resolution of the intermittent exotropia, and anything else that, any parameter better than the suboptimal groups. So which ones did they do better at? Which ones were closer to orthotropia, or which ones had better stereopsis? So the results, suboptimal outcome was noted to be more in the bilateral group versus the R&R group. Complete or near resolution was seen more in the R&R group. The probability of reoperation was 30%, much higher in the bilateral group, although none of these were statistically significant. As you can see, where am I? Over here, everything kind of crossed over, even though it's obvious that in general the bilateral group was lower, it still didn't reach statistical significance. Did I miss something? Nope, there we go. Okay. So the possible reasons for these outcomes, so Berg-Kushner hypothesized that the restriction created by the medial rectus tethers the eye in place and decreases the tendency to do an outward drift, and that's why operating on the medial helps to decrease the recurrence or the need for more surgery or the poor outcomes. It could be that the dose tables that were used, and we all use different dose tables. I have 3 that I use and kind of issues. They were insufficient for the bilateral rectus recessions. And it also shows that there is no statistical significance between the two groups of whether it's a bilateral surgery versus a unilateral R&R, but the long-term outcomes may be better with a unilateral surgery. All right. So this is another strabismus paper on the surgical approach and reoperation for intermittent exotropia. It's another retrospective. This is a retrospective study, unlike the PETA group. It used the IRIS registry, so there's going to be a lot more papers. This is a big data study done by Dr. Hunter. And there's over 7,000 children, mean age of 6 years, where about half of them were male, half female. They underwent strabismus surgery over a 5-year period. The children with initial surgery involving 3 or more muscles, vertical muscles, or were reoperation were excluded. And the bilateral lateral rectus recession was done significantly more than in R&R, which also compares to the previous study of which ones potentially may be better, or maybe stronger or better in terms of long-term outcomes. And this is they had an adjusted 5-year cumulative incidence of reoperation of 21%. Which is a decent amount, and we'll discuss that a little bit afterwards, of like timing for intermittent exotropia. So the bilateral lateral rectus recessions had a higher incidence of reoperation than the R&R at 1 year, 5.4% versus 4.1%, which isn't that much, and it continued and diverged a little bit at 3 and 5 years. The unilateral R&R was associated with a lower 5-year reoperation risk than the bilateral, and the adjusted hazard ratio was 0.77, so it was a decent amount. The younger age at time of initial surgery was at a higher risk for reoperation, and you'll be able to see we'll have 2 nice, there we go. So as we get further out, it becomes actually statistically significant to the difference between the 2 groups, even though, remember, there was a much, much larger group of the bilateral surgeries versus the unilateral surgeries, and although over here it was not necessarily statistically significant. The limitations of this study was that there were many, many surgeons in an IRIS registry study, and choice of which surgery to do based on the presentation of the patient was not included in the IRIS registry. Decision for reoperation is also something that can have confounding issues that was also not discussed in the IRIS registry. Unilateral poor vision usually gets an R&R and will have a much higher likelihood of reoperation. Indications for reoperation were not identified in the study. The 5-year follow-up may not be long enough, especially some of these kids are 6 years old, so 5 years, they're still only 11 years old. And that's the average. Some were younger, some were a little bit older. So basically we need further go back for a second. There are further studies that are needed to figure out what things we need to do and what things we need to look at in order to decide what kind of surgery we need to do for intermittent exotropia and the timing. There's a lot of treatments that we're able to do optically. I have a number of patients in prisms that are doing very, very well, that are very, very young, and I just hesitate to operate on them just because of the poor long-term success rates and the need for reoperation. And if I can hold them off and keep their stereopsis and vision for longer without operating, it just gives me kind of more hope that I'll do better for them long term when I need to do the surgery. Next one we're going to be discussing is surgery in thyroid eye disease. So this is what's called the intraoperative relaxed muscle positioning. It's a technique for strabismus surgery in thyroid eye disease. Basically what you do is, or the way I do it, is you take the muscle off, you figure out kind of where it wants to be, and you let it be there instead of actually doing measurements that we do for most of the other surgeries. So you let it go to a place where there's no more tension, and that's where you suture it down, whether you're doing a hangback or suturing to the globe. Long-term outcomes for patients who underwent this procedure. It's a retrospective study done between 1999 and 2021. That was done by Dr. Tripolsi. This is a one-surgeon study, and it looked at their long-term outcomes. So what they kind of decided what are excellent outcomes. So excellent outcomes is no diplopia in primary and reading positions, which is straight and just down, and that's no diplopia and no need for prisms. Good outcomes were residual deviation of less than 10 prism diopters, and they had diplopia, and they in the primary and reading positions. These were considered successes because they were able to be treated with prisms or not needed. Poor outcomes were greater than 10 prism diopters with diplopia, and the fact that they were not able to tolerate prisms in these positions. So there was 129 patients in this study. They were followed for an average of 4.25 years with up to 20-year follow-up. 96 of the patients, which is about 75% of them, underwent a single surgery. 33 patients, 25% underwent additional surgeries. 7 of these patients were actually planned 2-stage procedures, which we do significantly in strabismus. 93% had successful outcomes, which was either excellent or good, which means only about 6.5% didn't. The strengths of this study was that it was a large cohort of patients. It was a single surgeon with decent follow-up. What's important for this study is that the orbitopathy, there's no inflammation in the orbit. When there's active inflammation, I tell all of my thyroid strabismus patients beforehand is I can do a great job, and if you start smoking and you get some inflammation in 2 weeks, my surgery is going to suck, and you can go back exactly the way that you used to be. So this, basically what the takeaway from this is that it's a very good approach. The approach lasts long, and you won't even necessarily need to do a reoperation for the same cause. Comparable rates have been reported for just doing adjustables. These were not adjustables. Disease reactivation and the magnitude of the angle predicted the need for additional surgery. I guess I'm still going. So next is a little different. We're off of the strabismus topic. I think you just deleted my. This is the next one, right? The next set, yeah. So this is the next lecture. So this is the role of OCT in evaluating papillitis in children with uveitis. So this happens to be a kid of mine with VKH. She had an opening pressure in the 40s and tons of uveitis. So what this looked at is optic nerve swelling or papillitis, which is a common finding in childhood uveitis. Is an increased interest in multimodal evaluation, especially because kids are a little bit more difficult to get FAs on. Some of us even do it oral FAs. So the study aimed at determining the diagnostic value of RNFL in diagnosing and monitoring papillitis in children with uveitis. I do it significantly. These are actually printouts from my office. It's the same patient. And you can kind of see progression over this maybe even 2 years of her and how she looked, and following the RNFL and the macular thickness, the GCL. So this is a retrospective study of 455 eyes of 257 patients with uveitis, of varying types of uveitis. 93 of the patients underwent both OCT, RNFL, as well as FA, which is the gold standard for diagnosing papillitis. And this is basically what they did, they found patients with uveitis. They excluded a few of them for other pathology on the optic nerve. Once they excluded those, they tried to do FA and RNFL on them. They saw which patients actually had papillitis based on the FA and which ones didn't, and then they made a cutoff on the OCT as the main number for the overall number of the RNFL thickness being 130 microns, and that's what they used as the cutoff for diagnosis of papillitis. It should be in everybody's OCT. They give that one main number, which we rarely look at. Still the same patient. This is a few weeks ago, actually. So using global OCT RNFL, thickness of greater than 130 was seen as the ideal cutoff. Once again, the sensitivity and specificity is not great. You don't really want an 80 to 85% sensitivity or specificity when you're trying to diagnose papilledema, but it's something nice to look at. I usually look at the whole thing in each quadrant. I use this. I don't even look down there. But they cut it off at 130, and I think you can use that as an overall of like, I'm not sure whether or not it is, and it's over at 130. Let's assume that, and maybe we need to do an LP on this patient. I actually have a 3-year-old that I'm trying to get an LP on now for this. So significantly associated with the higher prevalence of CME, active uveitis, and optic disc swelling on fundoscopy. When you have an OCT thickness greater than 130 for the RNFL. And that was that. So, there's an issue. So I have for this lecture, I do have, I am a speaker for, I guess, Amgen now. So we're going to discuss Tepezza a little bit here. So this is the treatment of thyroid eye disease and myopathy, with treatment of intraorbital injection of 5-FU and triamcinolone. So these patients were active TED patients that required therapeutic treatments to suppress the immune response, the active inflammation, and what they were trying to do is to limit the sequela of scar formation in these patients. So there's a number of things that were done: systemic anti-inflammatories, orbital radiation. Tepezza has been used for long-term treatment, or at least 6-month treatment. Intraorbital injections with steroids have been used, and they've been used for the myopathy as well as the eyelid retraction since the 60s, but 5-FU has not been documented before this study. So evidence shows that 5-FU is great with keloids and arresting fibroblast proliferation, and which is very similar to what we think of or what we know of as causing the issues in TED. So what they did is they used 5-FU plus triamcinolone and Lido with epi as injections for patients with TED. Sometimes they tried to do it both in clinic and the OR to see which ones they were able to do. When they did it in clinic, they would inject it subconj or subtenons over the medial rectus and the inferior recti muscles. In the OR, they would kind of go all over the place. They'd use an angiocath. It was a lot easier. So they only had 7 patients. So this is kind of like just their first study that they were saying, hey, this is a really cool thing that we can do. So all the patients had an improvement in motility. 5 out of the 7 patients had an improvement in diplopia. And it's just an interesting new approach that may be really good for active TED that's brand new and you're working on figuring out what other treatment to do of like, hey, I could do an injection in the clinic, especially if you have oculoplastics people with you and you have access to the 5-FU right there. So the potential complications are retrobulbar hemorrhage, blindness due to injecting the wrong place, worsening of the myopathy due to the local anesthetic. Limitation is, it was a single center, 7 patients. So, as we discussed, this could be a nice bridge therapy while you're getting them on all the other things that are a little bit stronger for patients that are really active. And we're going to go to the next paper.
So, in interest of time, we'll move to.
Excellent. I'm going to get to you, Shauna.
Thank you. I'd like to have Shauna Berry come up. Thank you.
All right. I have no financial disclosures. So I'm going to talk about the pediatric ocular melanoma, which was a collaborative multi-center study and meta-analysis. So the aim of this study was to investigate ocular melanoma in pediatric patients aged 12 and younger. It was a retrospective, multi-centered cohort study supplemented by individual participant data and meta-analysis. So this included 133 eyes from pediatric patients with various ocular melanoma types, the most common being choroidal or ciliary body. Iris accounted for 25%, conjunctival 19%, and eyelid was 3%. The mean age of presentation was 7 years, with the youngest being one year old and the oldest being 12 years old. Pediatric ocular melanoma displayed unique clinical characteristics and prognosis compared to adults, underscoring its rarity and distinct nature. So the mean age by tumor site, choroid ciliary body was 6.5, iris was 7.4, conj was 9, and eyelid melanoma was 5.6. Association with ocular melanocytosis, the highest had choroid or ciliary body melanoma with iris 11%, conj 4%, and eyelid was 0%. When it comes to metastasis, the most common location of METs was the liver, and it was actually highest in the conjunctival. All patients that actually had METs with choroid and ciliary body melanoma actually passed away. So death was reported in 12.5% of ciliary body choroid patients, and all of those actually had metastasis. Iris was 3%, conj was 8%, eyelid was 0%. And then survival analysis indicated higher mortality in choroid, ciliary body, and conjunctival melanoma patients. So the strengths of the study involves a collaborative multi-center approach, comprehensive meta-analysis, and it's the largest cohort to date for pediatric ocular melanoma. Limitations included the small sample size in younger patients, the uncertainty regarding pre or post pubertal status due to the age cutoff proxy, lack of standardized treatment protocols, incomplete data and variable follow-up, and limited information on METS timing. So the implications for clinical practice are that clinicians must recognize distinctive features and outcomes of ocular melanoma in pediatric patients, and early detection is most important, and tailored management strategies are crucial for optimizing outcomes in this rare population. So the next study I'm going to talk about is characteristics of pediatric open globe in preschool-aged and school-aged children. So this reviewed the medical records of 93 children, and they were categorized into preschool age group and school age group, with the preschool age group being 0 to 7 years and the school age group being 8 to 15 years. The study recorded demographic data, trauma characteristics, an ocular trauma score, and initial and final best visual acuity, and the data was compared between the groups. So for the results, the preschool age group included 54 patients, while the school age group included 39 patients. Most injuries were penetrating caused by a non-metallic sharp object in both groups. Corneal injury was detected in 83% of the preschool age children and 74.4% in school age children. Corneal wound localization was 46.7% in the preschool aged, peripheral 48.3% in school-aged. Mean corneal wound length in, I think that's on the next slide actually. Results where factors correlated with poor visual outcome included a lower ocular trauma score, worse initial best corrected visual acuity, central corneal wound, a longer corneal wound, and total wound length, lens damage, retina detachment, and hypotony. Poor final best corrected vision correlated with a longer scleral wound and vitreous hemorrhage and uveal tissue prolapse. So in conclusion, corneal wound localization and length is closely associated with visual outcome. Central corneal wound in preschool aged is challenging for visual rehabilitation, and the implications for clinical practice included a high importance of corneal wound localization and length in predicting visual outcome, and consideration for visual rehab, especially in preschool aged children, and probably also keeping sharp objects away from them. And that is it for me.
Thank you, Shauna. Okay, so I'd like to open the papers for discussion. I had a few. So let's start with the first one. How many of you use low-dose atropine in the clinic? Any of your patients you prescribe? Okay. So what is your experience? Does it work? Does it not work?
It's been long enough to know, actually.
Huh?
In my case, I don't think it's been long enough to know. I'm not sure that it's been long enough to know in my practice. I mean, these kids have only been on it for a couple of years now, so I mean, I think it's too soon to say.
Yeah, I started, I guess I graduated from fellowship in 2018. I've been using it since then. I've definitely had like mixed results with the 0.01%, except in the really light-eyed kids when I actually have to have on every other night. I've definitely had better results. I guess we'll call them short-term, like 3 or 4 years results. I've had decent results at 3 or 4 years, but we're putting them on starting at age 7. 3 or 4 years isn't even getting them to puberty. So we need to get like 10 or 15-year results and like making sure the axial length really stops growing at 23. So like 3 or 4 years is like getting an 18-year-old to 21. So the results are like, they're good now, but I can't, it's difficult to speak to it.
Are you monitoring their axial length?
We are, because of the studies that we're in. So we're actually, even in our non-study patients, we're trying to at least routinely do that on a regular basis.
I don't. I actually, the way that I monitor them is I get OCTs and fundus photos every year, and I only do cyclorefractions. I guess I forgot who was the guy who spoke first today said all of his patients have drops before he sees them. I don't see patients without being fully cycloed beforehand, and so my refractions are going to be dead on. So if the refraction doesn't change, either the cornea change shape, but I'm also looking at like the back to see like are there staphylomatous changes on the OCT and things along those lines, and are those changing over the year? Is the RNFL changing? That's a really big thing for me. Like is that GCL thinning out? Those are things that I'm looking at, and like I can show parents like clinically and like, hey, look at this. There's a big change over this year. You really need to start like either doing the ortho-K, I have a bunch of optometrists in my offices, or you need to be doing the atropine, or at the very least the progressive lenses, which a lot of them fight just for price-wise. Not that I really like them, but I prefer the contact lenses. I think my youngest ortho-K patient is 5, but nobody should try that ever again.
Wow, okay. How was your experience?
I think I have been using diluted atropine, but I haven't used it like long enough to really
know.
Yeah, to know.
Mary?
I practiced in Michigan after fellowship, so the patient population was mostly Caucasian who don't really have significant myopic progression, but the rare Asian patient for sure, I've started 0.01%, but of course if all the recent studies like Atlas and the PEDIC studies showing the long-term 20-year non-statistical significant difference, I do think that with the certain ethnic population it might be worthwhile, especially, personally I'm a -11, so would I want my child to be that high? No. If I can decrease it as much as I can, especially when you start earlier, compared to doing, say, something like ortho-K earlier, I think the benefits are worthwhile, but I definitely think there should be more studies for sure for the higher percentages of atropine.
What is your experience on orthokeratology? Who's using it? How many patients? Would you like to comment? You can come up to the mic. We can all hear you.
Yeah, I mean, you know, just like all of these kids, there's varying different pathologies that cause significant myopia, and there's various different levels of myopia. So, I mean, some kids just, if they have significant pathology and they're myopic, you know, I don't consider these things, none of them. But if they're kind of in that lower myopic range, I think Ortho-K works great. I have an optometrist in my office. She's familiar with doing it. We always prefer to do MiSight first, and we typically go with that first with a combination of atropine, but we do use Ortho-K and we get good results. Not every parent loves it, and it can be difficult in young ones, but I have a couple that do it, so.
So my personal opinion is if you don't need to wear glasses or contacts or worry about them during the day, and you could treat the myopia and you could stay in a lens for years, why not? It ends up like being a lot cheaper. I think atropine is, I can get it for $100 for 3 months supply. That adds up over 10, 15, 20 years. And then with Ortho-K, they don't even need glasses because they can never use the glasses. I can get Ortho-K. We use these off-label ones that can get up to -10 and 3 diopters of SIL. So I kind of push the Ortho-K. I've gotten 0 infections. And the WSPOS statement came out basically saying they were just as good in terms of infection as like monthly contacts. So when that came out, I was like, okay, let's try it. So I've gotten really, really good results in Ortho-K and patients staying them in well over a year. And I warn them, like if they take care of them, then they can keep them for more than a year. If not, they may only be able to keep them for 6 months, and then they're gonna be spending a lot of money. So to me, the first line for ones that can do it is Ortho-K, and then I add atropine on top of that. I don't like the MiSight just because of the price. And I know that it's like center distance, which is different than most of the contact lenses, but with like a Biofinity, I can get that also, and they're going to be in a monthly, but it's going to be significantly cheaper. That's why, like to me, like it's nice. I can tell them, okay, you can get a spherical contact lens. So anybody that goes over 0.75, I can't even keep them in it of SIL. You can get a spherical one that's like FDA approved, or we can do something that's not FDA approved and save you thousands and thousands and thousands of dollars, and you could buy them extra toys. So that's my thought about MiSight versus anything else. But I've gotten really great results with Ortho-K if you can get them in, if they're the right thickness of the cornea, if it's everything that needs to be correct. So there's going to be a lot of chair time with the patient, not with me, with my optometrist, because I have no idea how to do it. But I personally like it, and I'm a -1 in 150, so I would never do it to myself. But if I'm a -250 or 3 already, I don't want to be, I played every sport known to man as a kid. I wouldn't want to be in contacts or glasses. I'd want to just walk around with nothing and not have to worry about it. So that's kind of what I tell my patients. It's like I have a lot of girls that are gymnasts, play all different sports, and I have boys that are wild and or play sports, and they love the idea as long as the kids can get it in, and as long as the parents can pay it. They do like care credit and stuff like that. It's not that expensive if you look at it long term. So that's my personal take on Ortho-K. I guess I'm the only one here that does it.
No, I don't recommend it, just for the infection. Right. So how about, how many of you have experience doing strabismus surgery in your practice? How many are doing it as comprehensive docs? Neuro-ophthalmology? How many hands? I saw a few. So can you tell me about your experience? Do you do large unilateral recessions or bilateral recessions?
I'm an IO recessor when I want to weaken it, and from a private practice kind of standpoint, I have a little bit of a different take on how I approach these V patterns. You know, in the real world, if I do 4 muscles at one setting, I'm getting paid 100% for one eye, typically 50% for the other eye, maybe 25 for these, unless it's medical assistance, and then I'm getting 0. And if a muscle's going to take me 20 to 30 minutes, that's what I tell families it's going to take me, and it might take me an hour. IOs I can do quicker. To do 2 hours of surgery and get paid for really one, it would be like bilateral regulars. That just is not very cost effective for me. So when I have a V pattern, I usually will take, if the inferior obliques are the main problem right off the bat, I will recess them. I tell the families that it's going to be a staged procedure, maybe. I go, but if I take care of those IOs and I can collapse the pattern, there's a chance that one of two things might happen. Number one is my horizontal alignment may change. My number might be greater, it might be less. Maybe it's going to be less if it's going to be anything. It may not change at all. So if I commit to LRs and IOs, I could theoretically overcorrect or undercorrect the horizontal. And then the other issue is, honestly, their control over their the intermittent component at distance might be better. So there could be a chance that I don't have to address that exotropy, at least right away. Maybe down the road, yes. So that's my approach being in private practice. I mean, I know that, there's academic centers that, the person gets paid by RVUs, so whatever the hospital gets paid, it doesn't matter. You're gonna get paid by your RVUs. So you can do all 4, and that's fine. Kestenbaums, I have to bite the bullet and do all 4 muscles off the bat because that's the way you approach null point, nystagmus surgery and with head posturing. But that's a private practice aspect of that. And I just want, since I'm talking about exo real quick, my mentor, Jack Baker, told me the day I graduated, he goes, you are gonna learn to hate exotropia. And he is totally right. When I tell my families strabismus surgery outcomes, I say 60% success on my exotropes, about 75 to 80 on my esotropes, and on my hypertropes that are inferior obliques, those are almost slam dunks most of the time. So exotropia is tough, no matter what.
Yeah, no, I push those surgeries off as much as possible. I've done surgery, like a lot, like 7mm recessions, bilateral, and the patient didn't change.
Yeah, oh yeah.
I've had really weird results with intermittent exotropia. So I like pushing them off. I think the studies say like mid-teens. So anything I can do not to operate on one that has single digits in their age, I will not. I'm really going to do everything. I'm going to push them going to a vision therapist or doing the HTS or doing the pencil push-ups. Or I have a 3-year-old that's in 7 prism diopters base in OU and has excellent control, great stereo, 20/20 OU. The eye never turns out. I do anything I can not to operate on them because I just tell them, I can do a really good job and nothing is going to happen and it has nothing to do with me. So I try not to. And I think we are out of time, Austin? 2 minutes. One last question. Any questions in the audience?
Any questions for the audience? Anything on thyroid
Tim, is that your hand up?
disease, OCT? Yeah. Would you?
So no. So that's how I was trained actually to do it as relaxed, as basically I do it as a hangback and then just kind of let it hang back until it wants to be there. His numbers, Dr. Trabulsi, they were not like all 4mm. They were not all 4 prism diopters, 10 prism diopters. They were kind of all over the place. That's usually kind of what I do. I don't even go in with an expectation of numbers.
I think I go in with the expectation of a number, but it turns out I think I'm doing what they're doing, really. I didn't do a hangback. I kind of put it where it's supposed to be, but I would have to agree from my experience. Yeah, mainly the vertical, yeah. And then, the medials, I kind of go in after what I'm at. But I think just anecdotally, I think I get very similar results, just kind of. That's not a bad consideration. No, I don't.
I haven't ever. Although I'm thinking about doing 5FU now.
I do them on. I check my re-ops of the steroid though. I always do.
Re-ops? Are you resections?
I don't. Recessions.
So you're doing another recession where it lies?
Either a re-recession or a different muscle.
I might, if I didn't go all the way back, I might re-recess. Yeah. Or a different muscle.
Any other questions? questions about the OCT papillitis paper? Okay.
Either myopia gets me to start it, or I actually have one retina surgeon and one of my optometrists that are -7, and their kids are like 3 years old and a +50 cyclode, and they're both on atropine. I have a bunch of low hyperope young kids, and the parents are huge myopes, and like the retina surgeon was like, he prescribes it now for the kid. He's like, tell me what to do and I'll prescribe it. Because he sees, he's the one that fixes all the issues afterwards. He does those cataracts in the 30-year-olds. He does the retinal detachments in the 30-year-olds from the high myopia. So he was like, my kid's less than a +1 and he's 5 years old? Absolutely not. So.
Great, thank you.
Thank you.
No other questions? All right. Thank you so much.
So, yeah, we're at the Acunas. I'm in no way affiliated with Acunas whatsoever, but we're at the student research section here, so let's go. My name is Jamie Beckman. I'm one of the PGY4 chief residents at Corwell, Beaumont, whatever our hospital's name is this week. And I'm going to be talking about the effects of streamlined surgical system, which is a glaucoma device that recently got approved last year, versus endoscopic cyclophotocoagulation in primary and secondary glaucomas. So, okay, didn't realize that. Come on in, Ralph. All right. Wouldn't want to. So anyways, so glaucoma, if you don't know, it's a optic neuropathy, typically caused by elevated pressure, or what we're going to call for the rest of the talk, IOP, okay? It right now is the second leading cause of blindness in the world, is the leading cause of irreversible blindness. This affects over 3 million Americans. Likely that number is higher than that. For Black and Hispanic patients, they exhibit more rapid progression than Caucasians do, and every 2 years, patients that are diagnosed with glaucoma will typically have to spend about $2,000 out of pocket in medical expenses and medications. This aligns to a little over $8 billion a year lost in productivity to the United States. So the treatment paradigms for glaucoma kind of go as such. Typically what we want to do is lower the pressure. That's the only treatment we currently have right now to treat this optic neuropathy. So the different types of treatments include oral medications, drops, which are going to be more of our first line, laser treatments, which is becoming kind of more first line now with SLT, and then also traditional surgery too. So most commonly, like I said, we're going to start with drops on these patients. And now with the invention of MIGS, or microinvasive glaucoma devices, right, a lot of patients will get glaucoma surgery at the same time they get cataract surgery, okay? So to go back a little bit in history, back in 1992, endoscopic cyclophotocoagulation was invented. I'm going to be talking about this today as comparison of this new device, the streamlined surgical system. So what this is, this got approved last year off the 510K pathway, which what that is telling you is that they didn't have to do like a huge clinical trial or anything. They basically showed that they are safe to use, and they got approved off of a 20-person study down in Mexico. All right. So this is why I wanted to look into this. I had some surgeons that were doing this, a lot of these. So we wanted to check it out. Is this actually working? So what it is a goniotomy device that pushes a hole, so it does the goniotomy in the trabecular mesh organ. At the same time, when you press down the button, it squirts out an aliquot of viscoelastic to do with the viscodilation as well, too. So it has dual modes there. So we're going to look at a video of this surgery. So we can see we're putting the streamline into the eye there. Sorry, it's a little bit grainy on here. And we're going to target the trabecular meshwork there, and going to go in, press against, causing that goniotomy there, and then you'll see the press, and then you'll see blanching around the area there. That has shown that you were in the correct space, and it has worked then with that blanching. So let me see if I can since, we're just kind of messing around and having fun here for research today. So right here, that was previously pigmented. Now, as you can see, we have blanching there showing they had treatment. So surgeons will typically do 6 to 8 of these. It has enough viscoelastic to continue to do 8 of these aliquots into the angle. So there we go. The next one I want to show you is endoscopic cyclophotocoagulation, or ECP. So the first thing we're going to do is put a viscoelastic into the eye. The next thing is put the actual laser. So on the left side, you're going to be seeing what we actually see in surgery. Obviously, right side is the graphic. So in ECP, we're ablating the ciliary body cells here that produce the aqueous fluid. So we want to lower the pressure, right, by reducing aqueous production here. So when you're doing ECP, you're targeting each individual cell with this laser. You're titrating it up so you get blanching and shrinkage of the actual cell, the cell itself. And you can see on the left side there, once you see all this blanching and shrinkage, you know that you are getting treatment to this area. And you can do about 300 degrees of treatment from one single, from your main incision. So the purpose of this study was to compare the effects of the pressure on patients diagnosed with primary and secondary glaucoma at baseline and 6 months postoperatively. So again, to go back to the original studies that they did on this, they were looking at 6 months as well, but they had washed the patients out of medication, and they had only done 40 patients, and they'd only looked at people with mild primary open-angle glaucoma. So we looked at everything. So we had 3 study groups. We had one that just had ECP, one that had just the streamline, and then the third study group had both ECP and streamline in the same surgery. So all of these are also going to be having cataract surgery at the same time. So they have the cataract surgery first, followed by the MIGS procedure. So this was approved, of course, by the Beaumont Research IRB. This was a retrospective chart review from a single site on 105 patients with 168 total eyes, counting all the groups. All surgeries were done by one of 3 fellowship-trained glaucoma surgeons, one of them being Dr. Citron, if you went to his talk on acute angle closure earlier this morning. So the inclusion criteria included patients that had cataract extraction with one of these 3 or combined from April 1st, 2022 through April 1st, 2023. So, for the patients that had the ECP, all of them were titrated to the patient's needs. So heavily pigmented patients need less laser power as compared to lightly pigmented patients needing more laser power because the laser itself actually targets melanin, okay? Each patient was treated with at least 270 to 300 degrees of it. All the patients with the streamline, so the SSS group, were given 8 goniotomies with also aliquots of viscoelastic. So the primary endpoints for this study were going to be the mean IOP reduction at 6 months and medication reduction at 6 months as well. The secondary endpoints, of course, were going to be best corrected visual acuity, proportion of patients with a greater than 20% decrease in IOP, and I'll explain at the end why that's kind of important based off of the previous studies done. Number of IOP lowering medications per patient, right, and proportion of patients with surgical complications afterwards, because like we know, any surgery can have complications. So here's the demographics from the patients. The nice thing you can see in the 3 different groups there is we had statistically insignificant age, so they were all similar age. They all had similar pre-op IOP, but the main difference is going to be the Streamline and ECP group had more drops. And the reason being, patients that are getting essentially 2 glaucoma surgeries at the same time are going to have worse glaucoma than patients that are just getting 1 glaucoma surgery, okay? So at the bottom there, I know this is kind of a little bit of a heavy chart, okay? You can see the proportion of male to female, but the more important one, I think, is the number of patients in each with each differential diagnosis. So OHT stands for ocular hypertension. POAG is primary open angle. Secondary glaucomas, combined mechanism, meaning they have one or the other, and then low tension as well. So let's look at the data on the primary endpoints. It's going to be not exciting. I'm going to tell you guys that off the bat. So as we can see in the charts, so it's going to be ECP, Streamline, and Streamline plus ECP. It's going to be, we did on this with pre-op, 1 month, and then 6 months, okay? The only one that has statistically significant drop in IOP ended up being just ECP alone, okay? But the interesting thing, in my opinion, is going to be the number of medication drops, because this is what patients care more about, right? So you can see we had a statistically significant drop in the streamline and then also the streamline plus ECP. On average, those patients were able to get off of one medication, whereas patients, even though they had a reduction in IOP with the ECP, they weren't able to get off of a medication. So secondary endpoints, this is going to be really not exciting. We did improve their vision after doing cataract surgery on them, which should surprise nobody. But only in the two groups. The third group with the ECP and streamline, we did not improve it. The proportion of patients having a greater than 20% decrease in IOP, with ECP, it was only 52%. With the streamline is 10%. I'm going to explain again at the end why that's an important number. And then streamline plus ECP was only 38%, got a greater than 20% reduction, okay? So patients able to decrease at least one medication, 27% of them in the ECP, half of them in the streamline, and then 62% in the streamline and ECP, okay? Surgical complications ended up being similar. Each group had one hyphema, one had recurrent iritis from it, which is very typical in patients that have had ECP done. But the rest of it, a couple low pressures in each one, but nothing statistically significant and nothing that stayed around after 6 months. So the discussion, I brought up twice why that greater than 20% IOP reduction is important. Well, the reason being, and for, I guess, this will be a training session for our poor medical student here that has to listen to this. In glaucoma-specific studies, the way they try to juice their studies is they will do a medication washout, okay? So obviously, patients' pressure in that 30-day washout is going to increase, right? That would be like taking somebody off their blood pressure medications for 30 days and then oh my God, I can't believe it went up, right? And then, so what they do is they say, all right, this is our preoperative IOP. They do the cataract surgery, which is already shown by itself, if you just do it by itself, to lower pressure 20% in 80% of patients already, just doing cataract surgery. And they're like, we did a glaucoma surgery on top of it, and look at how many people went below 20%. And they're like, we created a miracle. This is a numerical drug. So that's the way they juice these. So that's why I wanted to look at this, because I thought, frankly, since we're all here, it was bullshit. So in their studies and two other ones that they did the same damn thing where they washed the patients out of their medications, right? They showed that greater than 80% of patients. So they're like, of course, it's a miracle. Streamlined surgical system's the best thing that's ever occurred, right? And they showed at around 50%. So in our study, remember, it was only 10% of patients we showed actually had a 20% because we did not wash them out of their medications, okay? So we were practicing as if anybody in real ophthalmology is actually going to be practicing, right? So it makes sense why ours is lower, right? We ended up with about the similar as for medications that they were able to get off of. So the cool thing with this, if you do a streamline on these patients, on average, you can get them off of one medication, which is, at the end of the day, really what's the most important thing to the patient is not having to put drops or not having to put as many drops in their eyes, right? So strengths of this study, we did include all types of glaucoma, similar patient age, and similar pre-op mean IOPs. Weaknesses of this, so we're going to lack intergroup matching, and if you don't know what that means you're going to be looking at mild POAG in each of the three groups and matching those together, right? Secondary and then matching those together. We didn't have quite enough to do that. That'll be the next part of this before we actually do the paper. We had a small group size with the streamline only, so these were fellowship trained glaucoma people, so most of the patients they're getting are going to be worse than what the comprehensive ophthalmologist would do. So comprehensive people would do more of this streamline anyways. And then, of course, a short follow-up period, what matters. So we know in cataract surgery, the effects of the 20% reduction just with cataract surgery itself typically lasts about 18 months, and then their pressures start to go high. So really, if you wanted to look at a good one of these devices, you would look at 2 years and then visual fields. So anyway, that's my talk. Here's my sources. You guys just want to hang out and chat? Meow. Here we are. Thanks, guys. Thanks, guys. Hopefully you like glaucoma. Anybody have any questions?
What were their procedures for taking the drop off? Were they taking it off right after surgery, or were they waiting until a specific visit?
Yeah. That's a great question. So it went basically based off of what their post-op IOP. So let's say the patient came in next day, pressure's like 10, right? They're stopping all their glaucoma medications. We'll see them at like, the 1 month or something. If the pressure's back up, we'll add it on again. So that was the nice thing with Streamline and stuff. I didn't include this in the data. Nobody actually got put back on to a drop, which was important, right? So one of the things, if you ever end up doing ECP, or if you do ECP, right? One of the big problems with it is it causes a ton of inflammation, right? So ECP, a good study really needs to be after 6 months. I have another study I did last year on this that actually looked at 6 years worth of data on it, and it showed that 72% of patients will have at least a 20% reduction and lose at least one glaucoma medication. But the problem with the studies like this, because they get more inflammation, you have to extend when you can drop the medications, because the inflammation is obviously going to cause a rise in pressure. Sorry, probably a long answer to. All right. Okay. Audrey, come enlighten us. Thanks, Ben, for being here, man.
Okay, testing. Okay. Hi guys, I'm Audrey. I'm a third-year medical student at West Virginia School of Osteopathic Medicine. I'm really happy to be here and present a cost-effective surgical approach for pharyngeal excision. So a little bit of background, pharyngeum is the abnormal growth of the conjunctival tissue onto the cornea. As you can see on the picture on the right, it displays a triangular shaped fibrovascular tissue. The primary risk factor is prolonged UV radiation. Am I making that noise? Okay, how am I doing that? Oh, okay. Okay, thanks. Okay, so the primary risk factor is prolonged UV radiation, and so it typically affects those that live near the equator, such as Ecuador, Brazil, and Mexico. There are mild cases, but surgery is typically indicated when it begins to impair a patient's daily life and if there's any cosmetic concerns. So typically with surgery, you usually typically use a surgical blade to get rid of the pharyngeum due to its precision effects. And after that, there are many options on how you manage the defect. I have all the options listed here, but the one in bold is typically what is done, which is a conjunctival or amniotic membrane graft given its low reoccurrence rates. There are many methods on connecting the autograft to the host site to make sure it doesn't leave the eye, and traditionally people use sutures and fibrin glue, but newer methods have been using the patient's own blood. And the idea is that sutures and fibrin glue are technically foreign bodies, so we kind of want to minimize the post-operative upregulated inflammation reaction and minimizing future surgical procedures. Again, like I said, reoccurrence rates can vary, but majority occur between the first and third month. So in our case, we had a 48-year-old female who presents with persistent blurry vision that's been worsening over a couple of years. She's an immigrant from Mexico who works as a hotel cleaner and is accompanied by her son due to a language barrier. When you do her physical exam, you see a progressive nasal pharyngeum approaching the central visual axis. Her visual acuity is 20/200 versus perfect vision in her left eye 20/20. After talking the risks, benefits, outcomes with the patient and her son, the patient consents to surgery, but the caveat is that she's unable to afford medical insurance, and so she's paying this entire procedure out of her own pocket. So come surgery day, the things that are in bold are what's different. So the ophthalmologist, instead of using a blade, he uses Westcott scissors and 0.12 forceps in order to remove the pharyngeum body. By using the scissors, he's pretty much cutting out the blood supply, and he's waiting about 10 to 15 minutes, waiting for the blood supply to be fully dead. At the same time, he's doing the typical marking, measuring, outlining the autograft that he's going to use to place on top of the defect. After about 10 to 15 minutes, he takes the forceps and uses it to peel away the pterygium. And I'm sorry I don't have a video, but it did very smoothly take out the pterygium. And so after that, he used the graft and secured the graft with some pressure using round tip swabs. So I'm sure you're all wondering how the patient's doing post-op, and she's doing very well. On day 3, she just complains of mild itchiness, but overall the visual acuity improved from 20/200 to 20/60, and her extraocular movements, including the medial rectus muscle, are intact. Post-op 2 weeks, she continues to do well. It does seem to be that the graft is lost, and that's most likely during the immediate post-operative period. On the figure here, you see also the conjunctival tissue has not fully grown over the tinea capsule. Post-op 3 months, still doing well. Central cornea is clear with some reduced redness, and her visual acuity improves even more from 20/60 to 20/50. And the latest update that I have for you guys is about 2 weeks ago. This is her picture of her eye right here. It's probably not the best photo, I'm so sorry about that. But she's doing very well, and she has no reoccurrence, and her vision is stable at 20/50. So I want to talk about this surgery approach because the whole idea was that it was done given her socioeconomic status. Traditionally, a blade is used for position, but some dangers can arise when you use it improperly, such as scleral or corneal thinning. You could also use fibrin glue to make sure that the autograft is there. But people without health insurance, they might find this very costly because it costs about $600 to $700. The graft loss seen 2 days ago that I mentioned is most likely due to the absence of the fibrin glue, but there are studies been done comparing the fibrin glue sutures and using the own patient's blood, and they found a non-significant higher rates of graft loss, while also all showing the same amount of reoccurrence rates, which are low. So the last remarks I have is that I think that this approach could be an advantage for those who may have financial constraints. And because it's minimally invasive, it's highly cost effective, and it's relatively quick. We only allocated 30 minutes because I'm sure if you added time onto the surgery, that would only increase the patient cost. And while I was writing this report, I was thinking about how global mission trips. I spoke to an ophthalmologist at Loyola University who does pterygiums and cataracts, and I asked for this traditional protocol, which are sutures and fibrin glue, and I brought up this idea to him, and I've been talking to him, but I'm still waiting for his response after that. But I wanted to bring this up because a lot of people over there, the ones who have pterygium tend to be near the equator, which unfortunately tends to have limited healthcare access. So this approach could be used. And also going back to the surgical procedure, when you're waiting for 10 to 15 minutes, cataracts are very, very common. It's probably the most common procedure that ophthalmologists do. And so when you're waiting 10 to 15 minutes, you could also do the cataracts. I mean, there also are some things you have to consider, like depending on how large a pterygium is, that might affect measurements of the IOL and whatnot. But I think that if it's a small pterygium and they have cataract surgery, that would be a cost-effective and minimally invasive and time-effective procedure for surgeons and for the patient. And these are my references.
Can you go back to the surgery?
Yeah.
I just want his technique. So you did not use fibrin glue for this?
He did not.
Did you do this in office then?
Outpatient. Mm-hmm. Yeah, so he...
And you had brought, you had brought up a study that showed that not using fibrin glue was non-inferior?
Yes. Right here, oh, the last bullet point? Yeah, because I wanted to address the graft loss and how the reoccurrence is still low. And about 2 weeks ago from then to surgery, that was about 7 months ago. So almost a year. It was just using the patient's own blood and using, tip swabs to add pressure, and then it just stayed. But obviously the graft was lost, so.
So was the non-use of viral glue just like save money on paper?
Exactly, yeah.
I just want to make sure that wasn't the.
Exactly. I think for like global mission trips, if you have the money to do that, maybe considering fibrin glue is probably the best thing. But in terms of people who can't afford medical insurance, I think this might be something that might be good. Yeah. Huh? Sorry. Yeah, kind of like not introducing a foreign body and stuff like that. We kind of wanted to minimize ever needing for her to have another surgery. So by using her own blood, I feel like that risk is lower because of that. And she's doing well, so yeah. Any other questions? Okay, thank you.
This is on.
Actually, the next speaker, who's starting at 7, he's the editor-in-chief of a journal of ophthalmology or translational ophthalmology or something. And I was talking to him, and he said he'd be interested in publishing case reports.
Okay.
Yeah, just happened to be talking to him last time. So one of the things that you guys could probably come up with some papers or something in the journal.
Yeah, thank you.
Where did the past president play? Well, we don't wait for him.
Oh, there we go.
What is that, yogurt? Oh, cereal. No, it's still got 30 seconds. Do you have the clipper? You know how to use it?
Yeah, he taught me. Yeah.
Second, third, and resident. Okay, thank you. All right. My watch says 6.
Good morning. I'm Rachel Daly. I'm a second-year medical student at VCOM Carolinas. Today, I'll be presenting in orbital fat prolapse, the surgery and histopathology. Before starting this presentation, I'd like to thank Dr. Scorin for his mentorship and for the opportunity to present this today. And I have no financial disclosures. So our patient, a 79-year-old male, presented to the ophthalmology clinic with a protrusion of orbital fat coming from the supratemporal region of his left eye. The patient was using artificial tears due to chronic epiphora, but he still was having irritation due to prolapsed orbital fat. So this patient failed conservative therapy and is now going to be getting surgery due to the irritation that the fat is causing him. On physical exam, his best corrected visual acuity and intraocular pressure were normal in both eyes, and there was no restriction and full excursion in extraocular motility bilaterally. So here's our patient. So here you can see this yellow-white mass protruding from the supratemporal quadrant of our patient's left eye. On physical exam, the mass was mobile to palpation and was non-tender, indicating that this was likely a benign lesion. So here we have the cone behind the eye. You can see the intraorbital fat, which is going to be within the cone. And then you have the extraconal fat, which is going to be exterior to the extraocular eye muscles. Separating the two layers is Tenon's capsule, which is a thin membrane extending from the optic nerve to the corneal limbus. Any sort of weakness to Tenon's capsule due to aging or due to spontaneous rupture or previous trauma can lead to this intraconal fat prolapsing through the orbit, leading to herniation and an orbital fat prolapse. These commonly present as an irritation or protrusion to the eye, and they can also present with a cosmetically displeasing lesion to the patient and pose a concern for malignancy. So our patient elected to have surgery due to the irritation that the mass was causing him. So here, a transconjunctival incision was made, and here you see the hand-over-hand surgical technique being used to adjust and reapproximate the fat that was herniated until a tension was felt. And then an excision was made, and cautery was used to control the bleeding. And once the bleeding was stopped, Tenon's capsule as well as the conjunctiva were reapproximated with a fibrin glue. Histopathology confirms a benign lesion of the orbit. Here on 40 times H&E, you see mature adipocytes. So these are all your mature adipocytes in this delicate fibrovascular septate, which you see here. Scattered throughout the biopsy is also an abundance of inflammatory cells such as plasma cells and lymphocytes indicating some inflammation, as well as Lockhern cells and multinucleated floret-like giant cells. So here's a multinucleated floret-like giant cell which exhibits this petal-like appearance. Closer look shows that the nuclei are normochromic and they make this petal-like floret-like shape. Here you see a Lockhern cell, which is going to be an intranuclear vacuole. These indicate that we're looking at adipose tissue. Both of these stain positive for CD34 on immunohistochemistry, though it's not necessary for diagnosis. So among the differential for a prolapsed intraorbital fat mass is the list you see here. On the next few slides, I'm going to touch on the conjunctival lymphoma as well as pleomorphic lipoma. So here's one of Dr. Scorn's patients with a conjunctival lymphoma. Here you see a salmon pink mass protruding from the superior quadrant of this patient's eye. The major difference is going to be the color as well as the fact that on physical exam, these are going to be more tender to palpation and a firm mass that's typically immobile. On histopathology, we see an abundance of these small round blue cells, which are going to be your lymphocytes. This stains positive for CD20, BCL2, and BCL6, confirming the diagnosis of a conjunctival lymphoma. Here is the histology of a pleomorphic lipoma. This histology mimics the protruded intraorbital fat mass due to the multinucleated floret-like giant cells, which also stain positive for CD34, as do the adipocytes and the Lockhern cells in the prolapsed orbital fat. However, your major difference is going to be this ropey collagen and this myxoid appearance opposed to the orbital fat with the abundance of adipocytes. So here's our patient 1 month post-op. The patient was very happy with his surgery and the result of the surgery. He no longer has any of that irritation and is doing well. Here are my references, and thank you for listening to my presentation. I can take any questions.
Okay. All right. Hello and good morning. Like Dr. Scorn said, my name is, can you guys hear me okay? Is that loud? Yes. My name is Jared Banks. I'm from Lincoln Memorial University, and Dr. Scorn was kind enough to help me out with this presentation. And what this presentation is, it's a case study with a patient with some interesting findings that we'll talk about together. My hope is that I can give you some subtle hints at the very beginning so you guys can think about what this patient may have, and then I'll reveal it, of course, and then we'll look at their findings and talk about their outcome. and I have no financial disclosures. Okay, so the title of our presentation is A Toast, Here's Blood in Your Eye. And it's a play on words for saying a toast, here's mud in your eye. So where does that come from? So in the Bible, there's a story of Jesus spitting into the dirt, rubbing it into mud, and then putting it on a blind man's eye. In World War I, this is something that soldiers would say as they're running out into the front lines, here's mud in your eye. It comes from when they're running out and the bombs are exploding around them and the mud's getting in their faces. And also interesting, in horse racing, when the winning horse would cross the finish line and win, they would kick mud behind them with their hooves into the horse's or maybe the jockey's eyes. Okay, so the case report. This person presented, they were a 43-year-old Caucasian female complaining of bloody tears in the right eye for the last 4 days. She noticed it after she started laughing hysterically, and now it occurs after she lies down or when she coughs. There's no pain and no trauma, but she does describe an occasional mild foreign body sensation. Some history for you. She has an autosomal dominant disease with incomplete penetrance. She's had chronic epistasis since her early 30s. She has, on imaging, liver arteriovenous malformations. I'll refer to those as AVMs. Maroon and tarry stools. She takes an iron supplement for her anemia. She has a father and 2 sisters with the same disease, and only 1 of her 4 children is symptomatic. So these are some common causes of bloody tears. Now, she does have one of these in this list. The biggest hints I can give for what she may have is the genetic component of her father and 2 sisters and 1 child, as well as the chronic epistasis. So I'll give you a second to look at that.
In other words, you want us to guess?
Yeah.
Any guesses? See, this is where you turn it around.
Yeah. What I learned is choose the longest answer if you don't know.
That's a really good one. Okay. Okay. Wow. All right. You have very good test taking skills because that is the answer. Yeah. It's yes. Good job. So yeah, this person has hereditary hemorrhagic telangiectasia, HHT. Sometimes it's known as Osler-Weber-Rendu syndrome. And it is, in fact, an autosomal dominant disease with incomplete penetrance. And what this means, her father and 2 of her sisters had it, and then obviously her and only 1 of her children. So all of them have the genotype for it, but with incomplete penetrance, not all of them express it. So not all of them have the phenotype. 1 in 5,000 to 8,000 people have it. Very commonly, you'll see the telangiectasias and the AVMs. But it can affect any organ or any organ system, most commonly the mucosa in the skin. There we are. So this is actually a picture of the patient. We can see these telangiectasias right here and right here, these big dark red spots, if you will. And then up here as well, these smaller red spots. What these are, sometimes people talk to them, or they call them, these spider veins. They're these dilated blood vessels that happen because of this disease, and you can see it, through the skin. Here's another picture of the patient. You can see it on the tip of her tongue, all these dark red spots right there. That's all those telangiectasias. You can see as well as in conjunctiva. Hopefully you can see it. There's a raised one right there and a raised one right there, as well as right here. So on ocular exam, this is a representation of what the patient may have looked like. This is not actually a picture of the patient. But ocular exam, ODOS 2025, bilaterally. Multiple conjunctivas, telangiectasias, as we saw. With physical exam, the lacrimal sac was normal with no discharge or palpation. When she came in, they tried to reproduce this hemolacria by having her cough and having her laugh. And when she started coughing, she would bleed from the nose, and then a couple seconds later start to have those bloody tears, the hemolacria. So she was diagnosed with retrograde flow from epistasis through the cannulicular system. And we'll take a look at how that may have happened. So here we see a Netter's drawing. As I mentioned, she coughed, and the blood vessels started to burst from the increased pressure. And so, she had the bloody nose. And after a moment, the blood would rise into the nasolacrimal sac, duct, into the lacrimal sac, and then out the cannuliculi. So this is the proposed mechanism of how that may have happened. This is our dilated fundus exam, and all we're trying to show here is that there's no retinal telangiectasias or AVMs. There is a little bit of an increased retinal vein tortuosity right there, right there. So the genetics are really interesting. It can be a bit complex, however. So I think it suffices to say with HHT, you get these genetic mutations that affect structural proteins that cause these small blood vessels to become very fragile. They dilate and they're very fragile. That's why when you would cough or laugh or lay down, they would burst. And also, down here you can see mutations in the BMP and TGF-beta pathway. This affects the angiogenesis, so with that disrupted, the AVMs will form, the arterial and venous systems will come together where they should not, and it can cause bleeding and even fatal emboli. Clinical features you'll commonly see, symptoms begin in childhood, recurrent epistasis as we saw she had, easily blanched telangiectasias, AVMs in multiple organs as you see, risk of AVM exandrination, and high risk for anemia, which she did have. Ocular features, we saw before, the conjunctival telangiectasias and the hemolacria. She did not have these other ones, but these are possible ocular features that can be seen. So the guidelines for treatment, these are specifically for the epistasis. It's a stepwise approach, and it begins with a topical therapy of oral tranexamic acid, which is an antifibrinolytic. Ablative therapies can be done. You can give an antiogenic therapy for those AVMs. You can give bevacizumab. Other surgical procedures can be done. But most commonly done, not in these guidelines, is giving tamoxifen, which is an antiestrogenic that helps to lower anticoagulant proteins. That's the most common one. Treatment for other organ systems. This patient only wanted treatment for her epistasis non-surgically, so they tried humidification. She was continuing on her iron supplementation, but in these other organ systems, very commonly you'll try to get rid of the embolization, and if you can do a transplant of that organ. This is a self-help website, the HHT Foundation, and very interesting, it says that 90% of people who have HHT are undiagnosed. So maybe they do not express the phenotype, or maybe they just have epistasis chronically and just deal with it. Oops. Those are my references. Any questions? Thank you.
Yeah, of course. My name is Jacob Brucker. I'm a PGY2 resident at Kettering Health in Dayton, Ohio, and my presentation is more of a literature review. It was inspired by a conversation I had with one of my retina attendings on a topic I didn't know too much about. And so we'll start with a brief case presentation and then kind of go into more of the pathophysiology and management. So a 44-year-old female came in. She was a known myope. She presented to clinic with symptoms of inferior visual field defect. She was found to have a rhegmatogenous retinal detachment involving the superior macula. 2 days later, she underwent pars plana vitrectomy with gas tamponade. The acute post-operative course was unremarkable and stable visual acuity. However, at about a month and a half later, she returned to clinic with similar symptoms as when she presented with this inferior visual field defect. And unfortunately, I couldn't get her fundus photo, but this is one I found that was very similar. So we're looking at the superior macula around the distal superior arcade. And as you can see, there's some whitening of the retina with some membranes and this kind of star-looking formation. And so what we're talking about today is PVR, or proliferative vitreoretinopathy. PVR is one of the major complications of rhegmatogenous retinal detachment, and it is the most common cause of rhegmatogenous retinal detachment repair failure. It was formerly known as massive vitreous retraction and massive periretinal proliferation. And on the bottom here is a wide field photo showing fixed folds in the retina. Kind of where I'm looking is right down here and kind of all around. This is a pretty severe case.
Is that your case?
This is not, no. But the biggest thing, and we're going to go over this, are fixed folds. Fixed folds is kind of the buzzword for PVR. What PVR is it's growth and contraction of cellular membranes within the vitreous and also all layers of the retina, including the epiretinal surface, the intraretinal surface, and the subretinal surface. The contraction of these membranes can cause the retina to redetach and even transform from an RRD into a tractional detachment. And fibrosis of the intraretinal layer can make it difficult for the retina to flatten after surgery. It typically occurs in about 5 to 10% of RRDs, and it most commonly presents about a month to about a month and a half after detachment surgery occurs. The risk factors are almost all related to a break in the blood-ocular barrier, and these include chronic RRDs lasting more than several months, choroidal detachments, and excessive endolaser. The only modifiable risk factor for PVR the patient can control is cigarette smoking. How this occurs, it's thought to be due to an abnormal wound healing process. Ischemia and cell death after a detachment triggers a break in the blood-ocular barrier, and this facilitates influx of growth factors, inflammatory mediators into the vitreous and the layers of the retina. And what these growth factors and mediators do is allow cell proliferation and extracellular matrix deposition. Another interesting thing with PVR, the RPE cells actually undergo an epithelial mesenchymal transformation. So they more act as connective tissue rather than epithelium. These contractile membranes contain fibroblast-like cells and even have actin and myosin, so they have the ability to contract within the retina. And the intraretinal stiffening also occurs from gliosis. So here is a figure that really displays how the process is all kind of self-perpetuating. If we start here in A, this is where the initial retinal detachment occurred, where there is a break in the blood-retinal barrier and leads to cytokines, those inflammatory mediators. From the break in the blood-retinal barrier, we get the changes in the RPE cells when they change to more connective tissue-like. And then we go to membrane formation, and the membrane formation can turn into contraction of the membranes, which can further potentiate retinal detachments by changing an RRD into tractional detachment. So the whole process of a PVR is self-perpetuating, meaning it kind of makes itself worse and worse and worse over time. Diagnosis is typically made through an in-depth history and also physical exam. The things you really want to look for on history are how long the symptoms lasted to indicate if it's a chronic RRD and if they've had prior surgical repair. And like I said before, the most important thing to recognize with PVR is fixed folds. That's the buzzword. There is kind of a complex classification system of PVR, and different sources had different classification systems. But the most commonly used one, we identify a type. We identify a type, and then there's also a letter that goes along with it. So there's a type, a location if it's posterior or anterior to the equator, and then certain features. But I thought that was a little too complex, so I'm not deep diving too much into the classification system. But I did show a couple pictures to kind of see what we are dealing with. And if this is a color fundus photo, if we look on the bottom right hand, more of the temporal macula, as denoted by the S, this is what they call a star fold. And this is a fold in the retina from contracted epiretinal membranes. And if you could imagine, it kind of looks like a star. And then if we turn our attention to D here, this shows diffuse posterior contraction. And if you see the membranes radialing out, this is actually called clotheslining, right around here. Another photo, this is called a napkin ring. This is when there's subretinal membrane located adjacent to the optic nerve, and this holds and confines the retina in a funnel shape. A way to distinguish between a primary retinal detachment and PVR, the symptoms are very similar. They get the flashes, the floaters, the painless visual field defects, but the exam is where you can really tell the differences. In primary RRD, you're going to have this bouncing movement of the retina when you're doing your 90 exam, and this is from the subretinal fluid. And you could imagine as they move their eye around, you can kind of see the retina bouncing. There's no fibrosis there. Whereas with PVR, you're going to have fixed folds, so when the patient moves their eye, you're not going to get that same bouncing motion. We typically diagnose this through our slit lamp exam with a 90 or a 20. If there is opaque ocular media, you can use ultrasound. And they talked about dynamic ultrasound is where when you have the probe against the eye and you ask them to move in different directions while you're focusing on the posterior.
I've actually had a couple of cases like that where we couldn't see the back and used dynamic ultrasound, and it's very dramatic.
Sure.
So that works well.
Okay. And ways to kind of tell it through ultrasound, whether it's a detachment or PVR, you're going to have less mobility with PVR due to those contracted membranes, and you're going to have a V pattern near the optic disc, where the retina is more of V-shaped due to the contracting membranes. If there is a detachment, you're going to get more of a U pattern, since there's no tightening of the retina. How we manage this, the biggest thing is to facilitate flattening of the retina, and it's primarily managed through pars plana vitrectomy and membrane peeling. If there's no scleral buccal present, there's usually a placement of encircling scleral buccal. After the membranes are removed, typically what I read is you start most posterior near the macula and then work your way anterior. And as you correct the most posterior segment, you place more of a heavy liquid, and this is the perfluorocarbon liquid, which is heavier than water or saline, and it can stabilize the posterior aspect of the retina as you correct more anterior locations that are involved. As a last resort, there is something you can do called a relaxing retinectomy to help relieve traction. This is where you make a circumferential cut in the peripheral retina and excise devitalized retina anterior to it. After there is reattachment, you remove the perfluorocarbon liquid and replace it with either long-acting gas or silicone oil. The prognosis is not too good. Only about 39% of eyes affected by PVR remain attached long-term. And in that specific study, they defined long-term as greater than 30 months. And visual acuity is also a poor prognosis, with around 40 to 80% of people maintaining 2200 or better. Why there's such poor prognosis? We think it's due to changes in the macula. And after surgery, we tend to see people develop macular pucker or CME or subretinal fibrosis. And that is my presentation. Any questions I can answer?
It's bad, don't get it. Don't get it. This is not what I'm not a retina doctor. We really well off retinal attachments, but this is one that's a real bummer when we show up usually a few months later. But there's another circumstance that I see that we also PVR, and it's also common. What's another time you see PVR? This is not a new one. Here it says it.
On
I mean, like, I think in proliferative diabetic retinopathy, sometimes I see it even after a Avastin or something, what they'll get is they'll get PVR and contraction, and all just get like a tractional RD, and a lot of times our retina doctors will talk about PVP and sort of PVR in the same way. And sometimes a lot of doing that really difficult tractional RD case from PVR regress or from those changes from proliferative diabetic retinopathy.
Thank you.
And our very last presenter is Anna Egley. Did I get that right? And you're going to thrill us with some cool imaging, right?
Yeah, ocular photography. Thank you. You need my flash drive? There we go.
So there's a break, right? So like a tractional RD, there's a break. Something like PPR is causing, and PPR actually causes the retina to detach, but there's no break. That's the difference of, you can get RD from this traction. There's no break to fix it. You have to fix it like you fix it.
Good morning. My name is Anna. I'm a third-year medical student at LeComm Bradenton, and today I'm going to talk a little bit about a guide to anterior segment photography. So here's a little overview on ocular photography. It's especially important in practice for documenting different eye conditions such as cataract progression, uveitis, melanoma, retinal detachment, which would be fundus photography, diabetic retinopathy, again, fundus photography, macular degeneration, and more. It's also especially important for education, research and publications, telemedicine, legal documentation, and marketing. So it's definitely a developing field, so it's important that residents and physicians are well educated on how to do proper ocular photography, whether it's anterior segment, fundus photography, et cetera. So I'm going to talk a little bit about that today. Okay, so a little overview of some of the most important types of ocular photography. So what I'm going to talk about today mostly is anterior segment or slit lamp photography, and that's going to be the anterior portion of the eye, which is the conjunctiva, cornea, sclera, iris, and lens. Also important here is gonioscopy, which is visualizing and photographing the drainage angle of the eye. And then obviously fundus photography, which is very commonly used in practice and can also include angiography to visualize different diseases of the posterior segment. And these are all from the Ophthalmic Photographers Society, so none of these images are mine. Okay, so here are some examples of different fundus photography devices. I don't know if any of the physicians in the room can speak on, do y'all have any of these devices or anything of the like? What do you use to photograph your fundus photography? An IDEN, okay. Interesting. A Zeiss, okay. Yeah, so here are some examples, and there are handheld devices now for fundus photography, which is quite interesting. I'm not sure how accurate they are, but it's definitely a developing field. So we're advancing from these very large machines into more handheld devices. But mostly what I want to talk about today is anterior segment photography. It's something that I've had an interest in, actually, since I was in high school. It was kind of trendy on Tumblr back in the day to take pictures of your eyes, and kind of from there, I just advanced into really loving the eye, and now that I'm becoming a physician, I realized that I could merge the two loves. So here are two examples of devices that you can use to attach either your iPhone or a DSLR to your slit lamp. And here is from an article that is a smartphone image from a slit lamp and a DSLR. So kind of seeing the difference. Obviously, still the DSLR is superior to most iPhone photography, but as we know, iPhones are quickly, gaining better technology and are taking better photos. So here's another example of some images taken during, oops, go back. There we go. Okay, some images taken on the slit lamp. This is done with a DSLR. And so here we have an iris melanoma, and we had a iridectomy done, and same with down here. So they can be really good for monitoring treatments over time and photographing and charting and documenting, especially for malpractice purposes as well. Okay, so now we're going more into how to take anterior segment photography. I'm gearing more towards a on-the-go type setup, so not everyone has access to a slit lamp, whether it's in the ER or if you're a student and you want to document something maybe for research papers and you don't have access to a slit lamp or the technology to take photos on the slit lamp. So the first thing you're going to want to do is create a well-lit environment, and you can either do this with a natural light like a window, or you could use a flashlight. For example, I have here, just something simple like this that you can use to illuminate the eye. The important thing is that you don't want to directly put the light source into the patient's retina because you don't want to cause any damage. And between photograph series, you're going to want to take breaks for the patient, turn off the light source, and let them relax. And you want to make sure that you and the patient are in a comfortable position in order to take good photos and not have any motion blur. Also, you can utilize a tripod, or even as a photographer, set your elbows up on a table and have the patient rest their chin on a table or even on the slit lamp straps, and that can help demobilize the patient and you to minimize motion blur as well. And this is a picture of me. This is me at 16 years old taking pictures of my friend Tyler's eyes because he had these big eyeballs, so I love taking pictures of his eyes. Okay, so I'm assuming most of us in the room have an iPhone or a Samsung device, something of the sort. So although maybe not everyone has a DSLR, a lot of us do have access to wonderful camera systems on our phones. And a lot of the new iPhones, such as the iPhone Pros and Maxes, have built-in macro capabilities. But if your phone doesn't, or you want a more advanced image, you can also purchase a lot of attachments online. So here, for example, is the Sandmark macro lens for the iPhone. It's around $115, and we even have cheaper options. This is from Amazon. This is the one I actually have. It's a pixel macro lens, and this runs about $39. And I have links to all of these. No financial disclosures, though. Okay, so here are some examples of photos that I took using these lenses. So that's with this lens here that I was talking about from Amazon. So as you can see, you can get some pretty high quality up-close images. These are both, well, in all of my photography is going to be of healthy eyes, so I don't really have a lot of pathology, but obviously it can be utilized for that as well. And then here are some other examples. These I took when I was 16. These photos, I think all three actually, are actually taken with an Olo clip, which is another attachment for the iPhone. However, they went under during COVID, so they are no longer in business, and you can no longer buy their attachments, which is kind of unfortunate. But they also allowed you to get a really good picture. And again, this is really beneficial for students who want to document for research, or if you're in the ER, something on the go. Or even just, for artistic endeavors. Say you have a spouse and you want a picture of their eye on your wall, that's awesome. All right, so here's another example. This is with the Apixel lens. Okay, and now I'm going to move on and talk a little bit about anterior segment photography with a DSLR. So DSLRs obviously can run a little bit more expensive than a lot of iPhones that we already have, and a lot of the attachments for iPhones. But there is still ways to do this affordably. Really, any DSLR camera works, whether it's a Nikon, Canon, Sony, and there are a lot of different lenses that you can purchase with a lot of different price ranges. So what I use is the Venus Optics Loyola 25 millimeters, 2.5 to 5 times ultra macro. So that's this here. And this was around $300, but it actually works quite well, and that's a pretty affordable price for a lens. And then I use a Canon 90D. Other ones are the Canon EF 100 millimeters macro lens, and that one is usually around $1,000. The most important thing is to have correct camera settings. So here are some examples of the settings that I use. I won't bore you with them. But the important thing is to take multiple practice shots and adjust as you go along. And once you kind of get a feel of what works best for you, then you can really take some great images. Okay, so here's an example I took with my lens. This is actually my own eye. I set it up on a tripod and took some pictures. So as you can see, you can get some really close quality images of the eye and especially the iris. And here are two more examples. This is my friend Tyler, so he's the one that was in the photo earlier. So I took this with a 100 millimeter lens, so a little bit more zoomed out. And then this is with my macro lens. And then here's another photo that I took with my DSLR. This is also with my 100 millimeter lens, my friend Tatum. Okay, and then I was going to present my poster, so here's my poster if anyone's interested, but I thought it would be easier to break it down in PowerPoint presentation. And then here's a link if anyone's interested in the products that I mentioned today, so you can scan the QR code if you're interested in that. And then if you haven't already voted for all the wonderful posters that the students and residents made, please go ahead and go and vote. There's some really awesome ones. So I think it's until May 6th, according to the website, yeah, which is my birthday. It's the only reason I remember it, but yeah, but there's some really awesome student and resident presentations, so please go on there and vote for the ophthalmologists and ENTs that, you know, put some hard work in there. And let me know if it doesn't work. I can also try and zoom in. And that's my presentation. I have references after this. Yeah. With what? Yes. Yeah, no, iPads are not going to take quality images. Yeah, well, the good thing is where did I put it? This attachment, it easily fits in your pocket, your white coat pocket. So, and you literally just slide it on your iPhone, and then it takes really, that was, let's go back. Oh. This is the Apixel 100 millimeter. If you look up literally on Amazon, Apixel macro lens, then you'll be able to find it. It's around $30, so it's a great tool. You do have to get pretty close to the patient's eye with this. That's my only qualm with this product. So it's kind of difficult for beginners, but it's definitely worth it, you know, to try it out, you know, if you have a really cool eye in the clinic or something like that. But yeah, that's, this image right here is done with that, and then this image is with the Apixel.
You mean it's called Apexel?
Apexel, yeah. A-P-E, hold on. Oh, it's right here. Apexel. Yeah, so it's fun, and there's a lot of different ones. I recommend if you're trying it for the first time, that you might want something that's a little more zoomed out. Maybe try a couple of different lenses and see what works best for you, but you know, the most important thing is lighting. Yes? Yeah, so usually, yeah, so the most important thing is the external lighting. So I really recommend whether that's a window or using a flashlight and making sure that the image is bright enough. And then I also usually increase the exposure a little bit on my iPhone, but other than that, I really don't do anything. Another recommendation I have is to press and hold to lock the focus, because then it won't autofocus, so then it'll keep the focus that you want of the eye. Yes?
The barrier structure
Mm-hmm.
on the Apexel,
Mm-hmm.
is that made of plastic or is it metal?
Yeah, so it's plastic and metal. So there's like a metal interior to do the sliding so it can adjust to different phones. And then the majority of it is plastic, and then the lens are glass, I'm assuming.
In the area that you fit the phone into,
Mm-hmm.
is that plastic or is that nothing? In other words, is there any resistance? I've had so many of them that I hook up with a silicone with the binocular and they break.
Yeah, yeah. Yeah, I would say that this probably wouldn't be a good product to use with the slit lamp. This is more just on the go, say you're in the ER and don't have access to a slit lamp. But yeah, a lot of the products, you definitely would probably need something very sturdy in order to attach it to a slit lamp. I wouldn't recommend that for this product. Any other questions? All right, awesome. Thank you so much.